Santanu, good evening. Partha, good evening.
Everybody. Warm welcome from the Northeast. And I, on behalf of the Northeast Respiratory Chapter, welcome you all to the first Northeast RESPICON, which is held in collaboration with the Central IIP as well as with the Central or National Respiratory Chapter. Today we have among us our Honorable President Central IIP, Dr. Bakul Parikh sir, Secretary General of Central IIP, Dr. G. Basavaraja sir, President Chairperson of National Respiratory Chapter, Dr. Jagdish Chinappa sir, and Dr. Subramania sir, Secretary, National Respiratory Chapter. We have eminent respirologist, pulmonologist, Professor Barinder Singh sir, will be delivering the first oration in the Northeast RESPICON, as well as we have eminent faculties from Northeast who will be sharing the sessions. I welcome you all to the first Northeast RESPICON. Before I start, I would like to request our Secretary, Dr. Mrityunjay Pao, to give an inaugural speech.
Very warm good evening to all the respected senior faculties from all over India. Good evening to Dr. Bakul Parikh, our President IIP, and Dr. Basavaraja, Secretary General IIP. Dr. Jagdish Chinappa was the President of IIP Respiratory Chapter, the Secretary, Dr. Subramaniam NK sir, Professor, and respected Dr. Indu Khosla from Mumbai. Welcome Dr. Jagdish Chinappa sir, Shyama Sekhya sir from India, from Tezpur. Very good evening to Dr. Professor Barinder Singh, who will be delivering our oration for this year. Namaste sir. I hope you are doing fine. And all the junior faculties from our Northeast chapter. So this is an annual event that we have been holding since the last 4 years, and this is the first time we are holding it online. So at first, I would like to invite the senior faculty and doctors to give us a few thoughts about from them. First of all, I would like to invite Dr. Bakul Parikh sir to give us a address for a few minutes. Dr. Bakul sir.
Thank you, Dr. Mrityunjay. First of all, I like to congratulate IIP National Chapter of Respiratory for starting yet another chapter, that is Northeast State Respiratory Chapter, and yet one more conference, and that is RESPICON at Northeast State. I congratulate Dr. Rajkumar Sayal, Dr. Mrityunjay Pao, and Dr. Partha Bora for taking over as leaders of the Northeast State Respiratory Chapter. And I recognize the presence of great academicians, Dr. Barinder Singh, Dr. Jagdish Chinappa, the President of Chairperson of Respiratory Chapter, and Dr. Subramaniam, the Secretary of Respiratory Chapter, and my dear dynamic Secretary, Dr. G. Basavaraj, who has been always with me all throughout my activities. I recognize the presence of my friend, Dr. Indu Khosla, Dr. Santanu Dev, Dr. Rupam Das, Dr. Anupama, and so many others. So I'm sure the conference today, which begins with a bang, and it will be a very enjoyable science all throughout, with speakers like Dr. Barinder Singh, who is going to give an oration on tuberculosis, and it's always a pleasure to listen to him again and again on the same topic, but we gain to learn new things whenever we hear him anytime. So I'm sure I'm waiting for that particular oration to listen to. And of course, we have Dr. Indu Khosla, Ankit Parak, Dr. Subramaniam, and so many other great speakers all throughout this conference. So let's enjoy the science, and all the best. And I'm sure there will be a great success for this Northeast RESPICON. Thank you.
Yes,
Thank you, Bakul Parikh sir. Now I'd like to request our Secretary General, Central IIP, Dr. G. Basavaraja, to say a few lines.
Thank you, Dr. Partha Bora. First of all, let me congratulate our Northeast branch, Dr. Mrityunjay Pao, Dr. Anupama, Dr. Rupam Das, Dr. Shyam Sekhya, Dr. Rita, and Dr. Santanu. They are very active in their academics from the beginning, with the great support from the IIP Respiratory Chapter, Jagdish Chinappa sir, and Dr. Subramania, Dr. Indu Khosla madam. They are doing a wonderful work. Today we are fortunate, Dr. Professor Barinder Singh, one of the greatest academicians who's done a lot of work in the tuberculosis, as our visionary president, Dr. Parekh sir, has already told. It is always we are attending a sir's tuberculosis NTEP program. Each time we are learning something new. That is something which is really appreciable. And sir is an instrumental in taking tuberculosis NTEP program across the India along with our central IAP. With these few words, I recognize and welcome all the people who are logged in. With these few words, wish you all the best for this program.
Thank you, Dr. G.V. Vajabraja, sir. Now I'd like to invite Dr. Jagdish Sinappa, sir, our eminent leader, our mentor in the National Respiratory Chapter, who has encouraged us. And because of his support and encouragement, I think our respiratory chapter has flourished. And I'd like to hear some words from him. Sir, welcome. Sir, please unmute.
Thank you, Dr. Partha. All the members of the Northeast Respiratory Chapter, members of the Respiratory Chapter from the Northeast, Dr. Bakul Parekh, Dr. Basavraj, and all the members from the central team. It's a great pleasure today to participate in this very prestigious RESPICON of the Northeast with some fantastic faculty led by, of course, our guru, Professor Varinder Singh. Professor Varinder Singh need not, I mean, every bacha knows about Professor Varinder Singh because of his eminence, not only in the respiratory chapter and the infectious disease chapter, but as a human being. I mean, he is one of the most gracious persons I've ever met and one of the most knowledgeable yet humble persons I've ever met. We also have a fantastic faculty led by Dr. Indu Khosla, Dr. Ankit, Dr. Bharat Reddy, and many others who are the leading lights of the respiratory chapter and who are going to take the respiratory chapter to greater heights. Dr. Subramania, I don't need to say anything about because he's been the live wire of the respiratory chapter and he's been motivating every nook and corner of the country to come into the fold of the respiratory chapter. So I think this is a wonderful conference which has been organized by you, and I wish that everybody takes home all the key messages which the faculty are going to give today so that they can be implemented in their day-to-day practice. So with this, I wish all of you all the very best in this particular venture. Thank you.
Thank you. Thank you, sir. And last but not the least, our leader, our energy behind the respiratory chapter, Dr. Subramania, sir. So please say a few lines.
Thank you, dear Partha and Northeast team, which happens to be my heart, and all the authors and makers of cough module from Northeast, and many more who have joined the pulmonology from there. Thank you very much. At the outset, let me first thank the two visionaries in IAP. Both happen to be the classmates, because I thought this is an occasion where I will tell them they are classmates also, Dr. Bakul and Dr. Jagdish. You know, they foresee 10 to 15 years ahead of many of us. You know, that's why they could lay down the path for youngsters like us to work for. And thank you very much, both of you. And we, the followers of IAP, are indebted to you for making us, you know, go in the right path. And I can take the pleasure of, you know, my contemporary by my age, Dr. Basavaraja, who happens to be my dearest friend apart from being secretary. You know, it gives a great occasion to be working with you. Thank you very much. सर जी, मैं क्या बोलूं, मेरे को तो दिल करता है हमेशा गले लगा दे. And whenever we meet in conferences, we used to you know, share a lot of thoughts, and it's always a pleasure to watch. I think Varinder Singh sir, if you remember in Davangere conference, आपने मेरे को तो शेर बनाया. I think I took that time I was very young, you know, having a debate with Balasubramanian, if you recollect, long back. And then, you know, so I think I have taken all your words and blessings and your teachings, and in the respiratory chapter, whatever dreams you had as youngsters, and I'm not telling myself, many of us together have taken the paths led by you, Kabra sir, and many senior teachers. You have taken it forward, and now we will assure you that this respirology is spreading horizontally like anything in the country. I think the spread of pulmonology is exceeding that of corona, I suppose. So therefore, we will see that everybody will become member of the respiratory chapter. And Doctor, I would congratulate and tell you, sir, and Dr. Jagdish Chinappa, that the Partha has made many members from Northeast as respiratory chapter members. So that part of the country is not spared for becoming members. And I will thank Dr. Partha leading by inspiration, and the chapter is expanding, and we are very happy to see many youngsters who are now becoming authors of many modules in the chapter. So to that extent, we are very happy. So with this couple of notes,
The central IP members.
no, they are all central IP members. After that only they'll become Bakul bhai, for filling up of respiratory chapter membership, IAP membership is a compulsory column, without which they won't. And if they want to become chapter, we are also making them members of chapter, central IP also. So I'm also a CIP member and a soldier under you. So luckily in my life, I have been a CIP member along with you and Basavaraja. So thank you very much. This is a great occasion. Today morning, we had a workshop on pneumonia module, and there were more than 200 attendees. And from a region to have 200 plus attendees for a workshop was very heartening. And Kolhapur IAP also, they had a regional conference and they co-joined Northeast, and what a blending from Kolhapur IAP plus Northeast in pulmonology. It takes a great kind of miljul that happened, and it's fantastic occasion and a festive atmosphere. And lastly, I will take this occasion. We will invite all of you to join us in war on pneumonia. We are waging a war, and the leadership will be from Bakul and Jagdish, being that movie by Amitabh Bachchan, Bakul bhai Sholay. To the extent you are taking it forward. So let's win our war against pneumonia. We have series of activities in the week. In the next week, we are having TOT on pneumonia, first of its kind. Please join all of us with these remarks. And as secretary, I will have many things to say, but let me not take much of your time. So wishing this conference all the best, and hope that this continues year by year uninterrupted, and with much more colors and more festive atmosphere being built up in Northeast. Partha, yeah, and many of you, we are Northeast is blessed to have youngsters like you. In fact, he conducted a unique airway workshop, first of its kind in India. And thank you very much for kindling pulmonology in Northeast and even across India. Thank you very much. Thank you for invitation.
Thank you, sir. Now I'd like to request Dr. Santanu Dev, one of our guide, one of our colleague, with whom we dreamt of a Northeast Respiratory chapter. Santanu Dev, please go ahead.
Thank you, Partha. Warm welcome to all the dignitaries, especially Bakul sir, Dr. Vasavraj, Dr. Jagdish Chinnappa, Varinder Singh sir, and Dr. Subramania. Welcome to the Northeast Respicon. And as you all know, Northeast is a area which is very vibrant in culture, tribes, cuisines, folk music, rock music. And I welcome you all virtually to the Northeast today. I would have very much liked that all of you visit physically the Northeast during the Northeast Respicon, but this time it will be virtual, and the warm welcome awaits you whenever you decide to visit physically. Actually, this Northeast Respicon is due to the hard work of Dr. Partha Bora. He deserved a lot more support from me, but this year I was not able to give him so much of support. He was supported locally very ably by Dr. Mrityunjay Pao, and nationally by Subbu sir, by Dr. Subramania. And Partha has developed into a very good leader and an organizer, and we are very proud of him also. And we thank him for bringing this Northeast Respicon to all of us. I again welcome all the seasoned faculty. Lots of excellent faculty will be adorning the screens of all our delegates after some time. And also the young Turks. We have a lot of young faculty from Northeast lined up for today's evening. So I welcome all of you again. Thank you so much, and warm welcome again.
Thank you, Santanuda. And our last speaker, Dr. MP Bajaj sir, who is the Secretary of the Indian Academy of Pediatrics, Guwahati chapter. Sir, please give a welcome note to everyone.
Bajaj sir, unmute.
Unmute, sir.
Bajaj, please unmute.
Yeah.
Okay. Good evening, delegates and participants and the leaders. Low-cost policy is working very well under from the central IIP. Lots of Northeastern activities new now, and with the effort of Dr. Partho, we are seeing this Northeast RESPICON also this time. And I am very happy to see Dr. Varinder Singh, Dr. Vasaraj, Dr. Jagdish Chinappa, Dr. Inusa, Dr. Bharat Reddy. And I will learn a lot. I was just in the morning, I was telling, I don't know anything about the pediatric sleep disorder. And I asked Partho to give me some review article so I can read. Thank you very much for this. And again, warm welcome. Please go on, carry on now. Thank you.
Thank you. Thank you, everyone. We'll have an inaugural. I want to share my screen. This is. This is Dr. Rajkumar Kayal sir, who is our president.
Calls upon us to ensure healthy lives and promote well-being for all at all ages by 2030. To achieve this, we need to focus on universal immunization, promotion of breastfeeding, ensuring clean air and clean fuel, prevention of tobacco exposure, and propagation of rational, evidence-based care. Importance of respiratory hygiene has been highlighted recently in the COVID pandemic. Friends, we need to promote more use of a simple test like otoscopy, more use of diagnostic ultrasound in respiratory conditions, better availability and rational use of microbiological and related investigative support, and we need to promote rational guideline-based care at all levels. We also need to sensitize ourselves and our other colleagues to some uncommon but not rare conditions like sleep disorder breathing, cystic fibrosis, mucociliary disorders, congenital malformations, airway foreign bodies, etc. It is a matter of concern that though there are many cases of cystic fibrosis in Northeast, to my knowledge, none of them has been diagnosed by us here. With these few thoughts, I wish the conference success and wish you all a very pleasant festive season. Thank you.
Thank you, Dr. Rajkumar Kayal sir. Sir, actually, sir is in United States of America now. So since he's not there, he sent a recorded message for everybody. Now we'll start with the inaugural session. We have a dance recital.
I am and today I'll be presenting before you Khatriya, a traditional dance form from the northeast of India.
Is the video visible?
Yes.
15th century.
Yes.
Partha, audio could be better. Can you increase the audio, please?
Yeah.
As part of a new Vaishnava Renaissance movement. Today, I'll be presenting before you Krishna Katha. Krishna Katha shows excerpts from Krishna's life, from killing of the evil king Kansha to killing of Putana, the wet nurse demoness, and lifting of the Govardhan mountain by Lord Krishna.
He
Partha, unmute.
Partha, unmute.
Partha, unmute. Partha, unmute.
Partha, music অহা নাই।
Yes, sir. Yes, sir. Thank you all. Now I'd like to start the session. And today we have the first session by oration on Professor C.S. Das sir, and that will be moderated by our chairpersons, Dr. Anupama madam and Dr. Hunsigiri madam. I'd like to invite Dr. Anupama madam and Dr. Hunsigiri madam, and as well as Professor Varinder Singh sir for the inauguration.
Good evening, everyone. Hello.
Yes, audible. You are audible.
Yes, you're audible.
We can hear you.
Okay.
No?
Good evening,
Dr.
everyone.
Giri.
It's a great honor to have our great academician, Professor Varinder Singh, during the Northeast RESPICON. Professor Varinder Singh will be delivering the Professor Dr. C.S. Das Oration Award. Oration, sir. So, sir needs no introduction, actually. He was with us 1 week ago. He also delivered the oration during the 17th Pedicon. So, sir, actually, he is a European diplomat of pediatric respiratory medicine. He is an honorary fellow of Royal College of Pediatrics and Child Health UK 2012. He a Commonwealth Academic Staff Fellow at Pediatric Respiratory Department at Royal Brompton Hospital, London. Sir is currently the Director Professor of Pediatrics in charge National Center of Excellence in Pediatric Tuberculosis, Lady Hardinge Medical College, and Associate Kalavati Saran Children's Hospital, New Delhi. He has published around 100 publications in the national and international journals. He's an author and editor of several books and sections. And he's a chairperson of the Indian Academy of Pediatrics National Respiratory Chapter, President Assam Asian Pediatric Pulmonary Society. He's a country representative international board for the International Pediatric Pulmonary Congress since 2005. He's a chair National Technical Expert Group for Pediatric Tuberculosis under National Tuberculosis. So Professor Varinder Singh will be delivering the oration and he'll be speaking on MDR-TB, its challenges and solutions. Professor Varinder Singh, I invite you for this. Thank you very much. The time is for you, sir.
Thank you very much, Dr. Giri, for your very kind introduction. I will need permissions from your end to share my screen. So if I can be, this sharing can stop, then only I would be able to share my screen, please. Thank you. So at the outset, I am indeed very thankful to the organizers for having given me this opportunity to be amongst you. Northeast area has always been special for us. I recall during my tenure as the secretary of the IAP respiratory chapter in 2005-6, what we did was that we were launching at that time the ATM. And as India is divided in 5 zones, they had agreed for 5 zonal conference. But I went to the organizer, to the sponsors, telling them that Northeast cannot be clubbed with any other zone because of difficulty of traveling and the way these 7 states are concentrated, yet have a very sparse population of pediatric friends. So we would like to hold that in Shillong. So I remember having conducted that in Nigrin, Shillong, and I have very fond memories of the place and the friends I made at that time. Shantanu Devi is here. He has been a constant support. So thank you very much. Thank you, Dr. Giri, Dr. Pao, Dr. Partha, Dr. Bajaj. I'm sorry if I forget any names from the Northeast, and of course, Dr. Chinnappa and Dr. Subramania for giving me this opportunity. I know all that you told about me actually puts a lot of pressure on me, because speaking on the same topic to a similar audience all the time actually brings a lot of challenge. And sometimes my family member asks me, you're again speaking on TV. Why did you spend 7 hours again preparing your talk? It requires that amount of effort each time to bring it differently. So let me hope that you will get something new today. What is it about MDR-TB which is so important for us to know? If we go and see, we really need to know where we started with DRTB. What were our concept? Why did we need a change? Whether it was to prevent DRTB or prevent augmentation of DRTB by optimizing the regimen, keeping background resistance in mind. And I will elaborate on each of these points. And the change, which once I have explained the need, what is the change which has come? How it affects us, whether it's the diagnostic or the therapeutic regimens for MDR-TB. And I will try to illustrate that with a couple of cases, given the short time I have. So often, when you know want to know where we are headed. We often require to know where we have come from. So there would be some degree of going back to our established practice, because that's important. The new learning sometimes require a process of de-learning of what we know or we do. And DRTB is one such situation where some things have undergone drastic change. If we look at the countrywide scenario, then what we see is that there are about 77% of the new cases are drug sensitive. All cases, new and old numbers are much lesser, are about 72%. If you look at any drug resistance, it's about 22%. 1 in 5 has some drug resistance. It's not MDR. MDR is only about 3%. 95% interval of 2 to 3.5. If you look at all cases, which is new as well as old treated, because the proportion of MDR in old treated will be about 10 to 12% compared to 3% in the new ones. So it comes to about 6%. Why I am showing you this? It's a new, which should be important for us. But pediatric TB is largely a transmitted drug resistance. So they are exposed to either this new or the previously treated. And that's where, unlike adult TB, which is often acquired, pediatric TB is largely transmitted. And therefore, except for adolescents, where they may be acquiring resistance TB also and having further amplification. So it's not that they cannot have acquisition or amplification, but largely to begin with, most pediatric MDR TB is transmitted. So possibly about 5% of the children which we see on an average in our country are likely to have MDR TB, and that's a very huge number. If you look at the global estimates, about 3% of all pediatric TBs globally are expected. That even if with that estimate, we should have between 25 to 32,000 children developing MDR disease annually. It takes about 2 years to treat one. So we should have close to about 50,000 children actively under MDR therapy in the country. We don't have few thousands. So we are missing a lot. Possibly only 3 or 4% of these children are likely to receive MDR TB because others are missed. When about 1 in 5 of this child is likely to die. And that's a big gap we have to be very mindful of. And this is not only a situation which is India. If you look at the median, this from 35 countries, this is again around 5% median, which you see here. What is a footprint which tells you that an individual who comes to you with TB has drug resistance TB? Is there a marker? Is there a flag somewhere? One of the studies which is from South Africa, which has reported a lot of drug resistance cases in tuberculosis, it tells us they are no different to identify, other than that they have an MDR TB index case identified in about 40% of the situation. That's one marker which is there. Or a defaulter or death in the family in about 14%. So about 55–60% of these patients either have an identified MDR TB case or an index case which is likely to be drug resistant because it was defaulter or treatment failure or has died of TB. And that's a very important thing to remember. They have both pulmonary and extrapulmonary form of TBs, as we can see. There is no difference in the type of X-ray they would have. Unlike in the adult, where it's usually said cavity TB, you would get about 50% of them would have, you see the lymphadenopathy. There can be large pleural effusion. Cavities in about 1/3. So that's something important to remember. They can have even a non-severe disease with multi-drug resistance. So all multi-drug resistant TB, to begin with in children, may not necessarily be very severe. It becomes severe because of poor treatment and not responding and continuing morbidity. So to begin with, body makes no differentiation between drug resistance or drug sensitive or multi-drug resistant bacilli. It behaves the same way with them. So if it is a primary disease, you might as well have just a hilar lymphadenopathy and no other disease. It's the lack of therapy. If the natural healing does not occur, which leads to these children having further, extension of the lesion. The clinical spectrum of drug-resistant TB would be very variable. Children and adolescents with drug-resistant TB can hilar or mediastinal lymphadenopathy, can have segmental lesions or pleural involvement. Extrapulmonary TB is also similar amongst drug-sensitive and drug-resistant infections. Cavitary or extensive disease is more often associated with acquired MDR TB in peri-adolescent group. So that's the group which behaves like adults and can have a similar lesion. So suffices to say that a lot of pediatric TB would not necessarily have adult type of pediatric cavitary disease. And this has been demonstrated even in an MDR outbreak in adults where non-cavitary consolidation, pleural effusions, or primary radiographic patterns were seen in as many as 70% because it was in a low burden country in a jail setting. And those children, those adults were having a primary infection for the first time. So therefore, there is no clinical picture or a radiographer finding which is diagnostic or suggestive of MDR. So we have no footprints to see and say, oh, okay, this is a child who is likely to have drug resistance and we should investigate. So that's an important thing to remember. So how do we meet this challenge? When we do not know what is drug resistant versus drug sensitive, we go back and see how the challenge of drug resistance is met in other infectious diseases. In all infectious diseases, including TB, isolating the organism and determining its sensitivity in every individual to guide the choice of drug is the only mechanism by which we can know somebody has drug resistance. Often, till you wait for that culture to come, the initial therapy may be guided by epidemiological information. Usually, that comes from sensitive pattern from the community isolates. And that's why I presented to you the details about what is the proportion of patients expected to be drug resistant in our country. However, this dictum, which works for most of other infectious disease, was hard to use in TB because you could not resort to an individualized therapy guided by culture and sensitivity because it has a long incubation time. It takes about 6 weeks, unlike an aerobic or pyogenic culture, which takes few days. You would know in 48 to 72 hours. The slow grows maybe in 7 days time. But here it takes about 6 to 8 weeks. And it still had poor sensitivity. Nearly 50% of the time you would not grow it. And there were very few facilities to do it. And that is why time in the past, we have always been resorted to meeting this challenge by a solution, which was investigating for TB drug resistance if only they were at a risk. And what were those risk signs? Clinicians would commonly consider it in a patient when therapy seems to be failing. That is, there is a clinical sign which is persisting, there is a poor radiological or clinical improvement or a clinical deterioration. More so if there was an epidemiological pointer, like a patient is a contact of a proven MDR case or has history of death due to TB in the household. Remember, drug resistance is ultimately a bacteriological diagnosis, which is not by smear, but by phenotypic or genotypic marker of resistance being recognized. So often, it is not feasible with conventional methods like culture due to poor yield and poor access to culture in the past. So our earlier focus, therefore, was that we would treat every child presumed to have drug-sensitive TB. So we had the category 1 treatment, which was given to all presumed new cases. They were presumed to have drug-sensitive. We were not doing any cultures. And if this child had received some treatment in the past, give them a retreatment regime, which was same first-line drug with category 5. The TR-TB investigations were targeted to clinically high-risk situations, which we have discussed just now. What did it result? This meant while most initial cases were treated effectively because there were not many drug-resistant cases to begin with, even if they were 90% drug-sensitive, you had an effective therapy. But those who had drug-resistant TB, there was a delay in diagnosis because you were first giving a new regime, category 1, then you were giving a retreatment regime, and then you often did not have you could not resort to cultures, did not have anything else. And this was leading to accumulation of drug resistance cases in the country, and we were headed for a second epidemic. So was standard regimen ATT, which we were using till now, category 1, 2, good, bad, or ugly? It was very good. It sorted out a large proportion of our drug sensitive cases and sorted them out pretty well. We had close to 80% cure rates. But now, as we go towards the drug elimination, towards the TB elimination from the country, then it is very important that we ensure that even this 10% which is there is taken care of. Because this 10% is likely to increase further because they continue the chain of transmission within the community. And that's something important to remember. Because that is why it led to a large number of hotspots of TB coming up from areas like Mumbai, Sikkim, Delhi. We had large hotspots all over the country. And therefore, we had to be really worried about it. Mumbai saw one of the biggest epidemic of drug-resistant TB, to the extent that at one stage we had no drugs to deal with, and it was called totally drug-resistant, and it made a big news. Not a news we would be very proud to be making of. Why do we have this situation where, while we are able to manage a large number of drug-sensitive cases with category 1, we still have a difficulty of collecting more and more drug resistance? It's because of the amplifier effect of standard course chemotherapy. If you start with an initial resistance to rifampicin, so if your new case, because of the transmitted drug resistance, had rifampicin or INH resistance to start with, they were at a higher chance of failing with the standard regimens, which are otherwise successful in the DSTB to the extent of 80 to 90%. And that was something which was very important. They not only failed, they amplified resistance to other drugs, and thus making it more complicated and difficult to manage drug resistance TB. And that's why we really needed to focus on or change our strategy. So this required shifting in our strategy. Earlier, we were working on drug resistance only for the failures, but now we had not only had to work on failures alone, but also to prevent amplification of failures or prevention of failures, which how can that be done? And why is it important to do? It's important to do because prevention of drug resistant TB is the most cost-effective strategy. Treating MDR, diagnosing the MDR or XDR TB is not a cost-effective strategy. It's hugely expensive. Its outcomes are not as great as the first-line therapy and also very toxic. So the incidental cost of treating it is pretty bad. So if we can prevent it by early diagnosis and effective treatment of a targeted or individualized therapy, where if you are unlikely to be successful with category 1, you don't get it. And if you are likely to be successful, then you get it. And it is taken care of that your drugs are provided to you, somebody observes your drug, so you're likely to complete your course and therefore be successful. And therefore, we will prevent occurrence of resistance. And if we are able to identify those who had rifampicin or INH resistance to begin with, particularly rifampicin, and did not expose them to the category 1, we would not have an amplification of resistance, which was happening with empirical regimens. And that is what has changed the current thinking. Conventionally, just like other infections are best treated based on drug sensitivity, we should try that with TB. And that has brought the concept of universal DST. I will elaborate on this a little more. And this has been fulfilled by the availability of point-of-care tests, which we have in our country now, which are rapid NAT possible as point-of-care tests. The universal DST, currently the focus is rifampicin resistance, where we are doing an upfront testing of rifampicin resistance at first step. It's a key drug for success of first-line therapy. And therefore, identifying resistance to it will tease out patients who are unlikely to succeed. It's also technically feasible because most resistance in this are because of mutation in one gene, which is beta-RPU. And we know nearly 90–95% of the mutations in that area, which are of clinical relevance. So therefore, you have a very high specificity if you know. There are a very small proportion we do not know, or where there is a difference between genotypic and phenotypic. And we have rapid point-of-care tests like Expert, TrueNAT available in our country now, where you could upfront diagnose whether a patient who has MTB, this MTB is sensitive to RIF or not. So this is what is the crux of today's understanding of MDR, which is universal DST. We do realize that there is another elephant in the room, and that elephant is INH resistance. Around 15% of our initial cases are resistant to INH, and failure to therapy in many cases, instances, is actually driven by INH resistance also. So it was seen that drug failure cases who were put on category 2, the success rates were very variable, and success rates were poorer if they had INH resistance. Not only that, if they were INH-CATG resistant, they were more likely to subsequently have amplification to rifampicin or other sister drug resistance, and that had a big impact. So INH resistance was not only driving failure to first line, it was also driving amplification of resistance. So that's something which is very important, that both rifampicin and INH have these difficulties. The harder part is that INH resistance is not that easy to diagnose, and I will come around that a little later. How did we therefore try to address this problem of INH resistance? One of the ways which was brought out was we changed from intermittent regimens to daily regimens. The intermittent regimens otherwise were robust, but there was some evidence to suggest that if intermittent regimens for some reason were not taken adequately, if the patient missed some doses, that put them on risk of developing INH resistance. So per se, if you are totally adherent, you are taking DOT, then daily versus intermittent, there is no difference. But if you lose drugs from a thrice weekly regime, then you could become resistant. And that is why we shifted to daily regimens. The second thing which was done is that we have added a third companion drug in the continuation phase to RH. Now our continuation phase contains RHE, and that ensures that it will protect the INH in case there is rifampicin resistance, or rifampicin in case there is INH resistance. So for INH resistance, it was to safeguard the rifampicin exposure of rifampicin during the continuation phase. Once RHE came into the continuation phase, there were serious concerns whether we should have regimens like category 2 because they were no different. And secondly, if it is the amplification of resistance you want to prevent, then it is better to upstart the detailed workup of DRTB among the non-responders rather than going to an empirical therapy like category 2. So this is what was done for INH resistance. Unlike rifampicin, it's more difficult to detect rapidly simply because the test which is so far available is line-pro-VESE, which has a lesser limit of detection and therefore requires a larger number of bacilli. And secondly, the resistance to INH is not by a single type of mutation. Primarily, we know there are several mutations in INH-A or CAT-G area, catalase G, which catalyzes the INH in the body, INH-A, which converts it into the active drug, that has an impact. So if you have CAT-G resistance, you are also likely to amplify to rifampicin. And therefore, what we use here is a line-pro-VESE, which in pediatrics is difficult to use unless until you're an adolescent or a young child with extensive disease who has a smear-positive disease. It is also not so successful on the extrapulmonary specimen. I will detail more about LP as we go by. So therefore, in these situations, the smear-negative or EP samples will perhaps need to resort to MGIT culture and LPA being done on that culture isolate rather than directly, which is possible in smear positive. So the goalpost for managing MTB have moved from MTB detection to MTB and rifampicin resistance detection, and that's UDST. RapidNat has made that possible. By RapidNat, we mean either a Cepheid-made product from USA called Expert or GeneXpert or Expert RIF, and an indigenously developed product called TrueNat, which is a chip-based technology. Expert is a cartridge-based NAT, which is a closed system with automated processing, unlike earlier PCR tests, which is less prone to contamination. Here, the amplified DNA is detected as the reaction progresses in real time. So it also has a nested PCR, which has a primer for MTB as well as for RIF resistance. And therefore, within about 2 hours of testing time, one can know this is what the machine looks like. You put the sample in a digester, and this is the digestic solution, and you put it in this cartridge and put that into the machine. No more action is required by any lab technician. That's all. It's so simple to do. That is why it is possible as a point of care test. And then in about 2 hours, you would know whether this sample has a detectable DNA of MTB and RIF resistance. So that has made it easier for us to know. However, if you look at how it performs in childhood respiratory specimen, it performs as good as a culture. And if I may remind you, nearly 40% of our pediatric cases on an average, particularly maybe up to 60% of our nodal TB is culture negative. So this test will, if it comes positive, it is very good. But if it comes negative, it does not rule out TB. And then you have to resort to a clinical diagnosis of TB. That will not rule out TB. This works equally well with fine needle aspirate, gastric aspirate, pus samples, CSF, but doesn't work very well with pleural or pericardial or synovial fluid usually because of the lesser bacillary load. So to get best yield, you need to optimize your diagnostic algorithms. Remember, the negative test does not rule out TB and still misses nearly 50 to 60% of the cases. So if you have to detect INH resistance, it is feasible, but it is difficult. Direct testing so far is possible for INH only with an LPA. So unlike Gene Expert, for INH resistance, what is available is a line probe assay or LPA, which is also called a Heinz test. You can do it either on a smear positive sample, which may not be available in many pediatric cases. Otherwise, what we were doing in the past, we will do a culture and then do a phenotypic drug sensitivity on that culture. However, here on that culture, if from that isolate, if you put that to LPA or Heinz test, because the number of bacilli or DNA would be high, it can be directly applied. Within 72 hours, you would have the results for first line LP or second line LP. So while phenotypic would have taken another 4 to 6 weeks. So you can, by this hybrid technology, you can bring down the time taken for diagnosing INH resistance, but it still needs to process through an MJIT and then LPA if it is smear negative or extrapulmonary disease. If it is smear positive, then it can be used directly on a specimen like in an older child. This is how the Heinz test looks like, and it has multiple steps. Unlike the Gene Expert test, it has several other steps which come in between. These are the many probes which are used for not only RPO, but also for INHA. And this is able to tell us whether you're dealing with non-tubercular mycobacteria complex, or whether it is sensitive to rifampicin or INH. So LPA will tell you both RNH. Expert will tell you only rifampicin. In our country, we assume if you have RIF resistance, nearly 90% of the time, you also have, along with INH resistance, they go hand in hand. So all RIF resistance are presumed to have MDR as a surrogate marker. However, on LPA, this can be confirmed, while on Expert, it's only rifampicin which we are able to. So if you have understood this far, then how are we diagnosing now our TB patients for drug resistance? We therefore are not using a risk stratification as we used in the past. We are testing for drug resistance to rifampicin upfront, what we call as UDST, either by a NAT or an MJIT culture. Depending on whether you have RIF sensitive or resistant TB, you go further. If you have RIF sensitive TB, which is the RSTB, then you do not need to. Just give me a moment. So if you have an RSTB, then you may start therapy. And if the child has any reasons to not improving and you on follow-up, then on the MJIT culture, if you're sent, or later on, you can test and do a first line LPA for INH resistance, because that may be the reason for non-response. On the other hand, if you get a RIF resistance to begin with, if it's a new patient, you may like to confirm it. I'll tell you where it is like to should be confirmed. But you do not stop with RIF resistance alone. If you get RIF resistance, just as we are trying to optimize the first line therapy, we are also optimizing the MDR therapy. Because in our country, the background resistance to second line drugs like fluoroquinolone, to injectables, is also high. So you want to do a second line LPA to see whether the fluoroquinolones or second line injectables sensitivity is still there in this isolate or not. And that is something which is very important to optimize what MDR therapy you will use to treat your cases. Sometimes you will get about 4 different types of CB-NAT results when they come your way. And this is important to remember. I recall how much change has happened during my lifetime, very finite amount of time of my professional life, about 35 years, that we never talked of culture. Then we started talking of cultures. Then we started talking of knowing rifampicin resistance. And today, when we in the past talked of resistance, we said, okay, this is something you refer to an expert. And today we have come to a situation that since its report is going to come to every clinician who follows the guideline, they need to know more about it, whether they treat or not treat, or whether they just partner or provide that support to the patient when the patient is treated by the system. They need to know more. So unlike in the past where I would have said, okay, now you refer, here is something which you will need to know more. And CB-NAT results are one of these areas, because once you send the samples, you may get 3-4 patterns. The first pattern is the easiest. MTB detected, rifampicin resistant not detected. We do not say rifampicin sensitive, we say rifampicin resistant not detected, simply because you are able to detect only 95% of the resistance. So you can't say it is sensitive because 5% you do not know. However, it is the terminology when we say resistant not detected, it means effectively that we're likely dealing with the sensitive strain, and we treat that as a DSTB. If you get second type, you will get is where it very clearly say MTB detected, rifampicin resistant detected. That's also easy, because then you just have to send either a first line LPA or second line LPA, because if it is smear positive, or an MJIT culture for further processing, so that you can optimize your MDR therapy. The difficulty is if you get something like this, which is MTB detected low or very low and rifampicin resistant detected. Now here is a situation. What does it mean? When we say MTB detected low or very low, that means there is a very small amount of DNA available in the sample. Just to tell you, when we are using phenotypic sensitivity, you have to have 1% of the bacilli phenotypically resistant to a drug to call it drug resistant. When we do it molecularly, genotypically, then if 5% of the DNA shows resistance to a drug, then we say it is resistant. So that's one thing to remember. So here is a situation when you have very small amount of DNA, then this proportion can get very haphazard. It may have picked up on a colony which was RIF resistance, but actually the disease is not having more than 5% of RIF resistance. So the specificity of detection of rifampicin resistance, not of MTB. If it says MTB detected low or very low, it is TB. That is not doubtful. What is doubtful is whether if it says rifampicin resistance is detected, it actually exists. In such situations, if there are no risk factors, if there are risk factors, treat it as RIF resistance. If there are no risk factors, then you will need to retest and treat as DRTB if only it is reconfirmed. Otherwise, we treat these children as DSTB and keep under watch. Some of them will turn out to be DRTB while others will respond. The fourth type is where it will say MTB detected. Usually this type of message comes when there is low or very low, and it will say rifampicin resistance indeterminate. This does not mean that it doubts rifampicin resistance is there or not, unlike in the past. Here it is not enough DNA to comment on. Here again, you retest if there are any risk factors, otherwise you treat as DSTB. So this is something which is important to remember, how to learn from our CB-NAT results. Quickly, some definitions. Mono, when we say mono, it is resistant to any of the first line drugs. MDR means resistance to HNR. Poly means any two drugs other than HNR. So two drugs which HNR is MDR, but two drugs other than, not including R and H together, but not including R at all, is polyresistance. If it includes HNR with either fluoroquinolone or second line, it's called pre-XDR. And if it contains both, it is called XDRTB or extremely drug resistance. We have done away with the term called total drug resistance, which was actually the XDR of Yore, which came up from Hinduja in Mumbai, and there was a big noise. And thankfully, that is what led to a lot of change in the management of drug resistance in the world, or in our country particularly. So that term has been taken away because there are many more drugs, and we have not tested for every drug known or which can be repurposed to say that it is totally drug resistance. And I'm thankful that we have not reached that situation, and we should not reach that situation. XDR is bad enough for us. Now, I've given you a lot of theory. As a clinician, how does it help? I'll just quickly give you two illustrative cases where we were helped by the strategy of UDST. This 14-month-old child, whose typical history of long fever, irritability, comes to you with no history of contact, family survey done, X-ray is normal, is slightly lethargic, 97% air, smile pallor, spleen palpable, is malnourished, irritable but consolable. You do routine investigations, they're all normal. You do an X-ray, you see a left upper lobe lesion, which is apparent gamma opacity here, which you can see. Ultrasound is normal. Other causes for fevers, wrong fever are normal. He came in the dengue season, even that was tested because fever had some degree of intermittency. So what we found was there was a persistent shadow which was not improving despite their adequate amount of antibiotics being given. We had tested for MTB, gene expert was negative, AFB was negative. Given this scenario, all of us perhaps would make it a clinically diagnosed case of TB because it's a strong clinical suspicion based on prolonged symptoms. There's no response to potent antibiotics post-admission. His Montus was also positive, and X-ray had a persistent shadow with persistent symptoms. So in our country, we would often at this stage call it clinical diagnosed TB. But this patient had come to us in a tertiary hospital where we do pulmonology. For us, this is a persistent pneumonia. And we know while TB is an important cause of persistent pneumonia, it's not the sole cause. We have had surprises. We have seen CGD, we have seen fungal pneumonias, we have seen autoimmune diseases also presenting like this, where you have fever, you have a lesion, and it's not responding because it's not infected. So we tend to investigate these. I'm not saying that every child at this stage would undergo investigation, but where it is possible, and today we are talking about there are more pulmonologists or respirologists available all over country, then we need to see patients where we do not have a definitive diagnosis. So we went ahead and did a bronchoscopy. And on bronchoscopy, we saw caseation some degree, and the ball expert rib was MTB positive with rib resistant detected. It was repeated as mandated, and it was on repeat also, it showed rib resistance. Child was started on MDR. So think of this patient. To begin with, clinical pointer other than fever or a prolonged therapy, not even a pointer of TB. Investigation, therapy, clinically diagnosed. But on detailed further investigation, not only TB confirmed microbiologically, but rib resistance. Had we continued with drug sensitive, this child, I mentioned to you lethargy later on, had few days later had a convulsion. Initial CSF was normal. And when CT was done, he also had a tuberculosis. He would have died or he would have had very severe, repercussions. Once we diagnosed, initially we had put on shorter regime. Once we diagnosed that this child was CNS TB, we went to the longer regime, but that's how this child progressed. So this is something important to remember, that there are no clinical markers of drug resistance. So this is the first case tells us there are no clinical clues other than the epidemiological clues I talked to you about, where the child is exposed to a known case of DRT, or someone who is a defaulter, or someone in a household, coming from a household where somebody has died of active TB, usually a TB orphan is a very common situation. Here is another child which we'll quickly talk about. It's a 2-month-old child who came with acute history, cough for 4 days, but also was not gaining weight adequately since birth. A newborn not gaining weight or losing weight is something which should alarm us to any disease, not necessarily TB, but any disease or a feeding problem. So here was a child who had come with cough, fast breathing, and poor thing. And this child had no history of tuberculosis in the family. This child had a history of death of mother who had expired 5 days before this child was brought to us with acute LRTI. And the mother had died of a severe acute LRTI with ARDS. She had cough for 2 days and she had severe breathlessness, was taken to a hospital, reached there in respiratory failure, required ventilation. She was treated as a case of severe acute respiratory infection. H1N1 was considered, put on Tamiflu, could be successfully extubated, though her H1N1 was negative, was discharged and died 3 days later at home. Her discharge notes, which were available to us, showed that she was H1N1 negative, X-ray had ground glass appearance, just suggestive of ARDS. So we also thought maybe our patient has contracted H1N1 from mother. We gave him Tamiflu. We treated that child. He had subcostal recessions. But one thing which was not fitting in was his X-ray. His X-ray had a large pneumonia with cavitation. That's not usually a picture of what you see with H1N1. Cavitation is described with secondary infection, but it's not the usual case. And this was a dense consolidation. There was a bronchopneumonic spread. We thought of TB. Everything else was normal. We did give oseltamivir to this child. We treated for bacterial pneumonia, but the counts were normal. Child did not show. We also gave category 1 and started investigating this child for tuberculosis. Lo and behold, it was MTB detected with resistant detected. It was low. We repeated. On repeat again, it was confirmed. So we took it as a RIF resistance, and this child therefore went through the subsequent next part. If you are RIF resistant, there was a child. We wanted to know whether this is a new child, if it new patient, because he had never been treated, 2-month-old, had no exposure risk factors. So she was retested. But then when we asked the family again, they were able to bring an old report of the mother that she was not doing well. And a couple of months earlier, she had an X-ray which showed fibronodular shadows. We just had that slip of paper with us. We didn't have an X-ray chest film with us. But this was perhaps a not treated TB, which had gone into an ARDS phase or a miliary, I do not, or maybe a secondary infection at that time. We were not a treating physician. We have no idea what happened. It was done at another hospital. But here was a child who not only later turned out to be drug resistant to rifampicin, but also to the fluoroquinolones, and he had other resistance and was a pre-XDR. So this is the child who had fluoroquinolone and SLI resistance and therefore required a much more complex therapy. So when we say that there is a need for optimization of therapy to prevent augmentation of resistance, this is what I mean. All that I showed you in previous slides is highlighted or underlined by these couple of cases. In routine, both of these cases would have got RHZD for 4 months and RH for 2 months. Somewhere in between, if they were unlucky, they would die. Somewhere in between, they would have deteriorated and maybe undergone investigation. This is important to pick them early, prevent morbidity, break the chain of transmission within the country of drug resistance. And that's something which is very important for us to do. And this is why this particular algorithm is important. Do not stay only with the RIF resistance, also optimize that therapy. Do not stay only with RIF sensitive. If this patient is not behaving, not improving, think of INS resistance or recurrence of RIF resistance here. So this is how the whole gamut of drug-resistant TB has changed. We are not, unlike in the past, starting with a presumptive case of DRTB. We are presuming that there are drug-sensitive and drug-resistant TB among all TB cases because there are no clinical markers other than few epidemiological markers. So we will upfront check for drug resistance in every child in our country now because we do now universal DST or UDST. And that, to my mind, is the biggest change. There will be a small proportion where you would have a probable MDR definition. This is a situation where you may not get a microbiological confirmation despite even doing invasive tests. So this is a pediatric case of TB with a clinical non-response with or without radiological deterioration despite adherence to ATT by the end of 4 weeks with one or more of the following risk factors: exposure to an MDR TB or DRTB or a history of recent death in family due to TB or someone who was earlier lost to follow-up. Therefore, this is a possible probable case where all efforts to make a microbiological test fail are negative and there is no, or sometimes you may not have possible access to specimen. You have a deep-seated tuberculoma or a lymph node deep-seated in the abdomen. Here, you may start a MDR therapy as a probable case. Remember, This always comes with a caveat that you have reasonably well ruled out any alternative diagnosis which could explain these symptoms, because this is not microbiological proven. And often you would need the recommendation of the drug resistance TB committee before you can actually start drugs from the NTEP. So this is a very small proportion, but remains important in pediatrics. Particularly, we have few intracranial cases where we had this difficulty, and we put them on presumptive cases. So one bone spine TB, where despite even going for aspiration of the pus from the paraspinal area, we were not able to culture or demonstrate anything. So these are difficult situations. What regimens are available? If you are under 6 and have a limited disease, there is a shorter regime. Shorter regime is for about 11 to 12 months, 10 to 11 months, which is moxiflox, high dose, kanamycin, ethanoamide, clofazimine, pyrazinamide, high dose INH and ethambutol. This cannot be used if you have INH, CAT-G and INH resistance together, second line injectable or fluoroquine resistance. So this can only be used in not very severe disease, purely pulmonary, and which doesn't have any of these resistance. You may start with it and prove that these resistance do not exist, as we did in our case, because many a time they may not be immediately available to you. If this child is above 6 years, then one can use newer drugs like delaminate instead of injectable, because injectable have their own difficulty. They cause a lot of adverse effects. With delaminate, you stop delaminate or bedaquiline, which is about 12 years. The continuation phase is 12 months without these two, because they are not recommended beyond 6 months. There are very, very few studies. If you have any other form of MDR TB, then you need to go on conventional, very long therapy. The drug combinations have changed. Now, linezolid has come in a big way. High dose moxiflox has come in a big way, and so has clofazimine. These are the 3 newer drugs which were not so often used in the past, which have come our way, and one has to be mindful. We are also now using different drugs for INH monoresistance or polyresistance, which is not with rifampicin. There you use drugs like levofloxacin to replace INH, and you use 4 drugs for at least 6 months as uniphasic. So once you replace INH with levoflox, it becomes a weaker regime. So there is, in the continuation phase also you use it, along with pyrazinamide, which you do not stop at the end of CP. And it can be extended to 9 to 12 months when you have extrapulmonary disease like bone or intra. Pyridoxine almost always needs to be given to all DRTB cases, particularly if you're using ethanoamide, right? Because there can be more and cycloserine, because there can be more neuropsychiatric side effects. All of these are toxic drugs, so you need a complete pre-treatment evaluation like KFT, LFT, electrolytes. Magnesium is very important when you're using drugs like clofazimine, or you're using clofazimine with delaminate, because there can be QTC prolongation, and that's where these electrolytes should be looked at. And often these children are malnourished and would have magnesium deficiency. Serum proteins, TSH if you are doing PAS, otherwise not required. Audiometry if you are doing SLI. So psychiatric evaluation at baseline may be required, because cycloserine can give rise to psychotic side effects, disorders. So there is a whole panorama of investigations which requires. As I said, duration is long. We have a shorter MDR-TB regimen, which is only for selected cases which do not have extensive disease, and they do not have resistance to FQ or SLI, and neither INH. Then only they can be used. These are just to show you the dosages, that they are different, and there are drugs available under the program where you can use the child and adult formulation in different combinations. This is just a chart to show you that. What is important is, just as we have to choose best educational try for a different age, you have to choose the right drug for a different age. And therefore, that's a challenge. Often the drug resistance therapy is not available in pediatric formulation. You have to cut, crush, or mix them. They're not scored. If you cut them, you're not sure whether the drug was equitably distributed. There are very little studies on availability or stability of drug once you put it into food. That is another issue. So there are challenges with injectables, painful, lack of muscle mass. You need a trained health person, and you need it for 6 months. Not easy. The risk of hepatitis C, HIV, injection site abscess, neural injuries, and ototoxicity. Nearly 20 to 30% of our patients develop ototoxicity when they go on injectable regimes, minor or severe. If they don't come back for regular follow-up, sometimes you have almost permanent loss of ototoxicity. And that monitoring is not easy to come by. Therefore, these are the areas of concern when we are dealing with DRTB. So DRTB, while we have progressed from several challenges to many solutions, we are yet got a lot of ground to cover. Remember, it's a sentinel event, but yet not a well-documented problem. We still do not have many patients on therapy despite this being an important area. Despite expecting about 6% of our initial cases to be drug resistant, we treat less than 2%. It's difficult to diagnose, agreed, but not so difficult with ease of availability of molecular diagnosis now. It was earlier more difficult to diagnose when there were just cultures which are to be done. There is suitable therapy and available for free. Even newer drugs like Delaminate and Bedaquiline are available for free under the program. So if you identify a patient and you are not in public sector, don't worry. Your patient doesn't have to spend money on anything. They can get quality drugs, absolutely quality drugs from the government pharmacy for no cost. And patient can stay with you for follow-up. That's the beauty. Remember, there are pill burdens and injectables we still have to deal with. Our the urge and our requirement to search for a safe, effective, and suitable, acceptable therapy for children, where children do not have a lot of side effects, is yet to be found for drug-resistant TB. We are working on it. The world is working on it. We have made some progress. Still, there is a long journey to go. Never mind. We will cover it. As long as we do not allow further amplification of this drug resistance. And also, if we manage our drug sensitive well, use UDST, do not allow the culmination of more, increase of more drug resistance cases. Perhaps this will not be a problem which is unsurmountable. Nobody else could have, brought such a difficult topic, the challenge of speaking on this topic, but Dr. Das, who in his own life, I was trying to read on net about him, has worked amongst very great challenges. And he was a professor and head of pediatrics at Silchar Medical College, a very well-known pediatrician of the area. But he did not restrict himself to one area of pediatrics alone. He was a good orator. He was a good teacher, of course, a good parent. You see here he is with his daughter, where who could not become a clinician was one of his, regret of life, but worked a lot on cancer research. And because of her, Dr. Das used to run breast cancer hubs. So he would talk to the mothers coming for their children's problem about breast cancer. What a synergy. These are the young mothers who really may be at a risk now or later of breast cancer. It's a big killer. And he did not say that, oh, this is not my domain. Whatever he could contribute, he was not treating, he was not diagnosing, he was just increasing the awareness. I tried to do what Dr. Chandrasekhar Das did much better than me, but I tried to do the same thing in this lecture, just sensitizing you more about MDR-TB. Why do we need to do it? What needs to be done? What can be done? And how to give best treatment to your patient. Thank you so much for your kind attention.
Thank you, Dr. Varinder Singh, sir. I think I invite Dr. Anupama Deka, madam. Because of some technical hitch, we were not been able to show a small tribute to Dr. C.S. Das, sir. I request Dr. Anupama, madam, to show the slides. Yes, Baido. Baido, please unmute, Baido. Yes.
It's my pride and honor to be here to offer a tribute to my beloved teacher, Professor Chandrasekhar Das, who is my guide, mentor, and father-like figure during my PG and also as a when I was work with him as a colleague. So he was a legend in his own life. He was a legend in his own lifetime, a person of eminent abilities and vision. Dr. C.S. Das did his MBBS DCH MD from Assam Medical College, Dibrugarh. He also started his medical career as a registrar from his parent institute and subsequently worked in Guwahati Medical College and Silchar Medical College in various capacities and retired as professor and head of the Department of Pediatrics from Silchar Medical College in 2006. He had loved for teaching and imparting clinical skill and bedside clinical art. He was a recipient of prestigious honor, Ceremony Chikitsak, and in 2019, he received the Lifetime Achievement Award. Dr. C.S. Das was loved and respected by all his colleagues, staff, students, and patients for his humble, benevolent, and loving nature. He was a passionate teacher and always loved the company of the students. He had many guest lectures, orations, publications, and presentations to his credit. He was a member of Indian Academy of Pediatrics, National Neonatology Forum, American Academy of Pediatrics, Respiratory Chapter of Indian Academy of Pediatrics, and Nephrology Chapter of Indian Academy of Pediatrics. Dr. C.S. Das sir was very much interested in developing pediatrics in Assam and was always in favor of development of subspecialty in Assam. Assam in pediatrics. He encouraged many of his junior colleagues to get trained in pediatric subspecialties and always favored and supported to the young pediatricians. Training and nurses for the pediatric nursing was also his passion. In spite of being a faculty of medical college, he was actively involved with all the IAP activities. Dr. C.S. Das oration is instituted as a tribute to his work and contribution in pediatric field. Today, in his first oration, his pupils and colleagues are here joined virtually due to COVID pandemic and paying their humble tribute to a person whose virtues they strive to emulate and whose academic trends they attempt to uphold. Dr. C.S. Das will continue to inspire several generations of pediatricians and teachers for many years to come. And thank you, sir, for your excellent deliberation. And we all inspire from your words of wisdom and all the who are, that means I am sure that pediatricians, all the pediatricians who are participating in this oration immensely benefited from your talk, this multi-drug resistance in pediatrics and its challenges and solutions. So, sir, thank you very much for your wonderful oration again. And I will look forward from you. We will get the interaction from you in near future. Thank you very much.
Thank you. Madam, please stop sharing. Thank you, Dr. Anupama, madam, and thank you, Dr. Hunsegiri, for sharing the session. I once again thank Dr. Varinder Singh, sir, for giving us the first oration on Dr. C.S. Das, sir. Sir, since it's a virtual meeting, we'll not be able to felicitate you virtually, but anyway, we'll be happy to send you the memento as well as a shawl by post. Hopefully, we'll take a picture and then we'll share it again. We'd love to see you again on a real world, not in a virtual world, next year also. And thanking you again for your time and for such a wonderful and elaborate discussion on MDR TV. And now we go ahead to this next session, for which
thank you,
sir. For which we have Dr. Bharat Reddy from Bangalore with us, and to share the session, we have Dr. Gautam Medhi and Dr. MP Bajaj, sir. Bharat, I'll share the slides.
Yeah, please do. Let me know when I can start off, Dr. Partha. Yeah.
Sorry.
He's sharing, somebody's sharing.
Dr. MP Bajaj sir and Dr. Gautam Medi sir, please introduce Dr. Bharat Reddy. Bajaj sir.
Hello,
Yeah.
good evening. Good evening, Dr. Bharat Reddy and delegates. After a very nice session by first oration by Dr. Professor Virendra, I'm pleased to introduce Dr. K.R. Bharat Kumar Reddy, who has done fellowship in pediatric pulmonology and sleep, and he is European diplomat in pediatric respiratory medicine. He is director to Shishukati Hospital and consultant. He is having a sleep training program for parents also, known as NEPs and Levels. And what caught my eye was that he is a fiction author also, a doctor's chronicle. Please, sir, we are ready for 10 commandments of pediatric sleep.
Thank you, sir. Thank you for that wonderful introduction. I would firstly, at the outset, like to thank this wonderful organization of the Northeast Pediatric RESPICON for inviting me to give such an important topic on pediatric sleep. So when I was discussing what topic is very important for us as pediatricians, I realized that talking about the 10 commandments or the 10 important points which pediatricians should know about pediatric sleep would be most apt. It would be very easy for me to go into each topic and talk in great detail. But I think for us as general pediatricians, to start getting aware on pediatric sleep is most important. So I would like to thank the organizers, especially Dr. Partha and all, for giving me this opportunity to talk about pediatric sleep. Next slide. So what is the first commandment that I want to talk about? What is the first most important point? Next slide, please. First most important thing I would like to tell you is that sleep is absolutely essential for growth and development. I think all of us know this. We have all studied this, and we all at subconscious level know that sleep is important for all children for growth and development. Next slide. So let me tell you a little more in detail about it. Firstly, for growth and development. We all understand that growth hormone per se cannot be secreted without the absence of sleep. We all know, right from our physiology days, that growth hormone is stimulated by sleep. But we tend to forget that if children don't sleep well, they do not adequately grow or adequately develop. There are a lot of studies which also show the role of sleep in memory as well as attention. We have shown that many children who have attention deficit disorder, many children who are probably even misdiagnosed as ADHD, were actually having sleep issues. So it's very important for us to understand the role of sleep, especially in the memory and attention of children. I think a very simple example for us as adults also, when we're studying in medical school, is that if we don't sleep before our exam, the chance of us remembering what we studied is much lower. If you study and then sleep, your memory tends to develop much better. The biggest surge of obesity right now has also been attributed to a little lack of sleep. We already know by studies now that not only do obese children have OSA, but children with OSA also tend to become obese. There is a pathway which says that if you do not sleep well, you will become obese. And finally, does sleep have an important role on the immunity of children? Yes. Sleep has shown to prevent infections. This is the very simple grandmother's tale that we used to say in many yesteryears, that sleeping well is the most essential thing to prevent infections and to lead a healthy life. And hence now we're all coming back to this, to say that the most important principle is sleep is essential for growth and development of children. Next slide. The second commandment which I would like to say is, yes, now that we established that sleep is essential, we need to understand that the quality of sleep is just as important as the quantity or duration of sleep. Many of us are very well versed to talk about the duration of sleep. We say that this is the amount of sleep that adults have to sleep, 8 hours. We always use 8 hours as a random number. And we say that all adults should sleep 8 hours. But is only the duration sufficient? And moreover, for us as pediatric sleep specialists, it is much more difficult than our adult counterparts. The reason being that sleep varies, even the duration of sleep varies as the child ages. The duration that a neonate sleeps is very different than what an adolescent sleeps. So it's more tougher for us as pediatric sleep specialists. But let us talk about the quality and quantity of sleep. Next slide. So the basic quantity of sleep is defined by the ASM guidelines. So the recommended amount of sleep in the pediatric population varies. For infants, it's up to 12 to 16 hours. For toddlers, 11 to 14 hours. Preschoolers, around 10 to 13 hours. school-going children 9 to 12 hours, and teenagers up to 8 to 10 hours. This is the ASSM guidelines and endorsed by the American Academy of Pediatrics. Of course, we are trying to work on new guidelines for the Indian population as well. But with our data, which will be published next year, we will be able to establish the recommended amount of sleep in the Indian population as well. Next slide. But is it sufficient to say that the duration of sleep is sufficient? Now, if you see, a lot of parents may not come to you and tell you my child is sleeping less duration. Most important common problems that parents come to us in infants with multiple night awakenings. They say the child is waking up multiple times at night, or they say there's a delayed bedtime. The baby is not able to sleep or resisting sleep. Toddlers especially, the sleep resistance is extremely common. They may also come with snoring and restless sleep. But school-going children can come with an erratic sleep time, sleeping late in the night, waking up late in the morning, sleeping differently on weekdays and weekends, having some amount of restless sleep, snoring, mouth breathing. So all of these tell us that it is not just the quantity of sleep, but also the quality of sleep, which is essential for us as children. So let's remember, for all our pediatric age group, ask for the duration of sleep. Talk about the duration of sleep to your patients, but also, is he sleeping well, or is the quality of sleep good? Next slide. So in infants, let us talk about what is it that defines the quality of sleep. How do I ask for the quality of sleep in infants? The most important quality, which says, according to my rule number 3, is sleeping through the night. This has been established across a lot of Western studies as well. When we talk about these different stages of sleep, and is the child sleeping through the night through all these stages? So let me tell you the basic sleep stages in children. Stage 1, NREM, stage 2, NREM, and in children, we club stage 3 and stage 4 as one stage of NREM sleep, and stage 5 or REM sleep. So what we usually see as deep sleep is stage 3 and stage 4, and we always also see REM sleep. Now, why did I talk to you about these basic stages of sleep? Go to the next slide, and you will see that in REM sleep, a lot of babies are known to wake up. So babies, especially in infants, tend to, as you start reaching the end of REM sleep, a lot of babies tend to wake up or have minor arousals. Next, but these arousals are very minuscule. And a lot of babies, next slide. And a lot of these arousals are minuscule, and a baby goes back to sleep on their own. But what is important for us to understand is that when this baby wakes up, we need to encourage what we call as self-soothing skills. So self-soothing skill is an ability of a baby to put himself or herself back to sleep without any assistance. So it's important for us as pediatricians to know this concept of self-soothing skills. Remember that a baby developing self-soothing is a developmental milestone. Just like how we talk about all milestones, a baby should be able to go back to sleep with that minor arousal during REM sleep without any disturbance. But this needs to be assisted and nurtured, which means a baby should go back to sleep after arousal in REM sleep. This is natural for a baby to develop. Next. And in long term, this helps in a consolidated sleep. So talking about sleeping through the night. So babies begin to sleep long stretches between 4 to 6 months, but a baby can sleep through the night for 8 hours after 6 months. A lot of mothers come and tell me, how can I allow a baby to sleep for 8 hours? Should I wake up the baby to feed? Should I wake up the baby for anything else? I'm scared that the baby is sleeping for so long. This is a normal milestone actually, and we need to encourage this. So some developmental milestones can interrupt the sleep, like crawling, rolling, etc. But we as a goal should ensure that by 12 months, all babies should sleep a minimum stretch of 8 hours through the night without feeds. And this is physiologically possible and is essential for growth and development. So coming to my 4th commandment, what interrupts this? This is normally supposed to happen, but it doesn't happen. A lot of babies tend to wake up very common. So what is this reason for multiple awakenings? And the most common reason, as we all know, is sleep associations. Next slide. So what exactly are sleep associations? So rocking or breastfeeding, can these contribute to sleep issues? Yes. So teaching you an important principle called as a sleep prop or sleep association. A sleep prop or sleep association refers to any object or any activity on which a baby becomes dependent on to fall asleep. The reason I put up the picture of feeding and rocking is that because in India, we know that this is the most common method which is used for a lot of people to put their baby to sleep. So let us talk about sleep props and sleep associations more in detail later. But sleep props and sleep associations are the most common reason for causing night awakenings in a child and resulting in a child not able to self-soothe. So what I advise all my parents who come for sleep coaching especially are, do not breastfeed after the age of 1 year, especially during the night. You continue day feeding. Do not use rockers or use rocking mechanisms to put a baby to sleep, because this results in poor sleep as well as lack of consolidation or sleep. Next slide. So which means that we need to ask parents all these questions. Coming to the fifth most important component is that sleep history taking is essential for parents and for us as doctors. A lot of pediatricians ask me, listen, I don't know what question to ask parents, right? How do I ask parents questions about sleep? And let's say infants, I covered about quality of sleep. What about little older children, toddlers? What do I ask them? So the BEARS questionnaire, this is what we call as BEARS. Can you put up the S, please? S is missing. Okay, so we have BEARS is the simple questionnaire which is used for us to ask basic questions in pediatric sleep. B stands for bedtime. You ask about what is the bedtime of the child. Is the child having trouble falling asleep, or is the child having trouble going to bed? E stands for excessive daytime sleepiness. Is the child difficult to wake up in the morning or groggy during the day? A stands for awakenings. I already covered that. Does the child wake up multiple times in the night? Is the child dependent on something to fall asleep after waking up? R stands for regularity. This counts for older children. Is there a difference in your daytime sleep and nighttime sleep? Does the child go to different sleep on weekdays and weekends? This is important on the regularity and duration. And lastly, S stands for snoring. Does my child snore, or other features of OSA like stopping breathing or gasping and choking? So for a pediatrician, very simple questionnaire, BEARS. You ask these questions, a lot of your sleep issues can get covered. And especially once you take these questions, you will start realizing that a lot of children will be having sleep issues. And if you start counseling them very early with the help of sleep coaching, a lot of them will respond. So this may sound like a new concept to you, but what is sleep coaching or sleep training, which we specialize in? So this assists parents to help their babies to self-soothe. I already spoke about the concept of self-soothe, but remember, many of us parents are not aware of this and find it difficult. So we also encourage sleep practices. We help children achieve a concept of consolidated sleep. That is, you sleep throughout the night, sleep a good duration and a good quality of sleep, and achieve this milestone of sleeping through the night. So ultimately, if we achieve sleep training very early or sleep coaching early, these babies develop long-term healthy sleeping habits and good sleep hygiene as they grow older. A lot of studies have been done, but Jody Mendel's study is very popular, which generally says that the benefits noted with sleep routine and coaching is multiple. I won't go into details of this, but we need to understand that the most significant improvement was noted in maternal mood and maternal depression. We underestimate the amount of depression that is present in mothers because their kids are not sleeping well. A lot of people advise these mothers saying, listen, you had a baby is not sleeping well. This is natural. I mean, how can you, it'll settle with time. Or as a mother, you should understand that you're going to have sleep issues. A lot of depression is caused because of this. But just by doing sleep training and sleep coaching, a lot of maternal depression has been solved. So this is very important for us to start very early. Next slide. So the primary steps which we go for sleep coaching are to firstly set a fixed bedtime, irrespective of the age. Even for infants, I set a fixed bedtime. We establish a sleep routine. That is, you start a basic principle at least half an hour to 1 hour before sleep time. Use activities which are not very stimulating for a baby. You start reducing co-sleeping slowly. Maybe in India, it's not completely possible, but start encouraging it at an early time and safe sleep practices. Next slide. But the most important key to sleep coaching is to not introduce sleep props or sleep associations right from the beginning. Ensure that you eliminate all sleep associations and help the baby to develop self-soothing skills right from the beginning. But we see all this as a pediatrician. Should I start counseling the mother right from day one? The mother says sleep problems are there. Do I always start sleep coaching? No. As a pediatrician, we also need to realize, are there any medical issues causing sleep issues? So number 7 commandment is always rule out medical problems, especially when a mother has sleep issues. So what are the medical issues that we can face? Next slide. So in infants especially, we notice gastroesophageal reflux can cause some amount of sleep issues. OSA is a very important condition which we already know causes sleep issues. Allergic rhinitis and asthma. Allergic rhinitis especially causing turbinate enlargement, snoring can be a very important component. Many of my children, for example, who come with sleep issues, we've treated AR and found that their sleep issues respond. Smaller babies, even up to 6 months, can have infantile colic. And lastly, food allergies and sensitization. So remember that these are some basic medical conditions that can cause sleep issues. And as a pediatrician, we need to rule them out. And once you start ruling this out and start taking a lot of history, as I mentioned, you will start realizing that pediatric issues are not uncommon. Pediatric sleep problems are not at all uncommon. So let me present you some of the data which I have collected over the past 1 year before the lockdown. So I run an exclusive pediatric sleep clinic, and from January 2009 to before the lockdown, we had around 117 children who came to our sleep clinic specifically for sleep issues. We did almost 55 level 1 polysomnographies in these children to understand their sleep problems. And all of these were either level 1 or level 2 sleep studies which were done. Next slide. So let me tell you the basic indications. The most common indication, as you can see, were children coming with infant sleep issues for sleep coaching, which almost formed 42%. This could be a bias because a lot of people do know that we deal with infant sleep issues as a specialty. A lot of children were referred for obstructive sleep apnea. We had a lot of neuromuscular children who come with sleep issues and hypoventilation. So it's mandatory for us, especially when we discuss with our pediatric neurologists, that all children with neuromuscular conditions and genetic syndromes will have sleep issues. So as a pediatrician, you need to understand that when I see out of these 117 patients, we see that infant sleep issues, suspected OSA, neuromuscular, and genetic syndromes are the most common cause for sleep issues. So keep in mind that when you are sitting in a pediatric clinic or your regular general pediatric clinic, if you see children with neurological conditions, take sleep history. If you see children with genetic syndromes, take sleep history. Don't forget about OSA, especially on a daily basis. And most importantly, don't forget about infant sleep issues, because in our sleep coaching program, nearly 90% of them had resolution of all their sleep issues. Next slide. But ultimately, in children which we cannot solve these problems, polysomnography is the gold standard. In the pediatric sleep studies that we did, most of them were again neuromuscular, genetic, and OSA, for which we did sleep studies. The reason I put this up is pediatric PSG is not difficult to do. It is very easy for me to do, and we also can encourage a lot of us to start setting up PSG labs in our country, in our cities. So we just connect basically. So let me show you the next slide, where the basic leads that I put on for a PSG. Next slide. So what I actually do in a PSG, we record EEG, which tells you the stage of sleep, EOG, which tells you whether you're in REM sleep. You see, we connect a nasal as well as an oral thermistor to tell you what is the airflow going in and out through the nose and mouth. We connect a chest lead for the chest and an abdominal lead to look for chest and abdominal movements. And finally, we connect an EMG to the leg to look for leg movements. And we have a video camera and a technician, which is continuously looking at the child. This is a level 1 PSG. Remember, in many places, this may not be available, but we can do level 3 and level 5 sleep studies where all of these may not be connected, but some of these leads can be connected and we can get basic data which can be interpreted. So what do I do in a PSG? This might look scary to you right now, but this is how a pediatric PSG looks. Just concentrate on the 3 center lines. You see a yellow line, a blue line, a red line, and a green line. The blue line is the nasal airflow, red line is the oral airflow, and the green line is your chest lead. Next slide. As you can see, the chest lead, next. You can see some amount of obstruction. As you can see, the nasal flow has got obstructed. At the same time, you see that the thoracic and abdominal breathing is showing some amount of paradoxical breathing. But as you can see, one red arrow showing downwards, that is the saturation. So you can see that the saturation is dropping at the same time that we're seeing obstruction. This is very simple. By taking these simple parameters, we have certain grading system, which is called as the AHI, or the apnea-hypopnea index. And by this, we're able to grade the degree of obstructive sleep apnea and the sleep problems. By these 9 commandments which I told you, I hope we all realize that pediatric sleep is a new branch that we all need to wake up to. We as pediatricians need to wake up to pediatric sleep and understand that we are going to grow in this branch more. And in India, let me tell you that within the next 10 years, we will lead in pediatric sleep because of the sheer numbers that we have and the awareness that we are creating in pediatric sleep. Next slide. So let us understand that we are the first point of contact as pediatricians to discuss sleep issues in children. So we need to wake up to it. Parents are going to discuss it with us. Who else will they talk about it to? Many of the cases will come to me, would have already spoken to their pediatricians. But most of the time, pediatricians tell them, just wait it out. All the sleep problem will solve on its own. No, we need to wake up to it. Sleep problems are not uncommon in prevalence, and our history taking is quite inadequate. A recent study which we conducted on the knowledge, attitude, and practices in pediatricians showed that the knowledge score of pediatricians is around 4.5 out of 10 all over India in pediatric sleep issues. This clearly means that I'm so grateful for our current RESPICON of the Northeast to even include this topic to create awareness. That itself shows that we are getting aware and need to talk about it. But as human beings, let us know that sleep is the most essential and primary need of the human body. If we ensure that children sleep well, parents will sleep well. If you have a happy parent, you have a happy family. And you have a happy family, you have a happy doctor who sleeps well. Thank you.
Thank you, Bharat, for a wonderful session. I think I'll ask Dr. Gautam Medhi sir and Dr. MP Bajaj sir, is there any questions?
So this is a very nice topic. Even I have never heard such type of topic in many conference also, even many CME also. Today I have, even though I am a chairperson, but I have learned a lot of things from you. Thanks for
Thank you, sir. Thanks a lot, Dr. Gautam. Yeah. Thanks
it's
a
a very
lot.
good deliberation, and I think most of this the pediatrician should look this subject very carefully. Thank you.
Definitely. Thank you. Thanks a lot.
Thank you, Dr. Bharat, for a wonderful session. Now I welcome Dr. Sharad Balaji for the second talk. To share the session, we have Dr. Debajit Sharma sir and Dr. Rekha Khan Borkotki madam to share the session.
Good evening.
Yes, madam.
Yes, it's a pleasure to invite Dr. B. Sharad Balaji to the Northeast RESPICON. And I'm sure we're going to learn a lot from him as we have done from the previous speakers today. Dr. B. Sharad Balaji has done his MBBS from KMC and the MD and Fellowship in Pediatric Pulmonology from MMC. He's a recipient of the JV Gold Medal Award in MD Pediatrics 2010 batch. He's also an IAP Active Pediatrician, won the IAP Active Pediatrician Award 2019 from the Tamil Nadu State Branch, along with Best Paper from in the RESPICON 2019. He's currently the Associate Professor at Institute of Child Health, Chennai, Pediatric Pulmonologist and Bronchoscopist, in charge of the Primary Immunodeficiency Center. He's a Nodal Officer, Center of Excellence also, and he's a visiting consultant, Child Trust Hospital. Dr. Balaji, I henceforth ask you to go forth with your topic. Yes.
Good evening, ma'am. Thanks for the nice introduction. Is it audible and visible for you?
Yes.
Okay. So let me come with a scenario, a single case scenario, in which we are going to deal with a problem in pediatric tuberculosis, which is often goes unnoticed. Okay. I won't say that is such a common problem, but definitely that is not an uncommon issue. So we need to think whenever we don't see a proper response after diagnosing a case of TB and putting the child on ATT appropriately. So here the case goes like this. So I'm going to deal with this case. The topic is a boy on ATT with persistent fever, the deceptive paradox. You must be thinking about a paradoxical reaction in this case. Let me see whether it is a real paradoxical reaction or not. Right. So we have seen a 15-month-old child born of non-consanguineous marriage evaluated elsewhere for fever of 2 weeks duration along with poor appetite and weight gain. Contact maternal aunt, drug sensitive TB, and she is on ATT. This was the X-ray taken outside, which revealed a hilar adenopathy. Manto was done outside with the two tuberculin units. Turned out to be positive, 15 millimeter in duration. X-ray revealing hilar adenopathy. Unfortunately, CB0 turned out to be negative in this era of pandemic. COVID turned out to be negative. The child was started on ATT as a clinically diagnosed TB based on positive contact, based on positive manto, and based on hilar adenopathy. So the child, when it came to ICH, our institute, on ATT for the past 1 month, but there was persistence of fever, no weight gain, appetite poor, not playful. So we have a case of clinically diagnosed TB on ATT. Despite being good compliance and good adherence, there is persistent fever, absence of weight gain, absence of appetite, and the child still not playful. Right. On general examination at ICH, weight is around 8.6 kgs, height okay, the child is not that sick looking, no significant lymphadenopathy or external markers of TB such as flectin or erythema nodosum. BCG scar was present. The child was neither tachypnic no tachycardia, nothing, absolutely normal on systemic examination. So his general and systemic examination turned out to be normal, except the low weight for age and low weight for height. In a nutshell, here we have a case of 15-month-old boy with fever of about 50 days duration with significant contact history. Chest X-ray showing mediastinal and hilar adenopathy. Manto was positive, and the child was started on ATT, and it was branded as clinically diagnosed TB. So when we received the child on ATT for about 30 days, but there is neither a radiological resolution nor a clinical resolution. First of all, when the child came to us, we had a doubt whether it is a case of tuberculosis or not. If it is a case of tuberculosis, why the child is not responding to my ATT? That is my second question. Right. Initial evaluation in our institute with CBC, TZ, DZ, platelet, everything turned out to be normal. CRP turned out to be negative. So less likely to be other chronic bacterial infection apart from TB. ESR around 96 more fits into our tuberculosis. RFT, LFT, ultrasound abdomen turned out to be normal. Apart from this, people had done some other investigations like Epstein-Barr virus, Brucella, blood culture, urine culture, in order to make sure that we are dealing only with the tuberculosis and nothing else. Again, here also GL turned out to be negative. CB0 turned out to be negative. All other investigations for bacterial infections, blood culture, urine culture, all turned out to be negative. We proceeded with the CT scan, contrast enhanced CT scan, which shows a large hilar adenopathy with a minimal central caseation. And also we can see bilateral consolidation, more on the right compared to the left. So in a country like India, with a PUO with a hilar adenopathy, unless otherwise proved, with an ESR of 96 with a positive manto and a positive contact, our first diagnosis will be TB rather than a T-cell lymphoma. So what are all the points in favor of tuberculosis? Subacute onset. First point, contact positive, manto positive. There is radiological evidence of hilar adenopathy in X-ray chest as well as in CT scan. Points not favoring TB, there is no microbiological evidence. No response in spite of adequate dose and compliance. Possibility of pulmonary TB was evident and proceeded with ball. So we wanted to get whether we could see some cheesy material in ball or whether our ball is going to retrieve some bacteria, that is Mycobacterium tuberculosis, or maybe something else too. But unfortunately, bronchoscopy was turned out to be normal. Our CB0 turned out to be negative. MG80 is pending. So this is the fever pattern. Every day the child is having a low-grade fever, even despite having good ATT. Right. So what are all the issues in a child with a non-responding TB? Is this a non-response or often a non-resolution of symptoms? Definitely this is a case of non-response. Usually fever defervescence will come within 4 weeks. Weight gain may take 8 weeks. But definitely we will be getting fever defervescence or increase in appetite or increase in sense of well-being within the first 4 weeks of ATT. But despite being child on ATT for about merely 40 to 50 days, we did not have any improvement in any of the parameters like fever, appetite, weight gain, nothing. Nothing we had seen despite the child being on ATT. Second child, is the child taking his pills? Correct regimen, correct dosage, correct duration, and correct adherence. We were so sure, and we had been asking the mother and father, what is the drug the child on? Is the child, is the parent are giving tablets daily? Particularly, they are giving tablets once daily in the morning. Okay, everything they said, yes, sir. They have not skipped ATT for the past 50 days, and they are not splitting the drugs. They are giving as a single dose in the morning, and the child is not vomiting the drugs after taking ATT. So what is that? Compliance is good. Regimen, yes, the child is on correct regimen with the 2P and 2E. Yes, the child is on appropriate regimen. It was confirmed by us personally. Is this a non-response TB or non-TB? Yes, this is likely to be TB, even though we don't have any microbiological evidence. Hilar adenopathy subacute onset, absence of other cultures, contact positivity, MANTO, CB, MANTO, ESR, everything is in favor of a clinically diagnosed tuberculosis. Is the symptoms persistent due to an unaddressed comorbidity or new infection? New infections was literally ruled out. Is it a malignancy? Our total count turned out to be normal. There is no lymphocytosis. And the radiological evidence was more in favor of tuberculous lymphadenopathy rather than a lymphoma, which is usually acute in onset along with a pleural or pericardial effusion, which is not in this case. Is this HIV negative or positive? HIV negative. Is this a paradoxical reaction? In paradoxical reaction, sense of well-being will definitely be there. Even though fever may be there, increasing pleural effusion, increasing the size of adenopathy, or increasing the size of tuberculoma, any other thing we can get in a paradoxical reaction. But there will be a sense of well-being. That is, appetite will improve, whether weight gain improves or not. Fever will improve, and the child should play after starting ATT because of the reduction of the microbiological load. But in this case, the child is neither playful, but not playful, fever persistent. Okay. So definitely this is not a paradoxical reaction. Usually paradoxical reaction occurs after a initial period of improvement. Here we have not seen any improvement either in the radiology or in the symptoms. So this is less likely to be a paradoxical reaction. Is this drug-resistant TB? Since we do not have any microbiological evidence, we need to rely on the fact what the maternal aunt was taking. Okay. So that's why we need to give importance to NICSHI. We need to search the NICSHI code, which is easily possible by each and everyone. We have searched, it is turned out to be rifampicin sensitive, INH yet to come. So this is a case of relatively a drug-resistant, drug-sensitive TB. The contact is taking. INH sensitivity was not yet reported. So we don't know what to do. So this is the NICSHI of the maternal aunt, which shows positivity for Mycobacterium tuberculosis along with rifampicin resistant not detected. So this is a case of clinically diagnosed TB with a contact who is taking drug sensitive regimen. So it is presumed that the child is having drug sensitive TB only, despite having microbiological evidence. So what now? So the only option that is left is whether we need to go for a CT guided biopsy and to look for a microbiological evidence, so that if we take some sample from the node, so that we can see whether it is a rifampicin sensitive, INH sensitive, etc., whether it is really a tuberculosis or not. So before proceeding towards CT guided biopsy, we want to do one thing. So compliance is good. Our diagnosis is relatively correct, even though it is a clinically diagnosed TB. The child is taking the drug, not vomiting, giving everything in a single instant, no comorbids like HIV or any other thing. So what we have done, so we have done our best. This is during the peak of corona epidemic, end of a pandemic, in which none has accepted for doing a CT guided biopsy in this case. No radiologist has accepted. That is particularly during the peak pandemic period of March and April. So we wanted to do one thing. So what is it? Do we need to go do a CT guided biopsy? But literally we had some practical difficulties to do a CT guided biopsy. So before waiting to do a CT guided biopsy, we really wanted to check the drug levels of the child. So what is that? Pharmacokinetic studies with the help of a National Institute of Tuberculosis that is there near our institute. Okay. So we have proceeded with the pharmacokinetic studies, and we discharged the patient on ATT after taking drug levels, blood levels. So we wanted to see whether the patient has been absorbing good amount of INH, rifampicin, pyrazinamide, everything. So what we did, we took blood samples and we wanted to see the level of drug in the blood of the child, so that we can confirm, but there is a minimum inhibitory concentration present in the blood which can inhibit the growth of the Mycobacterium tuberculosis. Okay, what is the result of the study? So look here. So this is the This is the normal therapeutic. This is the normal therapeutic range. Look at this: rifampicin 8 to 24 micrograms per ml, INH 3 to 6 micrograms per ml, pyrazinamide 20 to 50 micrograms per ml. So this is the therapeutic range. Either we need to get either at 2 hours after taking the drug in the morning or 4 hours after taking the drug in the morning. Either very good early absorption, at least very late absorption. We need to have either the drug in the therapeutic range, either at the 2 hours or at the 4 hours. But look here, rifampicin level is 8 to 24 micrograms per ml. That is the minimum inhibitory concentration. Neither my 2-hour nor my 4-hour value of rifampicin is nearing the value of therapeutic range. So failed. Rifampicin is not absorbed. Second, INH. Look at this. INH normal therapeutic range is 3 to 6 micrograms per ml. Here, neither my 2-hour value nor my 4-hour value touches this level. Pyrazinamide 2 neither touches. It is relatively okay. So pyrazinamide 2 or 4-hour value neither touches. So what we did, we had been asking whether the child is suffering from any sort of malabsorption or chronic diarrhea. No such thing. So what we wanted to do, we wanted to increase the dosage of ATT to the acceptable range. So what we did, the child right now on 100 milligram of isoniazid, 150 milligram of pyrazinamide, rifampicin, 300 milligram of pyrazinamide, and 200 milligram of ethambutol. So what we had done in this case, we wanted to give the maximum possible dosage to the child. So what is the maximum possible dosage? Isoniazid 15 mg per kg, rifampicin 20 mg per kg, pyrazinamide 40 mg per kg, and ethambutol 25 mg per kg. So what we had done, so we had increased the dosage of isoniazid from 100 to 150, rifampicin from 150 to 225, pyrazinamide from 300 to 375, ethambutol remains the same. So after taking 1 week of this modified increased regimen, the child started eating well, no fever, and the child started gaining weight too. Okay, the child right now completed 1 month of modified ATT with the increased dosage. So fever settled, appetite improved. So we need to give importance to the therapeutic drug levels of TB2. We have been seeing minimum inhibitory concentration of so many bacterial drugs, chemotherapeutic drugs. Why not we need to consider the same therapy, seeing at the same therapeutic level for a disease in which we are supposed to give drug for about 6 months to 1 year duration based on the site of the tuberculosis. So what are all the factors influence drug level? Malnutrition, HIV, malabsorption, other micronutrient deficiencies, which is not there in this child. So what is the carry home message? Whenever we are dealing with a case of TB which is not responding to our treatment, first point, we need to check whether are we dealing with a TB or not. First point. Second point is the dosage is correct, regimen is correct, whether the child is vomiting or not. Yes, everything is correct. Second point. Third point, is there any other comorbid illness? Even we had seen 2 to 3 cases of associated neuroblastoma, associated Hodgkin's lymphoma while treating microbiologically confirmed tuberculosis. So rule out other comorbid illness. 3. 4. What is that? Drug resistance or drug sensitivity. We are living in an era of no drug, no bug. But sometimes do we really have clinically diagnosed TB also? But at any point of instance, in these cases, better we need to go for a microbiological evidence. So we need to look for a resistance pattern of INH and rifampicin. And what is that paradoxical reaction, which initially we need to have some improvement followed by a form of symptomatic or radiological resolution. So these are all the things that is given in our guidelines. But the one thing that is not given in our guidelines is pharmacokinetic studies. So the purpose of presenting this case scenario is whenever these 5 things are going well, despite your child is not responding to the treatment, think about the drug levels of the ATT in our child. Okay, with this, I am finishing my topic. Thanks a lot. Thanks a lot for the team members of Northeast RESPICON. Thank you. I am finishing my topic. Ma'am, I have completed my topic.
Thank you so much. It was very interesting. I think we've never thought about looking into pharmacokinetics before. I don't know if it is easily available. This, I know it is important to look into this now, we realize, but how, can you tell us, is it possible to do it?
Okay, ma'am. So this is not, even I don't say this is such a common condition, but definitely not an uncommon one. We have around 10 to 14 cases in the past 4 years in which the child had benefited after increasing the dosage of drug levels. So it is available in places where National Institute of Tuberculosis Research Center is placed. So it is there in Chennai. That's why it was possible for us. It is there in Delhi, maybe possible. So if it is not possible, better we need to send the child to the institute asking for the pharmacokinetic studies. Because instead of not knowing the disease and not knowing the cause and continuing the drug, better we need to know what the cause is. So better the child can be shifted to a place where it is available, and so things can be done.
Thank you for the eye-opening talk. I think Dr. Debajit Sharma will have.
Yeah, it's actually quite interesting case. Most of us probably would not have think on that direction. We would have probably done for CT guided biopsy before doing the drug level. So it is quite an eye-opener. But I just wanted to know why the such absorption was so poor in spite of the adequate doses. Of course, it was not in maximum doses. Whether he was taking on any Ayurvedic or any other medicine, if not not the allopathic medicine, if he's taking any other herbals or any other thing which might have hampered it, any drug interactions?
The child is definitely not on any other non-allopathic drugs, only on the drugs given by us, given through the National Tuberculosis NTEP. And it can be due to so many things. We have read in our pharmacology book about the rapid acetylators, slow acetylators. Maybe the child, these people are suffering from, or they may be doing rapid acetylation of INH rifampicin. That might be the reason for which we need to do some genetic
He was not absorbing well all the three ATT. That is quite interesting without any problem with drug interactions. So
we were thinking about any other issues of mucosal issues such as celiac disease or some other thing, whether any history of malabsorption, but there was no clinical evidence of malabsorption in any of our series of cases so far. Maybe the metabolism with which they do with the ATT is definitely different from others who is responding to the current dosage regimen. The thing has yet to be seen, and we need to see really what the cause for this bioavailability too. Yes, these things are still pending. We are working on it. So if we get the cause for poor absorption, definitely we will let you know, sir.
We should know
okay,
about it.
thank you. Quite
Thank you so much.
I think he may need some intestinal biopsy and to look for other malabsorption causes as well. Thank you so much. Very nice presentation.
Thank you. Thanks for the opportunity.
Thank you, Dr. Sarath, and thank you, Dr. Debajit Sharma, sir, and Dr. Account Madam. So it was indeed a paradox. Now for the second talk, I'd like to welcome Dr. Indu Khosla, Madam. She'll be also talking about a very common disease, but yet we sometimes miss it. And to share the session, we have Dr. Rita Panyang, Madam, and Dr. Rasna Das, Madam, to introduce the speaker. Dr. Rita Panyang, Madam, please introduce the speaker.
Yes. Can you hear me?
Yes, Madam.
Good evening, everybody. It's very nice to see you on this virtual platform. It's my pleasure to introduce to Dr. Indu Khosla, Madam. Madam will going to present mucociliary disease. Are we missing them? Which is a very interesting one. Indu Khosla, Madam, is a fellow in pediatric pulmonology and consultant pediatrician in Lilavati Hospital and Research Center, NSRCC Hospital for Children, and director in Dr. Indu's Newborn and Children's Center. Her special interest in flexible bronchoscopy, mucociliary disorder, and sleep medicine. Madam is actively involved in many IAP programs and core faculty for ATM, RTI, and under 5 WIS module for IAP. She is also an international advisor to the Congress of International Pediatric Pulmonology. Multiple lectures in national and international conference in her credit. So it will be very interesting topic. So I think all the participants is eager to listen from Madam. Thank you.
Thank you so much, Dr. Rita. Am I audible? And are my slides visible?
Yes, yes, madam. Yes.
Okay. You know, as a child, I lived in Shillong. My father was posted. He was the scientist at the Atomic Research Center, and we were posted in Shillong. And I've spent a couple of years of my early childhood in Shillong. And I do have some memories of the place. And next time, I think if Northeastern Zone has a conference, I would like to actually come there physically to revive my old memories. I just love your place, and I'm very, very happy to be a part of RESPICON.
You're welcome.
Certainly, madam. Certainly.
Okay. So I'm going to talk about mucociliary disorders. Are we missing them? And I'm going to illustrate this by showing you multiple cases. When I show you multiple cases, what I'm trying to achieve is I'm trying to show you different ways that they can present. And I would keep in mind the fact that all of us may not have all possible investigative facilities with us. And sometimes that could be a deterrent, but still we should think of it clinically and that how we can take this forward. So 4-month-old, this is a child who presented to me with persistent cough, fever since the age of 2 months. He had loose stools on and off since the 2nd week of life. And he was treated with antibiotics, nebulization. He also required oxygenation, but he had a poor response and he was persistently coughing since 2 months. It was a normal delivery, and there was no history of delayed passing of meconium. There was no any perinatal events or neonatal events for this child. Incidentally, he was born in a corporate hospital where they did a normal neonatal screening, and immunoreactive trypsinogen was negative. On examination, he was clearly failing to thrive. There was no cyanosis or clubbing, but he had bilateral chest signs. There was Krebs, and all his other systems were normal. And this was what his X-ray was. So it was pretty a nondescript X-ray, but one could definitely appreciate that there was some amount of air trapping and there was bilateral reticular shadows, which was seen bilateral. So it was something which was an extensive, if at all, there was an extensive problem, and it was involving both the lungs. We did an ABG serum electrolytes, which was normal, and country of TB. We have heard Dr. Sarath Balaji and Dr. Varinder Singh speak on TB. So this child, we had done a MANTU. We did a gastric lavage for CB-NAT and AFP, which was negative. We also did a stool for fat, which was negative. We tried for sweat chlorides, and the sweat could not be collected because he was just 4 months old. We looked at tests for immunodeficiency. We do a blank, and hence we send genetic tests for, which is called the respiratory clinical exome, which covers cystic fibrosis, primary immunodeficiency, and PCD mutation that was sent. In the meantime, we planned a CT scan and bronchoscopy. Now, a bronchoscopy showed us copious purulent mucoid secretions. There was no other anatomical defect. We sent what we got for culture sensitivity as well as for CB-NAT and AFP. There was no lipid-laden macrophages to suggest any reflux, and the culture grew Pseudomonas with a significant colony count. So this was a CT. There was no evidence of bronchiectasis, but it was just reported as bronchial wall thickening. So you must remember that very early on, children who may have any problem like this may not show bronchiectasis. So think of cystic fibrosis if you have persistent cough in infancy, especially if you have persistent wet cough in infancy. And if you grow a signature bug like Pseudomonas, even in the absence of any sophisticated test, this is most likely to be cystic fibrosis. So, and in this child, the immunoreactive trypsinogen was negative. The immunoreactive trypsinogen, as we all know, is a good screening test, and it basically is a marker of pancreatic dysfunction, where trypsinogen, leaves the pancreas and gets into the bloodstream. And this test comes positive in the first 2 months of life, and then it generally becomes negative because of then the blocking of the pancreatic ducts. It is positive in only 80% of patients. So even if this is negative, it does not rule out cystic fibrosis. There was no evidence of metabolic alkalosis, or even there was no fat in stool. This can also be negative because early on in the manifestation, the child's oral consumption there is not much of fat in the diet, so the stool for fat can be absent. And metabolic alkalosis is basically a marker of loss of sodium and chlorides that results in secondary alkalosis, which may be absent very early on. So the take-home message is, even if your screening tests are negative and you grow up a bug like Pseudomonas, you need to consider cystic fibrosis. We did a CFTR mutation study, which finally concluded the diagnosis of cystic fibrosis. So here is a flow chart which I've taken from Dr. Cabra's article. It says if you have sweat test facility available and you do it and you get a sweat test which is more than 60 milliequivalents per liter, it clenches your diagnosis. You need to repeat it and then you need to treat it as CF. If it is between 40 to 60 milliequivalents, again, you need to repeat it and then try to get a mutational analysis. Less than 40 generally does not suggest cystic fibrosis. But most of us, even in a city like Mumbai, we are just setting up a sweat test facility at the center where I work. Most of these facilities, this sweat test is not available. But if you have an acid-base imbalance which shows and electrolyte imbalance which shows hyponatremia, hypochloremia, hypokalemia with metabolic alkalosis, and you get stool for fat globulins which are positive, and if you grow a bug like Pseudomonas, please consider this as cystic fibrosis. Okay, so, and you must start treating these children even before you can confirm. Genetic tests will come of great use in most of these cases. So you treat it as suspected CF, start at least empirical enzyme replacement, start the vitamins and start chest physiotherapy. This alone will make a lot of difference to this child. Let me take you through another case. 8-year-old, this child came with recurrent rhinorrhea from early childhood. He had multiple episodes of otitis media, lower respiratory tract infections, all of them were with fever from early infancy. There was no family history of atopy, asthma, or any recurrent infections. The only significant history was that he was a preterm 32-weeker, 1.6 kg, but he was managed with just basic supportive care. He was weighing 17 kg and his height and weight were both on the 3rd percentile. He had adenoid faces, no clubbing, no cyanosis. He had persistent rhinorrhea, no polyps, and chest showed some signs. So clinical diagnosis at that point was what was made was an allergic rhinitis with asthma, and he was treated with inhalers, nasal corticosteroids for suspected allergic rhinitis and asthma. Unfortunately, he was not better. Since he was 8 years old, a spirometry was done, and lo and behold, the spirometry did not show any obstructive disease or it did not show post-bronchodilator reversibility. Then this child was worked up. CBC, immunoglobulin, sweat chloride, and a genetic test for CF were all negative. ABG and serum electrolytes was normal, and sputum did not grow anything. So we were just wondering what we were having. And then at that point of time, we were doing this electron microscopic study at Mumbai, and we did a nasal brush biopsy. And it showed that all the cilia that were available were markedly distorted, and only a rare cilium could be seen with discernible dynamics. And then we did a CT, which showed evidence of bronchiectasis, and so a diagnosis of primary ciliary dyskinesia was confirmed. We had another, this was a child which I saw just about 3 months back, 12-month-old, consanguineous marriage, recurrent LRTI. Started with every time with cough, with fever. Mom complained that my child's chest is always rattly. There were no infections, no other infections, no diarrhea. And this child was admitted multiple times. This was diagnosed as bronchiolitis or a wheezy child, admitted, nebulized, given antibiotics. Child used to get better, but they used to go back. About 5 admissions this child had. And was a normal delivery, but on day 3 of life was tachypneic and was treated with CPAP. So this is the history that the child came to me with. She came to me with at the age of 12 months. She was well grown, 10.5 kg, no cyanosis, no clubbing. Chest signs were there, bilateral crepes, other systems were normal. She had already received a treatment with anti-reflux treatment, but mom says there was no improvement. And these were the investigations they had already done before they came to me. So hemogram, basic CBC, electrolytes, ABG was normal. They had done a CT scan, we did not show anything. They had done an immunology workup, ABG, everything was normal. We did a bronchoscopy and BAL. We didn't get visor. We couldn't get any purulent secretions there. BAL did not grow anything. And therefore, we sent a genetic test for a respiratory clinical exome. And lo and behold, we got the CCNO gene mutation, which is pathognomonic for PCD. And this child was also been diagnosed as primary ciliary dyskinesia. So my dear friends, we see many such children in our OPD. We need to identify them and pick them up. Given our population, I'm very, very sure we have a lot of children with PCD and cystic fibrosis. So when should you suspect PCD? So if you have a child who's born with a dextrocardia and has a pneumonia at birth or has respiratory distress at birth, this is especially if it's a full-term child. Think of PCD. We know of Cartagener syndrome, dextrocardia, bronchiectasis, and sinusitis, bronchiectasis and sinusitis may take time to develop. So if you have a child with dextrocardia at birth and he has respiratory distress, please keep your eyes and ears open that you may be having a ciliary dyskinesia on hand. So any children who come with recurrent respiratory infections, generally requiring antibiotics, who have headache because of sinusitis, who may have ear infections, and an X-ray which may be showing evidence of bronchiectasis or pansinusitis, please consider PCD. In adults, you may have infertility. So these males especially will have these spermatozoa where the tails will not be functional, and therefore these people will have infertility. An adult with chronic lung disease, an adult who's deaf, has ear abnormalities, you need to think of PCD. Let me take you back to some basics. So disorders of mucociliary clearance could be either congenital like PCD, CF, Young syndrome, which is an adult with bronchiectasis and infertility, and we have some syndromic ciliopathies, or it could be acquired like chronic bronchitis, protracted bacterial bronchitis. Asthma also can give rise to dysfunction of the cilia, which may be temporary, and when you control the asthma, it gets better. And smoker's lung in adults. We definitely know that in the last 5 to 6 months or 8 months that we have been indoors, where there's hardly any pollution, children are doing well, and probably the cilia are also functioning very well. So is it important to pick them up early? Are we missing our ciliary dyskinesias? Yeah, is it rare? So the prevalence has been described as 1 in 4,000 to 1 in 40,000, and probably the true prevalence is something like 1 in 10,000 and more where there are consanguineous marriages. Yes, we are missing our diagnosis, because there was this study which was published in 2011 that 70% of the patients had seen the physician at least more than 50 times before being diagnosed. So the first child that I described with PCD who came to, we thought of allergic rhinitis and asthma. I had seen him multiple times before we thought of PCD. The median age for diagnosis is something like 5.3 years. And even if there is situs inversus like dextrocardia and situs inversus, even there, the median age for diagnosis was 3.5 years. So definitely, I think we are missing our PCDs. What about CF? Are we missing them? So they say it's a Western disease. So Caucasians, the incidence is 1 in 2,500. African Americans, 1 in 15,000. Orientals, 1 in 90,000. India is a global village. We know immigrants in the UK, the Indian immigrants, their incidence has been described as 1 in 10,000 to 12,000. When then the US, it's described 1 in 40,000. So what is our incidence? So our population of 1.3 billion, birth rate of 20 per 1,000 per year, total birth per annum of babies is, I'm very bad in math, so you can count this, it probably is 26 crores or lakhs, I think, crores, I think, yeah. So new CF children per annum. So if you look at the CF, 1 in 2,500, if we take as the frequency as you talk in the West, we'll have 10,400 children born. And if we take our incidence as 1 in 40,000, 650. So at least 650 children or maybe 1,000 odd children of CF are being born in our country every year. And majority are not diagnosed and do not receive proper treatment. So if you look at our airways, they're lined by ciliated epithelial cells, and there is something called as an airway surface layer, which contains of the mucus layer, which is the yellow thing that you see, and you see the periciliary layer. Together they clear the airways. So whenever they are the ones which keep our lung defenses good, and they keep our lungs sterile. We have other barriers as well, but this mucociliary clearance is the most important requirement to keep our respiratory tract clear of viruses, bacteria. So whenever a virus or a bacteria enters our system, this mucociliary start functioning, and they kind of propel the mucus along with the bacteria into upwards in a cephalad direction, which goes into our oral cavity or maybe up or near the pharynx, and we digest it, and then it gets passed off. So this is a cut section of the cilia. You have a pair of central microtubules and 9 pairs of peripheral microtubules. You can see the outer and the inner dynenarm which help the cilia work. And these kind of cilia, and there are these nexine arms which keep this integrity or the structure intact. So the microtubules stay in a circle and you have a central microtubule. All this is required to maintain the structure of the cilia and the function of the cilia. Cilia line our large airways, paranasal sinuses, middle ear, posterior nose. It also lines the ependymal lining of the brain, fallopian tubes, spermatozoal flagella. So if you have a ciliary malfunction, all these organs can get affected. I don't know if you can see it, but here is how the cilia function. They flip back and they flip forward. They remove the mucus and the trapped bacteria and the particles which may be trapped and move it cephalad so that it can be passed on to the GI tract and digested. So cilia have motile function, but they also have sensory non-motile function, which are sensory cilia, and nodal cilia, which are responsible for organ laterality and messenger function of eye bone and eyes and the bone. We have about 200 cilia per cell, and they beat in a coordinated fashion at the rate of 1500 to 2000 beats per minute. And as I told you, they move the secretions cephalad, which can be swallowed, and it can get altered with exposure to pollution, age, sex, posture, sleep, alter the mucociliary function. And this is the emerging class of ciliopathies where cilia which are defective are associated with these disorders. Now coming to cystic fibrosis, we have the CFTR gene, which codes for the CFTR protein. And this is a protein which is responsible for transport of sodium and chlorides across the cell membrane. So it is like this is the CFTR protein which sits on the cell membrane like a gatekeeper. It opens the gate to allow the sodium and chloride, mainly the chloride, to go out, and sodium follows. And with that follows water. And then if all that functions properly, this mucus which is formed is not thick. But if this gate does not function well, the mucus which is formed here is very, very thick, and it blocks the respiratory tract, blocks the pancreas, blocks the intestine, causing the defect of cystic fibrosis. Now, let me take you through very small couple of more cases to elicit what are the different manifestations and when you should be alerted that you probably have a mucociliary disorder. Now, this was a 2-day-old healthy term baby who came with abdominal distension, bilious vomiting, and this child had not passed through. Obviously, when a newborn who comes like this, you have a differential of imperforate anus, whether there are some GI malformations like atresia, webs, bands, volvulus, Hirschsprung's disease, whether there was a small left hemicolon seen with infants of diabetic mothers, or a meconium mitis. So this was an X-ray. X-ray did not show any air fluid levels, but of course there were dilated bowel loops. In a newborn, in a small baby, you cannot differentiate between the small bowel and the large bowel. So they were clearly dilated bowel loops. And the anus was patent, but the mucus meconium was not passed. So clearly this we are dealing with a case of, and so we did a contrast study. You can see we have done an enema. This is the colon looks small, and then you can see air bubbles trapped in all this probably meconium, which is entrapped. So this was a child with meconium ileus. So meconium ileus, 10 to 15% of all CF have meconium ileus, but if you have a child with meconium ileus, 90% of them will have CF. So if you have a meconium ileus in a newborn, please think of CF. Antenatal diagnosis is possible in them because you see a hyperechogenic bowel, and you will also see might see calcification in the peritoneum in a child whom you suspect who may have a meconium ileus or a meconium peritonitis. You can treat it with gastrographin, which also relieves the microcolon, or some patients who are bad may require surgical intervention. So in a newborn, when should you think of CF? So if you have meconium ileus, as I already said, persistent jaundice, cholestasis, think of CF as one of the causes, recurrent respiratory infections, any evidence of pancreatic insufficiency, and any vitamin deficiency. Because if your pancreas doesn't work, all your fat-soluble vitamins will not be absorbed. So you will have hypoalbuminemia, acrodermatitis, hemolytic anemia. So when you have any of these, think of CF. We had a 2-year-old who had frequent, bulky, foul-smelling stools since early infancy. Mom said the stools are difficult to wash and was admitted with dehydration with diarrhea, and both during the summer months. Also, the child had recurrent wet cough. Mom says, my child eats well, but does not gain weight. So it's clearly failing to thrive. 8.5 kg, was clubbed grade 1, and had respiratory signs. No, so in infants, again, when should you think of CF? Failure to thrive, chronic recurrent bronchitis or bronchiolitis, rectal prolapse, do not forget CF, heat prostration and hyponatremia, because they anyway losing sodium and chlorides, and in the summer months they do not intake good amount of salt, you can have heat exhaustion and hyponatremia as a presenting feature. And you may have children who have only GI manifestation, and they get only worse in the summer months. You may have bleeding diastasis because of deficiency of fat soluble vitamins, especially vitamin K. You can have hyperproteinemia, and these children will be salty to kiss. 3-year-old, fever, breathlessness is 3 days, tachypneic, respiratory distress, Krebs, clinical diagnosis, pneumonia, X-ray taken, confirmed, right-sided pneumonia. Mom pulls out another X-ray. She said this was 3 months back. That time also you had a pneumonia. So what you see here, pneumonia in another row. So, and this again, past records pulled up, had diarrhea as well. So when you have a recurrent pneumonia, and this child has something like a pseudo-Bartter syndrome. When you have a Bartter syndrome, your urinary chloride is high. In these children, it's called pseudo-Bartters because the urinary chloride is not high, but they're losing their sodium and potassium and chloride through the sweat. So you'll have hyponatremia, hypokalemia, hypochloremia, and there will be metabolic alkalosis. So pseudo-Bartter syndrome with pneumonia, please think of CF. So to summarize, pulmonary chronic recurrent wet cough. Wet cough is important. Persistent wet cough, always think of CF. In an infant, if you have a persistent wet cough, it is going to be CF and nothing else. Difficult asthma, unexplained hemoptysis. Very, very rarely we have hemoptysis in children. But if you have hemoptysis, think CF. Nasal polyps, chronic sinusitis, GI manifestations, meconium or plug, which are highlighted, which can be diagnosed antenatally. Greasy, bulky, offensive stools, rectal prolapse, persistent neonatal hepatitis, hypoproteinemia, anemia, edema with ascites. Please think of CF. Pseudobarters, heat exhaustion, infertility in males, absence of vas difference, salty kiss, a sibling with CF, delayed puberty, short stature. Please think of CF. Recently, I did a CF workshop at Mumbai, and I had a 33-year-old call me up because I was enrolling parents. It was a workshop for parents. And this 33-year-old called me. I asked her, what is your child's name? She says, Doc, no, I have got CF and I've just been diagnosed 6 months back. So they can present at any time because the phenotypic variability may be huge. Delayed diagnosis, if you have only GI manifestation with no respiratory symptoms. Asian population, we think it's a Caucasian disease. The answer is no, I've showed you the incidence. Less severe phenotype, you might just completely miss it. A false negative or a negative sweat test, you may miss it. For diagnosing PCD, there is something new which has come up, which is called the Pickadar score, which is the primary ciliary dyskinesia root. This is a validated clinical tool, and I wish that you should use this tool when you're suspecting PCD. So it is a simple, cost-effective score which has been validated for clinical settings. And if you have a score of more than 10, there's a 90% probability that this is PCD. Between 6 to 9, there's a more than 11% probability that this is PCD. But if it is less than 5, there's only a 3% chance that this is PCD. So if you have a child with a score of more than 6, you need to think of PCD. And how does this score grow? You can take a picture of this slide if you wish. So the first question that you need to ask is, does your patient have a daily wet cough that started early in childhood? So again, I want to tell you, wet cough starting early in childhood is one of your key manifestations of mucociliary disorders. If the answer to this is yes, please go ahead with the scoring. Okay, then only complete the score. If it is no, please stop it. This child probably does not have mucociliary disorders. Okay, so then answer is yes. Was the patient born preterm or full term? You score 2 if it was a term baby. Did the patient experience chest symptoms in the neonatal period? If the answer is yes, you will score 2. Was the patient admitted in an NICU? Score is 2. Did the patient have a situs abnormality? Score is 4. Does the patient have a congenital heart disease? Score is 2. Does the patient have persistent perineal rhinitis? A baby who comes with continuous runny nose. The score, yes, you think of PCD, the score is 1. And does the patient have any ear symptoms? Then the score is 1. This totals to 14. And if you have more than 6, please think of PCD. Okay. Other tests, of course, this is a screening score, then you need to do other tests, but depends on the availability of facilities and the expertise. The screening test is a nasal NO, and there are a list of tests that which you need to do to confirm the diagnosis. But mind you, genetic tests are going to help us a long way today, right? So what I would like to conclude by saying, it is uncommon. I'm not saying that you're going to see many cases, but it is also under-recognized. So there are more cases than you imagine that they are there. Suspect if you have a given clinical phenotype, which I've highlighted both for PCD and cystic fibrosis. You start treatment if you have a strong clinical suspicion. Look for other clinical and biochemical markers in the absence of screening tests, and genetic test is a great tool today to aid diagnosis. It is available to one and all. Thank you very much, and I would be happy to answer any questions.
Thank you, Dr. Indu. I think it was a very interesting talk. And I think it's an eye-opener of a talk, because most of the time, when we have these recurrent coughs and pneumonias coming, perhaps even now we don't think of ciliary disorders. And beyond foreign body, migrating foreign bodies and other primary immune deficiencies, I think this is one of the important differential diagnosis that we should have. So if there are any questions, we can take it up.
One question is there, ma'am. One question is there. It's a, can CF present only with features of SAM without respiratory symptoms?
Yes, it can present with only GI symptoms. In fact, I've had a child who got admitted with me only in over 2 seasons of summer seasons with only diarrhea and dehydration, had hyponatremia. So we thought it's a normal hyponatremic dehydration which a child could have. And only when the child got admitted the second time, we thought, why is the child coming in the summer months with simply diarrhea and nothing else? And then we took the history, and that child had offensive greasy stools, and that's how we diagnosed that child as CF. So it is very common, can come with only GI manifestations.
Madam, one question. What is the youngest patient of PCD that you have seen? Because 8 years back, I had a child who was around 6 months with recurrent severe wheezing. The X-ray was mostly normal. There was no fever, no contact history. So I didn't have this. I wish I had heard this talk around 10 years back. So what is the youngest?
It's never late.
What is the youngest child that you have seen with PCD?
Okay, so you can diagnose PCD at the age of 3 months. And while I was working in UK, where I was working in a PCD clinic, and I saw they had diagnosed a child at 3 months with PCD. Okay, if you have situs inversus, you can detect it at birth. So if you have a child with situs inversus and it comes to you, suppose a full-term baby, and he develops respiratory distress, you can actually suspect it at birth and send a genetic study, and probably you will clinch it. So because it's a genetic disorder, it is going to manifest very early in life. You can definitely pick it up even at birth if you have specific clinical phenotypes. Okay, and if you don't have, see, we all do not have nasal NO. We only few centers in the country, in Delhi and one with Dr. Anthony in Coimbatore, are doing nasal NO, right? So even in the absence of those tests, in a given clinical phenotype that I have mentioned, go ahead and do genetic tests. It will really help you. Apply the Picadar score. That's why I brought up that score. Right. So apply the Picadar score, do a genetic test. You will suspect rightfully. And when in doubt, start treatment, because the more you delay treatment, they're going to damage their lungs. So start their physiotherapy. And if it's a CF, start with vitamin supplements, start with pancreatic enzyme replacement till you finally clinch the diagnosis.
Thank you so much.
So Indu, there's a very interesting question in the chat box, question and answer box. How come these patients with PCD, they also have dextrocardia or situs inversus? Like, what is the relation?
Yeah, so I just ran through that slide and somebody caught me that I didn't speak on that slide. So you have cilia which have motile function, and you have cilia which have sensory function and non-motile transport function. So when in the fetal stage, when the baby is being developed, these cilia actually help the embryogenesis by turning, right? And it's the cilia which kind of cause the moment of turning while the embryogenesis is occurring. So if your cilia are malfunctioning, that proper rotation and embryogenesis does not occur, and therefore you have dextrocardia and situs inversus, or dextrocardia with heterotaxy with polysplenia syndrome. That is the reason might occur. So it is the non-motile cilia which are not functioning in utero which are causing this.
So my last question to you, Indu. These enzyme replacement and all are easily available in India?
Yes, yes. So enzyme replacement, basically, what you need to replace is you need to replace all pancreas produces all your enzymes which digest your proteins, your fats, your carbohydrates. But what happens in these children, because of the plugging of the pancreas, there is majorly a fat malabsorption. There is some amount of protein malabsorption also, but majorly a fat malabsorption. So since there is malabsorption, you have to give enzymes from outside. So what you need to give is lipase. Basically, what the enzyme preparation what are available, you have to give lipase unit. So it comes as 10,000 lipase units and 25,000 lipase units. And there is dose specified for infants and older children. And it is also specified on the amount, on the weight of the child and the amount of meal they're taking. It is very freely available. One of the brands that is the pioneer is Creon, which is by Sun Pharma. But you have many other brands available now, Enzar, HS. So this is the key for managing cystic fibrosis. So you give the enzyme replacement so the child can absorb the fat and can absorb the vitamin, and then you give vitamins so the child can absorb the vitamins. Once you improve the nutrition of the child, this child will get less infections. And again, to persist that you have less infection, you have to do chest physiotherapy. So chest physiotherapy, nutritional enzyme PERT, that is called pancreatic enzyme replacement, improving the child's nutrition by giving extra fat, extra protein in the diet. This is the pillar of treatment. There are many other things, but this is the key pillar. You improve the child's nutrition, you are going to improve the child's longevity.
Great. So what about the PCDs? Do you have to give any specific other treatment?
Okay. So there is a little gray area about PCDs. So just like in cystic fibrosis like bronchiectasis, we have a lot of literature and lot of guidelines which are there. Unfortunately, in PCD, it is still quite gray. But the key again there is physiotherapy. So because the cilia are not functioning, they're not going to throw off the contaminated mucus which is getting collected. So the key there is physiotherapy. And when you do a physiotherapy and of course if the child is infected, you collect the sputum, do a microbiology, and you see which is the bug, and you give specific antibiotics. So you have to treat with antibiotics aggressively based on what you grow in culture. Okay, and you have to give it for a longer duration of time, 10 to 14 days. So your decision to start antibiotics in both these diseases should be very little easier. You have to really look at the deterioration of the child. If the cough worsens, if the child gets fever, then you need to start antibiotics, aggressive antibiotics at the earliest. You must do a culture sensitivity, and based on that you need to start, and chest physiotherapy. So like in cystic fibrosis, we know Pseudomonas is a bug, staph is a bug, MRSA is a bug. In flu vaccine, the pneumococcal vaccine, all these things you will do for these children. So mainly chest physiotherapy. You will need an ENT evaluation for ear. So it is a multidisciplinary thing. At SRCC hospital where I work, we have now set up a CF clinic where we have a multidisciplinary team which sits with these children. We follow them up with lung function, follow them up with regular cultures from this thing, look at diet, nutrition, everything all together under one roof.
There are some more questions. I think you will answer that. We may type the answers there, and we will close the session here. Thank you so much, Indu, and thank you, Partha and Mrityunjada, for giving us the opportunity to chair. Rita, if you want to say something.
I just want to say one more thing to Partha. While you all, I like the interest in people on the sleep lecture of Dr. Bharat. So with IAP, we have made a module called NAPS, which is just training pediatricians, and we had run it on the DIP platform. So if Northeastern Zone wants us to run that NAPS program, we can write to Central IAP and we will do it for you.
Definitely. We want it, madam.
Thank you.
Wonderful, ma'am.
Thank you so much.
Wonderful. Thank you, Partha. Thank you all.
Over to you, Partha.
Yeah, thank you, Dr. Indu Khosla, ma'am, for the wonderful insight into the mucociliary diseases. Now I would like to welcome our Rahul Dravid, Dr. Subramaniam NK sir, our most respected Subbu sir, for his talk. And to share the session, we have Dr. Kutubur and Dr. Manav Narayan Barua, sir. Please. Manavda, you can introduce Subramaniam, sir. Yeah, Kutubur, please go ahead.
Okay. Okay. Hello.
Yes, Kutubur.
Am I audible?
Yes.
Okay.
Yeah,
So
yeah.
good evening, everyone. Good evening, everyone. So the current session is, the topic is recurrent lower respiratory infection presenting with wheeze, which is very common and very important also. This will be presented by Dr. Subramania N.K. sir, and currently he is working as a professor of pediatrics in Bidehi Institute of Medical Sciences in Bangalore. Sir is holding as honorary secretary IAP National Respiratory Chapter currently, and he held different positions in IAP, like he was a conference secretariat in RESPICON 2017. He was the joint organizing secretary in 2009, that is in Bangalore, and he is the Central IAP Executive Body member in 2020 as well as in 2013 also. He is very academic. He shared many scientific sessions, organized many workshops and conferences, and he is the resource person for many modules that is prepared by the Indian Academy of Pediatrics. Like he was the editor-in-chief in IAP teaching module for undergraduates, that is in 2011 and 2015, and for postgraduate it was in 2018. And sir is already awarded by Indian Academy of Pediatrics as base secretary, and his special interest is in pediatric pulmonology. With these few words, I would like to request sir to start his session. Thank you.
Good, sir. Thank you very much. And Manab sir, let me congratulate Indu Khosla, one of our pillars in respiratory chapter, for setting up the tone for pulmonology spread in Northeast. And anyway, today morning we have done the sessions of, we have had a 3 hours workshop on pneumonia. So therefore, all of you are very much familiar. Bear with me for 20 more minutes. You have tolerated me for 3 hours. It won't be very difficult for you. I would make it as entertaining as possible and as brief as possible. Maybe in 15 minutes, let me cover the wheeze with lower respiratory tract infections for you. I hope that the screen is visible. I'm just checking. Fine?
Yes, sir.
Okay, fine.
Yeah.
So
yes, sir,
basically
visible.
referring to 3 components here. One, the child has got wheeze, and second, the wheeze is recurrent, and the wheeze is associated with lower respiratory tract infections. So these are the 3 things which have been given to me as a topic by Dr. Partha. I think he wanted to put me in fix simply because, this is the very gray area to decide what to do for this wheeze. Some of them are younger, some of them are older. So therefore, when we refer to wheeze in this category, basically recurrent wheeze with lower respiratory tract infections, we need to understand whether it is genuinely a lower respiratory tract infection causing the wheeze, or is it that the child has some airway obstruction, and respiratory tract infection will unmask and present as a wheeze at the time of flare-up. I would just explain to you. Let's say there is an obstruction in the nose. When the child becomes, and this obstruction is subtotal and and subclinical, it becomes symptomatic during colds. Did you understand what I'm trying to refer to you? So therefore, dear friends, please understand that lower respiratory tract infection with wheeze could be an actual diagnosis, or it could be a presenting phase when a disease has to be still uncovered. So I will take you through the journey of both, and I will tell you how to do it in your office practice. That's most important. Let me just start with the first rider. that is bronchiolitis. See, you have bronchiolitis as the most common cause of wheezing in young. And the question which I have for the audience is, how many of you say that the bronchiolitis can recur? Please type in the chat box. Yes, can it recur? It will not recur. Please type in the chat box. I wanted to just know. Just I wanted to know from you. Somebody said, yes, it can recur. No, no, yes, no, yes, no, yes. So you are divided. Divided house. Yes, it can recur. So I think what you are seeing is actually maybe may or may not be a true recurrence. What I wanted to tell is both of you are correct. When it actually to be true, a bronchiolitis by definition is an acute wheeze and it should not recur. Did you understand? Because the airways grow with time, and bronchiolitis by definition is cut off by 2 years. About 2 years, we don't call this as bronchiolitis anymore. This is just a viral associated wheeze with lower respiratory tract infection. So is that clear? So when the bronchiolitis as a syndrome starts recurring, it need not be bronchiolitis. It could be just that it is presenting as bronchiolitis. So therefore, yes, it can recur, provided there are risk factors, and in that case, don't diagnose it as the recurrent bronchiolitis. Please find the cause of recurrence. So I am just coming to a specific point that bronchiolitis as a disease may not recur, but bronchiolitis as a syndromic presentation can recur, and you must please uncover and unearth what is the cause of recurrence of a syndromic presentation of bronchiolitis. I think, am I done? And I will tell you how to uncover this in the subsequent slides. What about the older children above 2 years of age? So bronchiolitis is not defined by RSV infection. Please understand. Bronchiolitis is acute wheezing, predominantly with obstruction than infection, and more commonly in children below 2 years of age. So, and it is predominantly lower respiratory. So is that very clear? Now, if I come to older children, colds in the chest, they do happen 3 years, 2.5 years, 4 years, 5 years, 6 years. Does this recur? It can also recur. But therefore, why it recurs? How does it recur? And what should I do? So all of you just remember one thing, that you see this in your day-to-day practice like anything. Just a child will come with cold, cough, wheeze, cold, cough, wheeze. It keeps seeing you. Many must of you would have given bronchodilators, cough syrups. Some of you must have nebulized. Some of you must have given SOS steroids, SOS 4-5 days of budesonide nebulization, 4-5 days of bronchodilator. Do you all recollect all these cases? So colds in the chest do recur, and I'm coming to you why it recurs. Remember, many viral infections are common in young. Younger they are, more are the viral infections. And as they grow older, the infections become less. And to be very honest, I will tell you, the colds in the nose, we have colds in the chest. Colds in the nose and chest do not present with discharges in very young age. They present with obstructive symptoms. Is nose block common or not? Tell me. Yes or no? Yes. Can a chest block be also common? Because chest is small. When you can see a nose, but you can't see a chest. And I can't show you a chest. And I can't show you the airways. And therefore it is smaller. And as the age grows, it becomes wider. And therefore, you can have recurrent wheeze, yet normal a child. That is my first message. How do I ensure that the child is normal? This recurrent wheeze will not affect the growth of the child. And in between the wheezing episodes of cold, the child is essentially normal. This is the first take-home message, and the most important message. More than 70 to 80% or more than 90% of your practice, this is what you see. Just don't do anything. Keep on symptomatically treating the child. You will be fine. But sir, how should I ensure that this child is normal? You should not assume that this child is normal. You must first rule out the abnormalities, and therefore diagnose that this child is normal in absence of any abnormality. So that takes me to the next question. How should I ensure that this is a recurrent wheeze, a recurrent viral wheeze in a child, but yet a normal child? In that case, the episodes are brief. That means 2 or 3 days or 4 days. They're relatively non-severe. They don't require hospitalization. I'm just telling in general. Did you understand? More or less by symptomatic treatment, they do better. And the illness generally lasts for the duration of definition of illness. Well, how long the viral URTI lasts, you tell me? 2 days of fever, around a week of cough or so. So these kind of presentation you will see. They are brief episodes. And a child will be normal, playful, active, feeding well, growing well in between the episodes. Is that clear? So this is most important. So in that case, should I wait and watch? You should wait and watch for 3 reasons. Most of these children will outgrow. Let me ask the practitioners a question. Suppose you are a busy pediatrician. A mother comes with a child from the beginning to you. Let's say she comes for all the immunizations. Then she comes with cold in the chest. You have given some medicine. She comes again in the next week. And after 15 days, 20 days, 30 days. Suddenly after 2 or 3 years, that mother disappears. Do you remember all this? Honestly, tell me, do you all remember them? So let me stop sharing for a while. Do you remember that this happens in practice? Many of you are busy practicing. Do you remember? They keep coming to you. You know them, you know the family, you know the mother. They keep coming. And suddenly after 1 year or 2 year or 3 year, they start coming less and less frequently to you. And later, after 4 or 5 years, she comes with a second child. Then only she will tell, sir, you remember us. Do you remember me? Now it is the second child. The first child now is fine. The last medicine you gave worked very well. They will tell like that. But it's not the last medicine that worked well. The child has really outgrown the symptoms. So this takes me to a concept. Remember, most of the children are normal. They will do well in practice and they will outgrow the wheezing. The reason why they outgrow the wheezing is simply because the airway caliber improves. There are some known and unknown immunological mechanisms which improve, defenses improve. The epidemiology of the viral diseases also is not as common as that in that. And lastly, I wanted to tell you that many of us will overdiagnose cold in the young. What I meant by that, moment a child has gora gora, we say it's cold. It's not necessary. It is simply because there could be some kind of obstruction that happens more than infection, and many of us will overdiagnose the cold. So I gave, this is the most important part of my talk. So therefore, you can have recurrent viral lower respiratory tract infections or these at normal child. All that you have to do is wait and watch and treat. Number 2, these are the children who are going to be outgrowing the bees definitely by around 5 years. That is the gray area, and you have to somehow see that they enter LKG, UKG or first standard. By then they are fine. So this is the message number 1. And I'll go to a second category, which is not as common as the first category. You have recurrent wheeze, but a child is abnormal. And how do I pick them up? This is when you have to evaluate not the wheeze, but the child. Very, very simple. Look at the growth, look at the weight, whether the child is thriving, eating, how is the child growing. All these questions have to be asked. Then you know that this child is abnormal. And what is the reason for abnormality? The reason for abnormal growth in this child is the cause of wheezing. And just now Indo Khosla was referring to, it could be a ciliary dyskinesia, rare, but it can be there. It could be a cystic fibrosis. It could be an anatomical obstruction, like let's say a vascular ring. It could be abnormal airways. It could be abnormal blocks, malformations, congenital heart diseases, so on and so forth. I don't have time to tell you n number of causes. All that you have to do is you have to keep on asking questions about wheezing, questions about behavior of wheezing, timing of wheezing, duration of wheezing, duration of the episode, aggravating factors, relieving factors, persistence, daytime, nighttime, whether there are associated features of cough, fever, and whether other members have got or only this child has got, age of onset of the wheeze, for example, when it starts, all these questions you have to ask to know if the child is abnormal with the wheeze. So therefore, my dear friends, this is very, very important category. After exclusion of this serious disease only, we are going to tell that child is normal. I'm recapitulating it for you. Associated symptoms, persistent symptoms, but not recurrent symptoms. Isolated wheeze. See, wheeze with cough can be an asthma, but only wheeze cannot be an asthma. So you will have cough because there is airway irritation and inflammation. Multi-system features. Growth will be affected. Clubbing may be there. And beautifully, these are the children who will not respond to bronchodilators predictably. This is the most important. I think all pediatricians, please note down only one thing. Is the wheeze recurrent or persistent? Does it respond to bronchodilator? I think have I made it simple for you in under 5? Just ask these 2 questions. You are going to get these abnormal children out. So if the growth is abnormal, not responding to bronchodilator, either investigate if you have facilities. If you don't have, investigate, refer them. So message number 2 is that sick children with wheeze, evaluate or refer. So it's quite simple. So we used to call in the olden days them as happy wheezers and unhappy wheezers. So now we have happy parents and unhappy parents. When the parents are unhappy with actually a sick child, you must refer them. The third category of the wheeze is recurrent wheezing with respiratory, presents like respiratory tract infection, but fits into an asthma syndrome. What I meant by that, see, you know, you have viral respiratory tract infections which also trigger asthma, isn't it? So therefore, it's very difficult to separate asthmatic wheeze from a viral LRTA presenting as wheeze. The point is that in a viral LRTA, you will have evolution of the disease. That means, let's say on Monday, the child got cold. On Tuesday, the child got fever, and on Wednesday, the child got wheeze. Thursday, Friday, Saturday, the child got nebulized with you, and on the weekend, the child became better. This is not asthma. Please understand. This is an evolution of an upper respiratory tract infection to lower respiratory tract infection. I'll give you a contrasting what is an asthma. Let's say a child comes to your clinic at 5 o'clock. 4 o'clock it has got cold. 5 o'clock it is in your clinic. 6 o'clock you nebulize. 7 o'clock child is fine. Did you understand the dramatic response? Triggered. How do you understand trigger, trigger, trigger? Every mother says even orange triggers. So please understand. So therefore, triggered means as soon as there is an exposure, you will get the symptoms, and dramatically it is relieved by bronchodilator. This history you should take. So therefore, you have asthma, yes and no. And I will tell you, majority of the parents are not happy with the treatment. They'll come and tell you, sir, you gave this syrup, it's not working. You nebulize, how many times I have come to you. If they are frustrated, that means this may not be an asthma. That means it is not responding to bronchodilator well. And you know, you cannot have a wet cough, etc. Did you understand? So most common presentation is no for asthma than yes for asthma in under 5 wheezing. And when there will be answer yes, when you have risk factors like parental history of asthma, atopy in the child, etc. That time you will have. So what is most common is younger they are, no for asthma. Older they are, probably asthma. Is the second message, but simple, but very clear to you, fair enough. Now, therefore, when it is no for asthma, it could be mimic of an asthma. That means it behaves like asthma, but not an asthma. Let's see what they are. So an asthma syndrome, but not an asthma. How do you diagnose them? How do you pick them up? So if you have wheezing that is recurrent from too young an age, it could be vascular, it could be airway compressions, malacia, so on and so forth. Did you understand? When they are too young, when they are too sick, when the episodes are febrile, asthma are typically afebrile episodes, when they are not responding to bronchodilators. So therefore, my dear friends, I'm coming to the second message. It looks simple, but we don't follow it on our practice. All that wheezes may not be an asthma, and you have to evaluate. But this, everybody has this line, but you have to really apply it in practice. Which of those wheezes is not an asthma? So then how to diagnose asthma? You have to demonstrate airway inflammation and obstruction that is reversible and that has an atopic background, preferably. Or an allergic inflammation, which is chronic but presenting with recurrent symptoms, you have to manifest. So therefore, how do you identify them? By recurrent symptoms. Often they are afebrile and they're triggered and they're episodic. So you have episodes with intervals. And in between the episodes, they're often well. And there is family history and relief by bronchodilator or steroids. And in those children, asthma is likely and more likely when they are older. So you have a situation with wheezing with lower respiratory tract infection, yes or no for asthma. I have said so. Sir, you tell me so much when I'm listening to you, it's very easy. But when a patient comes in front of me, it's very difficult. Correct? No, this happens to all of us. Even I have faced. And I can see Ankit seeing he's a renowned pulmonologist. When it goes to Ankit, it could be easy. But when it comes to a general pediatrician like me, it could be very difficult. Do you agree? So yes or no situation come to all of us. And how do I decide now? I have to take a call, isn't it? So I will give you a simple solution. How to diagnose this? You have an obvious asthma. What I meant was that, sir, father is asthmatic, mother is asthmatic. I know the elder sibling is asthmatic. This child has come with recurrent wheeze. Whenever I give nebulizations or whenever I give bronchodilators, this child becomes well. And I have given a couple of times steroids also. He is a frequent visitor. He has atopy also. Fantastic. If it is obvious, just say, don't delay. Go ahead and treat asthma. It's a syndromic diagnosis. Make a diagnosis and treat. The second, you can certainly say, sir, definitely I will tell you, he's coming again and again, but I say he's not asthmatic. Is this also very easy for you? Very easy. Sir, nobody in the parents have got asthma. He doesn't have atopy. No risk factors are there. He is otherwise a fine child, growing well also. And I'm not finding any abnormalities of any atypical wheeze that you have told. Or isolated wheeze that you have told. Fantastic. No for not at all in asthma. This is very easy for you. Now I've taken you to through judgments. One, yes for asthma, go ahead and treat. Not at all asthma, don't treat. Treat symptomatically. But the problem comes in the interval category when you have yes or no. In one visit you thought of an asthma, in the other visit you didn't think of asthma. Did you understand this kind of junk you get in practice? See, you have a family history, you don't have atopy in the child, and you have half of this, half of that. Children won't walk into your textbook, clinics with textbook descriptions, and therefore in these children, what to do? You give trial of inhalation corticosteroids. Very, very simple. And I will tell you, only asthmatics responds to inhalation corticosteroids, not infections. And not other diseases also. You give budesonide 100 microgram twice daily for 3 months. And if the child responds, fantastic. That means, yes, you have high probability of asthma. What to do then? You stop the therapy, don't taper. And if the symptoms come back again, you reintroduce the therapy again and they respond. That means you have double proof. One, he responded, and on stopping the symptoms recurred, and on reintroduction again he is getting better. What does that mean? Steroid responsive airway obstruction. It cannot be anything other than asthma. Very, very simple. Go ahead and start him on long-term medications with inhalation corticosteroid. Did I make this clear to you? Okay. Second is, you have started a trial. Within 2 or 3 weeks, you realize that the child is not responding at all. That means this is not going to respond if you just go on continuing it up to 3 months. Don't wait for 3 months. I will investigate at the end of 3 months. By 5 or 6 weeks only, if he's not responding, in spite of correct technique and proper compliance, in that case, evaluate for differential diagnosis. Look for alternative causes of wheezing. So therefore, it's very easy for you. When in doubt, you give a trial of inhalation corticosteroids. When not in doubt, decide whether it is asthma or no asthma. Now you don't tell me, sir, I can't diagnose in under 5 wheezing. So you have only 3 options. to say yes for asthma, no for asthma, give a trial of ICS. And after giving a trial of ICS, it becomes either an asthma or not an asthma. When not an asthma, either refer or investigate. It's very easy. This is so therefore, no response to trial of ICS. You have to revise your diagnosis. So the children under 5 wheezing are of two categories: high risk for asthma, prolonged colds, more colds, children symptomatic between the episodes, family history or genetics of asthma present. Low risk means normal duration of colds less than 10 days, less frequent colds, child is otherwise playful, no risk factors. Very, very simple. Don't have to get confused. So now you understand when to call an asthma whenever a child presents with recurrent viral lower respiratory tract infections. How should I investigate? I will now mix old and young. When they are older, more than 5 or 6 years, it is easy. Please do pulmonary function test. This will give you objective evidence for asthma. Did you understand? You can do other investigations depending on your history. For example, you may have to do 2D echo for a congenital heart disease, etc. You may have to do a bronchoscopy at times because wheeze is a musical sound. Isolated wheeze, please do bronchoscopy. A sudden onset wheeze, do a bronchoscopy. Recurrent wheeze not responding to bronchodilators. Focal wheeze, local wheeze. Did you understand? A migrating wheeze. And I can give you n number of indications for bronchoscopy. Please find out and peep into the airways and it will help you. Now, how should, sir, it's all right. Now I understood how to make a diagnosis. But in my clinic, whenever a viral lower respiratory tract infection comes, how should I treat? These are last 2 slides of mine. How should I treat at the point of time? There are no controversies for you to use bronchodilators in all. This is well permitted. Whenever the child has episodes, whenever viral, whatever, irrespective of the controversies that exist, please go ahead and give bronchodilator. You have to relieve the child. Nobody says no for this. But whether the bronchodilator is effective or not effective is a different question. You give. Please document the relief. And if it responds well, go ahead and continue to give. And then evaluate the child. Should we give a low dose inhalation corticosteroids when you don't have a diagnosis of an asthma? One you can give as a trial, I have told you. I'm sorry for the spelling mistake. Second one is you have an asthma likely situation and the episodes are more than 3 per year. Asthma unlikely, but the episodes are so frequent that you are tempted to give a low dose ICS. But at all points of time, you must be always humble to revise your diagnosis because this is a heterogeneous spectrum and gray area of recurrent wheezing, especially if they are young. For antibiotics, a big no. Macrolides, please don't overuse. If the wheeze is more than the fever, no antibiotics. If fever more than the wheeze, and wheeze is not a predominant disease, but fever is an important disease, yes, antibiotics. At that time, your diagnosis is not recurrent wheezing, your diagnosis is an infection. Nursery school syndrome, where children with recurrent, going to play school and comes with recurrent colds and chest, wheeze in the chest, they do not respond to bronchodilators, they do not respond to your cough syrup, they do not respond to your antibiotics. Only counseling is the key. Please understand them. There is no treatment. You try all symptomatic means none of them help. What about Montelukast? A big no from my end, for especially without diagnosis of asthma, for routine colds, seasonal colds, prolonged colds, parental pressure, pharmaceutical pressure, and whatever. So Montelukast is not magic Lucast. It does not do any magic. Most of the parents take for 3 or 4 days. If you have Montelukast with levocetirizine, the levocetirizine works, but not the Montelukast for 5 days or 3 days. Did you understand? You may feel, sir, I have given last time Montelukast with levocetirizine, it worked. Do you think which one of them worked is my question. So therefore, my dear friends, it's an irrational combination. So solutions and summary for general pediatricians. When you get a wheeze, look at the wheeze. age of onset of the wheeze, how it recurs, how it behaves, how it responds, and family setting, environment, and look at how is the child growing. And that will give an answer to the cause of recurrence. But don't treat a wheeze, treat the cause of recurrence, and it is very easy. Sometimes you will not have the answer. The answer may be in the pipeline, and assessment at the point of time, assessment over a period of time. Did you understand? Sometimes when you assess over a period of time, pick the ones which are abnormal, which you should not miss and neglect, and evaluate them or refer to pulmonologist. And thank you very much. I've oversimplified under 5 and above 5 wheezing as an approach for you. I do understand lot of analogies I have made, gross oversimplifications I have made for the convenience of general pediatricians, and therefore in a particular case you are the best judge and you take a call. Otherwise this can be a simple algorithm that you can follow in day-to-day practice. And thank you very much.
Thank you, sir. Subramania, sir. It was really such a lucid presentation. And yes, under 5 wheezing is a very common diagnostic as well as treatment dilemma in a day-to-day pediatric office practice. And we have learned from you, sir, that while bronchiolitis is a single episode disease, as far as recurrent under 5 wheezing is concerned, whenever we are faced with a normally growing child, it is usually an episodic viral wheeze. And if the child somehow suffers from some underlying disease, has failure to thrive, has some atypical symptoms, then definitely the child needs extensive investigations to look for some underlying disease. And you have rightly pointed out how and when to suspect asthma in a child, and the fact that younger the child is, less likely it's likely to be an asthma. So sir, we have some questions in the chat box and the question answer box. One is that what would be the characteristics of wheezing in pneumonia? Somebody has asked. And second question is that the role of inhaled corticosteroids in Walroy. So your take on these two questions.
I will again, I will take apologies from Ankit Bhai, who is a pulmonologist. You know, my chota bhai bolta hu. And what I wanted to tell you is that to couple of input, I mean, couple of suggestions. One, as far as pneumonia is considered, wheeze is not a predominant symptom. The sensitivity and specificity, positive predictive value, negative predictive value of wheeze as a symptom and sign of asthma is to the tune of 30%. The sensitivity is just 15 to 30% in studies, and specificity is quite high. It's to the tune of 80%. Suppose you have wheeze in only left lower lobe, you know, more like wheeze and crepitation. Did you understand? Here you don't have isolated wheeze. Wheeze is a part of other symptoms and signs of pneumonia. See, is that clear? When we say recurrent wheezing, we refer to recurrent wheezing as a predominant and the main phase of the presentation is a wheeze. Is that clear? Cough and wheeze. It is not fever and other symptoms. Recurrent fever under evaluation is a different story and ball game altogether. I think I made that point clear as far as pneumonia is concerned. Second is response to steroids. All eosinophilic inflammations of the airways respond to steroids. Response to steroids in neutrophilic inflammations and lymphocytic inflammations, I would say non-eosinophilic inflammation, is unpredictable and variable. And usually it is not there. See, we have blindly given steroids to COVID. And we are expecting some magic results. Did you understand? It's basically neutrophilic or lymphocytic. We are seeing. So therefore it can, but does it help in everyone? Answer is no. But does it help in asthma with eosinophilic asthma, allergic asthma? Answer is 100% yes. Did you understand? So therefore, whenever you have an eosinophilic inflammation or a particular phenotype trait, you will easily recognize those with eosinophilic type of inflammation. These are the children with atopy, allergy, and exposure to dust and multi-trigger wheezing, etc. That's setting. You understand? Neutrophilic means more of infective type. Recurrent infections is the presentation of the wheeze, not recurrent wheeze as a phenotype. I think febrile versus afebrile. Am I just making it a grossly an allergic type versus grossly a non-allergic type? So in those with allergic inflammations, they do respond to inhalation corticosteroids. And corticosteroid is a beautiful antagonist to eosinophil. It's not a very good antagonist to a neutrophilic inflammation. While I understand that corticosteroids are broad spectrum anti-inflammatory drugs, but they are excellent drugs for eosinophilic inflammation. So my answer, let me take for you a rough question. Does steroids help in common cold, non-eosinophilic? No. Allergic rhinitis? Yes. Correct? Okay. Sore throat. Allergic sore throat? Yes. Infective? No. Bronchitis? Allergic? Yes. Non-allergic? No. What about bronchiolitis, neutrophilic inflammation? Answer is no. So a recurrent asthma, isn't it? Yes. Pneumonia, neutrophilic inflammation? Answer is no. Eosinophilic pneumonias and syndromes? Answer is yes. Parasitic, fungal, allergic, aspergillic bronchopulmonary aspergillosis with eosinophilic types, whether it will respond to steroids? Answer may be yes. So I think I've generally given you some idea about when to give and when not to give steroids. I think I've just given you a kind of rough idea. In a specific case, you have to get into that particular disease and find out indications for steroids.
Okay, sir. Thank you. So it's another interesting question, like whether in cities like Delhi and Kolkata, we need to look for particulate matter concentration in cases of recurrent wheeze in children below 5 years. Somebody has asked.
Yeah, recurrent wheezing in below 5 years, environment can be an add-on insult, not a primary insult. Please understand. Environmental lung injury or airway injury is dose dependent. Dose dependent means it depends on the amount of the insult. Second, it depends on duration of exposure, intensity, etc. Please, am I clear? So that means you can't expect an environmental lung injury in a 1-year-old child. How long the airway has been exposed to the environment is my question. Did you understand? So you need a duration, you need a dose of exposure. But is it a risk factor? Answer is yes. I will tell you 2 children are there. One from a polluted city like Delhi or Bangalore, another from a beautiful city like Shillong or Guwahati where there is hardly any pollution. I don't know if Guwahati has pollution or not, but I'm assuming it's not there. So in that case, the chances of risk for pneumonia or infections or even wheezing in children from the cities is more. In fact, there was a beautiful study done by Dr. Parmesh which said that school children in the main roads with houses in the main roads suffer from more wheezing than those from side roads. So which means that environment definitely has an influence, and environmental injury is time bound and dose bound.
Okay, sir. There is another question regarding treatment. Somebody has asked regarding the role of theophylline in wheezing and also the role of theophylline in asthma, IV or IM, it's written.
I think theophylline should be restricted to the use in acute flare-ups in ward or in not an outpatient. As the last drug in category 4 and 5, it is almost given up now. Because you have got better drugs now. The drug with lower safety of margin is almost, I will tell you, it's almost Kapil Dev. You know, it's almost retired now, but we always talk of glory of theophylline in the past. It's now phasing out.
Okay, sir.
I'm not talking of aminophylline infusion in resource poor settings. Suppose you don't have options. Please go ahead.
Okay, sir. So we come. I think there are no other questions, and we are running out of time.
Sorry for interrupting you. No, this one message. See that newer theophylline syrups and bottles that are available for day-to-day practice. Please don't use them.
Okay. Thank you so much. So I think we have come to the end of the session. Thank you so much, Subramania sir. Thank you, Partha, and all the organizers for giving us this opportunity. Thank you all.
Thank you, Dr. Manav and Dr. Kutubur and Dr. Subramaniam sir for these wonderful presentation. Now I welcome Dr. Ankit Parak, sir, for his presentation on imaging in pediatric pulmonology. He will be putting light into the shades of gray, basically, and he'll be giving us insight into the imaging in pediatric pulmonology. To share the session, we have Dr. Shyama Soikia, sir. Please, sir, go ahead.
Evening, faculty and participants of this virtual Northeast RESPICON. I now take the privilege of inviting Dr. Ankit Parak to speak on the subject of imaging in pediatric pulmonology. Before starting the subject, I would like to give a brief biodata of Dr. Ankit, who is MD in pediatrics, DNB, MNAMS. He is European respiratory medicine, ERS Sleep Fellow, GOSH UK, RCPCH Fellow London UK, and many more to his credits. He has to his credit 25 presentations. He also worked in Kalapatra Children's Hospital, New Delhi as assistant professor. May I now request Dr. Ankit Parak to start his.
So thank you very much. And is my screen visible? Am I audible?
Yes.
Yes, you are quite audible and screen is visible.
Yeah. So thank you very much to Partho and Team Northeast RESPICON for inviting me here for this talk on imaging in pediatric pulmonology. So let's start with a question that why do you need it? Well, I'm not a radiologist. The audience is not a radiologist. I'm a pediatrician. The audience is a pediatrician. Then why are we talking about radiology, right? So the question is that to whom the child presents? The child presents to us. Who sends the child for the investigation? Well, we send the child for the investigation, and we obviously manages and follow up the child. But you get a report, then why do you need to know how to read and interpret an X-ray? You have a report with you, or for the matter, a CT or an ultrasound or an MRI. Do you actually need to know? Now, the problems which everyone who practices pediatric pulmonology or pediatrics face is sometimes the radiologist would be describing the findings and there is no clear differential diagnosis. There can be a problem of lost reports. The patient comes just with the films and you have nothing else in hand. The quality of reporting may not be similar at all places. Do we have pediatric radiologists? Well, most centers don't. And at the last, an extremely important issue is clinico-radiological correlation. So I'm not trying to say at any point of time that that we are better than radiologists. Obviously, no. They are 100 times better than us when it comes to radiology. What I'm just trying to talk about is that our knowledge of radiology is extremely important to manage patients with pediatric respiratory problems, right? So all of us who deal with pediatric respiratory patients do need to know. And during this talk, I'm not trying to focus upon core radiology issues, right? It can be a 1 day or a 2 day workshop. So the aim is that I've picked out some cases from our archives, and I'm just trying to focus upon the need to know radiology and what it means to us. So for a clinician, an X-ray doesn't mean anything unless until I have the child with me. the history, the clinical examination, and the course. So that is the what we want to do in the next 25 minutes. So let's start with this case. And as I said, X-rays don't carry a meaning for a clinician unless until you have a clinical background there. So this is a 12 years old girl who has off and on fever for the past 2 to 3 months. Now the girl is afebrile, there's no anorexia, weight loss, no contact with TB. And now the Mantoux, which has been done, the Mantoux is 18 by 20 mm. So the question is that what is the finding in the X-ray, and what are you going to do? I know radiology is always an interactive session, and it will be a bit difficult here. So I'll just give you 5 seconds, look at this X-ray and comment. So interpret the X-ray in the context of clinical findings. So a long-standing fever in an older child, a Mantoux which is positive. Do you think there's a left hilar node? And do you think there's a left upper lobe lesion? So a pical lesion in this context makes it TB. Now, how many of you will start this child on anti-tubercular? Obviously, I do understand that you will get sputums for a smear and a gene expert and so on, but do you feel this is TB and will you work it on? Okay. Have a close look at this. So the left apex is definitely showing a lesion. The right is clear. Okay. And we get an X-ray after 5 minutes and the lesion has disappeared. So if you look at this X-ray, then there's no lesion, and this X-ray had the lesion. Now, how did this happen? So if you look at this X-ray carefully, this shadow is actually extending, out of the thorax. So if you realize this is a girl child and this is a hair braid which was there, and this happens a lot of time to us. This just happened a few days back. There was a shadow extending in the parasternal area and extending down up to the diaphragm. And someone got a CT and the CT was normal. And if you look at the X-ray, you realize it was actually a hair braid which everyone was trying to treat. So the first rule is that you need to know what you're looking at. Be careful about X-rays, and all these things can happen. So artifactual things can lead to a lot of misleads and a lot of errors in diagnosis. So you had some finding on the X-ray, but the X-ray was normal. And unless until we are careful about these things, we're going to miss findings, right? Now, let's look at this child. A 1-year-old boy has cough and noisy breathing for a month, right? No significant fever, got admitted 3 times, got antibiotics and bronchodilators, not remained well as per parents. So the parents are not happy, noisy breathing is persisting, right? Is choked after eating, cucumber, and that is something which is not, it doesn't fit in well, because cucumber is something which is soft, and we haven't seen, cucumber getting aspirated into the tracheobronchial tree. So something fishy going on, and you have 3 X-rays which are normal, right? Now, do you think these X-rays carry a meaning? If you ask any radiologist, they would say, there's some hyperinflation in these 3 X-rays, some reduction in the bronchovascular markings which can happen with hyperinflation, or can be a viral episode. But to a clinician, they mean much, because we have a clinical background in mind, right? So you have a child who has been wheezy for the past month, has noisy breathing, is not having fever, hasn't responded. So what are we thinking about? So we're thinking about an airway disease. So what could be your differential diagnosis? So if you're thinking about a differential diagnosis, you can think about tracheobronchitis, you can think about bronchiolitis obliterans type of thing. You can think about a foreign body, right? So it helps me to, this X-ray helps me to understand what can be going on. And in this particular age group, as Dr. Subramania was talking about, a child who was previously well doesn't appear to be infective, noisy breathing is persisting, we would definitely go ahead and do a bronchoscopy. And because there was a monophonic wheeze, so we thought that the primary illness is related to the major airway, possibly the trachea. And when we did the bronchoscopy, this is a very small clip. When we did the bronchoscopy, there was a foreign body which was there in the trachea, which we took out with a Domia basket. So you can see this foreign body was lying there, and because foreign bodies are large, sometimes they cannot actually lodge into the main bronchi, they remain in the trachea. The child remains symptomatic and the child will have a normal X-ray. So this normal X-ray to me means, yes, there can be a foreign body in the trachea. But if someone does not know, or if you're a radiologist, you have not talked to your radiologist that this is the clinical background, this X-ray can be reported as normal, right? So this is the Domia which is going in, and we can grab the foreign body with the Domia and we are out in hardly 3 to 5 minutes, and the child can go home after 2 hours, right? So a normal X-ray does not rule out disease, right? So that is what I am trying to emphasize in this. Now, this is an 8-year-old girl who has presented to us with fever, 3 weeks fever, persistent fever, weight loss. So something unusual going on, and an X-ray which is there. So just look at this X-ray and evaluate. Now, the unit who had admitted the child asked me to have a look, and my opinion was that there are definitely miliary shadows in the X-ray. Right now, these are digital films, and most of us are trained on analogs. But now, gradually, analogs are being faded out, and most hospitals have digital films. So the parents were not very happy with the diagnosis. The treating unit was not very happy, and we went ahead and got a CT, and the CT shows miliary mottling in this child. These are all miliary mottling, which you can see, and trine bud opacities in bilateral lung field. So sometimes the digital X-rays versus analogs can lead to a lot of confusion, and this is something which we all need to realize, that there is a bit of a learning curve when you move from analogs to digital X-rays, right? So analogs are something which are phasing out. Digital X-rays, either a CR or DR type of thing, is there in most hospitals, private hospitals now, because you can get a film very early. There is no delay. It can be stored. There's no chemical waste. It can be archived, and you can do a teleradiology. So they're all everything which is plus for digital radiology. But definitely, we need to know what we are looking for, and there can be a lot of tweaking around with the X-rays. So if you go around in the console room, and you will find the technician actually photoshopping it up and down, and whatever he feels is the best or looks best for the print, he will give it. But in this photoshopping, a lot of details can be missed. So the best idea would be that you go around to the console room and have a look yourself. But we need to be aware sometimes that yes, this is a digital film. So two things which are a bit difficult is ground glassing, presence of very small fine nodules, and bronchovascular markings. Sometimes these can be read or overread in a digital film. Right. So another one, 2 years old boy from Mathura has cough and distress for 2 months and no clear history of fever. Again, wheezing documented, admitted multiple times, normal investigations, received IV antibiotics. So again, longer history, 2 months, not getting better, again, afebrile and documented wheezing, right? X-rays were done. If you look at these X-rays carefully, then I would say that there's a collapse in the right middle lobe here. This X-ray appears to be normal. Right now, this child now comes in with a CT. Now, when you look at the CT and the report, it says alveolitis involving the left upper lobe, right? So they thought that there's an alveolitis which is there in the left upper lobe. And alveolitis in India, most people will take it as tuberculosis. And this child was started on ATT. Parents weren't happy. Again, doctor shopping started. Someone referred to us. So we thought that there's no clear fever. Cough and distress is persisting. There's a monophonic wheeze on the right side. What's going on? Is it a lymph node which is compressing? But how about this? How about this CT? If you look at this CT carefully, then it is actually the other way around. The right upper lobes appear to be normal. The left side appears to be completely normal. It is the right middle and the right lower lobe which appear to be hyperinflated. So now everything fits into that. You have something in the intermediate bronchus which is actually compressing, leading to a hyperinflation, and it is actually the left side which is normal and the right upper lobe is normal, right? So there's no alveolitis. There's no alveolitis. There is compression or there's obstruction to the intermediate bronchus leading to hyperinflation. Again, what it can be, well, obviously at this age, the most common would be a foreign body, and we took out the foreign body. So it was a piece of nut which was there in the intermediate bronchus. So again, you need to know what you're looking for. If you believe just the reports, then you're going to land up into a trouble. I'm not trying to comment on any radiologist. My basic learning comes from my radiologists who have taught me, and they teach me in and out, day in and day out. It is just that because sometimes they actually do not know what's going on with the child. They can be reporting which might not fit into our clinical diagnosis, and I always go back and talk to my radiologists that this is what I feel is there in the child, and this is my differential diagnosis. What do you feel is going on, right? So it is something like that, right? This is a child who had 9 months old, was febrile for 2 weeks, and has a persistent pneumonia. I'm not seeing all the X-rays. There's a persistent pneumonia in the left-sided lingula. MAN2 is negative, and the GAs are negative. So you are thinking in terms of a persistent pneumonia, possibly tuberculosis. You don't have a contact. GAs are negative. So what will you do, right? Would you go ahead and do a CT? That is the question. Well, most people will go ahead and do a CT scan. My question is that how will it help you? It gives a lot of radiation. It cannot give you the bug. So the best of CTs cannot give you a microbiological diagnosis. So in such situations, if you have availability, choose an alternate investigation. So for example, we choose to do a bronchoscopy over and above a CT because we are more interested in microbiology. And when we did a bronchoscopy, we could see that the left main bronchus is obstructed, and we went ahead and into the lingula. We could find caseation. So the diagnosis was made. We avoided radiation. We got microbiology. We got a gene expert which was positive, and we got a culture which was positive. So that is really something which we wanted to do. So choose investigations carefully, whatever is available to you. The choice of getting a CT, I'm not very keen on getting CT sometimes because, as I said, it gives a lot of radiation to a child. So this is the caseation which I was talking about, and the diagnosis was made. So choosing radiological investigation is on you. It is not on the radiologist. You ask them to get a CT, right? So choose your investigations carefully. Okay, so this child is 7 years old, has a pleural effusion, mainly polymorphic raised proteins. Now, tube was put, 1 liter fluid was drained. This child isn't improving, right? So what is going on? Is it TB? Is it not TB, right? So the treating unit got a CT, and now you have a CT here. Again, it shows a loculated effusion, some air pockets because of the tube. Where are we? Has CT helped us? Well, we were not clear about the diagnosis. Do you think CT changed management? Well, CT did not change management. We did the pleural biopsy. It was diagnosed as pleural tuberculosis, right? The question is that, again, you've given radiation of 3, 4, 5 millisieverts equivalent to 400 X-rays, but you've not gained anything out of that, right? So again, as I said, we asked the radiologist to do a CT. The radiologist never asked us, right? So doing an ultrasound would be something which is much better in such scenarios. For pleural diseases, CTs are not something which is going to help us. Someone is not unmuted. I would request everyone to please mute themselves.
Dr. Tunu Gadi, Dr. Tunu's mic is on, I think. Dr. Tunu.
Thank you. Now, so that is the background which I am talking about, that we need to choose the investigation carefully, right? So unless until you have some background of radiology, it will be difficult to choose the investigation. Now, this is a 4-year-old girl, has fever, cough, and distress, raised TLC, and mainly polymorphic. So there is some pneumonia somewhere, but we are not going to. It's not easy to pick it up with this X-ray. The X-ray looks perfectly fine. right? X-ray was repeated, some retrocardiac density, but we weren't sure what's going on. Now, lateral X-rays were done, they were non-contributory. We thought that there might be a pneumonia in the left lower lobe. An ultrasound was again done, it shows some retrocardiac consolidation, but the radiologists weren't sure. These are situations when CT is going to help you because there was a large consolidation. And look at this, this consolidation lies actually behind the heart, and hence your X-rays are going to miss this, right? So this is the mediastinal window, this is the lung window, which shows a large consolidation. So if you're trying to look at hidden areas in the chest, you've exhausted your investigations, then obviously CT is something that is going to help you. So the hidden areas could be both the apices, the hilar areas sometimes, the retrocardiac areas, and the areas of the lung which is actually behind that or in front of the diaphragm, where it overlaps and you cannot get a good answer with the X-ray. Okay, so this 5-month-old boy has noisy breathing since day 10 of life, something congenital going on, frequent episodes of cough with fast breathing, has received a lot of nebulizations, right? So a usual story, but looks like an atypical wheezer, as Dr. Subramania was talking about, has some stridor and a monophonic wheeze. So, you know, there is something fishy going on, doesn't fit into a typical wheezer, which we see day in and day out in our clinical practice. So something abnormal going on. So the question is, what investigation you will do further in this atypical wheezer? Well, there's a long list of differential diagnoses. I'm not going to cover that. So just to tell you, it can be infective, it can be congenital problems, it can be mechanical problems. And all children are different. So we thought that in this situation, a bronchoscopy is something which is going to help us, give us more answers than anything else, right? You might need 1, 2, or 3 investigations, but they have to be sequential and not parallel, because these are all difficult to do investigations. So bronchoscopy shows an extraneous compression in the trachea, and rest everything was normal. It was a pulsatile compression, so we were thinking of extraneous compression, so usually it is going to be a ring. And when we got a CT, we found it is a double aortic arch. So this is the right arch, and you find a left arch, right? So this is a double aortic arch, which is there. Sometimes the arch both the arches may not be at the same level. They can be like this, and hence it is, you see left or right better in different sections, right? So the CT or the CT angio actually clinched the diagnosis. But the question again is that, do you think something better could have been done? So something better can be done. So just to summarize this, that you need sequential investigation on a particular case. Something better, yes, MRI could have been done. So MRI, avoids a lot of radiation, which we are worried about. But remember that it is still a bit evolving. It takes a longer time. So if CTs take 3, 4, 5 minutes, it takes 20, 30 minutes. That is the main problem with the MRI, and you have to keep a sick child sedated for 20 to 30 minutes. Sometimes may not be easy, right? These are children who are wheezy, and there's a lot of chance that they might collapse in the MRI room. So it can be done in older babies who are stable, but yes, I would say for mediastinal lesions, MRI would be the investigation of choice if possible to do in the clinical situation, right? So just a small word about diffuse lung disease. Now let's look at these 4 X-rays, right? So they all appear to be like an interstitial lung disease. What is the difference? Okay, 4 X-rays. Can you say what this is, what this is, what this is, or what this is? Yes, if you look at this carefully, then you might be able to say something about this. So small lung volumes, diffuse opacities, fuzzy borders, possibly some lymph nodes here, some reticulonodular shadows here, diffuse ground glassing here, lymph nodes here, and miliary mottling. But further, it's difficult to say. So we can say that, yes, it looks like an interstitial lung, or now better called as diffuse lung diseases, but there is no characteristic pattern which we can identify. And in these situations, CT is something which has to be done. There's no choice about it. It can pick up many more findings like ground glassing, nodules, and what configuration is there, cystic lung lesions, mosaic perfusions, consolidations, right? And the first case in the CT, what we thought it was attraction bronchiectasis and a lot of septal thickening. This child underwent a biopsy and it was diagnosed as a non-specific interstitial pneumonitis. The second child, the CT was done. It was showing cystic areas, areas of ground glassing. And this child also had this sort of a rash, and it was diagnosed as a Langhans cell histiocytosis, and CD1A was positive. And these are cystic areas which we are trying to show in the corner section. Right. The third child has diffuse areas of ground glassing, no septal thickening, was more of a subacute kind of disease. The serum preference to pigeon droppings was positive, and it was actually a case of hypersensitivity pneumonitis. And the fourth child, you can find diffuse nodules and lymph nodes. And this child was actually HIV positive, and biopsy showed a lymphoid interstitial pneumonia. So CT in such situations can lead to narrow down your differential diagnosis and decide investigations. So sometimes CTs can be, as shown, it can be helpful in these situations. Sometimes CT can clinch a diagnosis when the pattern is distinctive, and I'll show you a case. But more often it is going to be suggestive, and it helps you to plan further investigations. Where do you want to do a bronchoscopy? What testing you want? What investigations involve? What genetic testing needs to be done? Right? It can help you from where to get a lung biopsy done, what is the best site, and what samples to be done or processed on the lung biopsy specimen, because everything may not be possible at one center. Right. So this is a child who presented to us 2-3 years back, had fever for 2 weeks, has respiratory distress, which is progressively worsening, and previously a well child, no problems. This child was a bit hypoxic on room air. The rest of the vitals were fine, is tachypnic, has received a lot of antibiotics, but doesn't seem to respond. Now look at the pattern on the X-ray. Do you think this is like a typical bacterial pneumonia or viral pneumonia? Well, no. Mainly peripheral-based opacities, patchy shadows, what's going on. There is something fishy which is going on, which we weren't very sure. So we admitted this child, we changed antibiotics. We thought, let's do a bronchoscopy and see what are we dealing with. The cultures were negative. Right, this child did not settle, the counts were a bit high. But we were not sure with what pattern this is and what we are dealing with. So in view of persisting hypoxia, tachypnea, we thought we should do a CT and look at what pattern of lung disease which we are looking at. And when we did, these are CT images, and these are classical findings of something known as cryptogenic organizing pneumonia, or BOOP. And this was an infection-induced BOOP. So these are all peripheral pneumonias, which you can see areas of consolidation and ground glassing seen on both sides of the lung. And again, in this, you can see peripheral areas of consolidation, which are seen. So this child was treated with pulse of methyl prednisolone, improved, remained in follow-up, and has remained well throughout. So these are situations when CT can be diagnostic. Right. So how much time do I have?
Sir, we are almost complete.
Okay, so I'll just try and wind up. So I think I'll just leave this case for the paucity of time. And okay, so I'll just show 1 or 2 more very short cases. 14 years old boy has recurrent hemopsis. Well, X-rays normal, doesn't look like tuberculosis. CT was done, reported as normal. We did a bronchoscopy, and there's a bleed from lingula. What are you going to do further? The CT is also normal, and you just find a bleed from the lingula. Do you think something has been missed? Well, yes. If you're not careful with the way CTs are done, you can miss. So a CT was repeated again geography, and it shows in arteriovenous malformation. So it is us who raised the diagnosis. It is us who asked the radiologist that we think this can be there. Please look at this, and this should be done before the scan is done, not after the scan is done, right? And this is the last one. A 14 years old boy who was referred to us with hemopsis, a nephrotic syndrome. We weren't sure what's going on, and the CT actually shows a pulmonary embolism. Right, so there's a pulmonary infarct, there's an infarct which you can see here, and there's a filling defect here. So it was actually an embolus. So these are situations when CT can be very useful. So I'll just wind up in the next 2-3 minutes. Remember that imaging is extremely important tool for diagnosis and follow-up. There are potential pitfalls in any form of radiological imaging, be it X-ray, be it ultrasound, be it CT. And failure to properly interpret these features could lead to misdiagnosis and inappropriate treatment. So whenever you are faced with such situation, review the X-rays. Remember, there can be a lot of pitfalls in imaging. You can order, alternate views like lateral, a picogram, and consider doing other investigations like an ultrasound. And then think what alternate investigation is better. Do you want to actually get a CT chest? Do you want to get a bronchoscopy? Sometimes there's a confusion whether should I scope or scan. Well, in infections, we scope first. In malformations, we scan first, right? We are a bit different from the adult group. The adult group will always do a CT, and that's not true for pediatrics, right? Because we have a different approach. And always, this step has to be done. Go back to your radiology with all the X-rays and the clinical findings, sit with them and discuss. That has to be done before you embark upon any other investigation, right? Think about your differential diagnosis. You're not supposed to think about your differential diagnosis after the investigation is done. Make a differential diagnosis before the investigation is done. Now, if you want to choose a CT chest, choose a center which has a good imaging modality. You should always discuss it with the radiologist, what needs to be done. Do you want a contrast or a plane? You should talk to the radiologist about a pediatric CT protocol using the least possible radiation to the child. What you want to do, always go and review the CT on the console. That is the best way of learning the CT. Look at the rest of the films, axial, the MPRs, the MEP images. And based on this, think about what radiological diagnosis in your clinical picture you have reached, and go along and do a clinical radiological correlation. And that is something which will help you to reach a diagnosis, right? And then further investigations need to be planned, like bronchoscopy, or genetic testing, lung biopsy, etc. Because in a lot of patients, you will not be able to reach a diagnosis just with your X-rays or your CT. So final diagnosis in pediatric pulmonology might require additional investigation like bronchoscopy. It might require specialized tests like evaluation of GRD, swallow evaluation, sweat chloride analysis, and so on, right? So the imaging is not the end of the world, but it is an extremely important investigation for pediatric pulmonologists. So I'll just end here. So you need to have a good, rapport with your radiologist. You can go and fight with them. If Partho is there, I'll go and fight with him, right? But you can make good friends there. Have a cup of coffee, enjoy, and also learn radiology. So thank you very much. I'll stop sharing, and if anything anyone wants to ask, then we can do that.
Thank you, Dr. Ankit. It has been really very beautiful, and you have done your job very well. The best part is that the rapport with the radiologist is the best part. One needs to have a good rapport with the radiologist. You must talk to him, as you have said very clearly, and discussing the cases clinical diagnosis with radiology. Thank you, and I think we are running slightly short of time, so I would go back to Partha now.
Yeah.
Thank you once again.
Thank you, Dr. Ankit Parak sir, for your wonderful insight, and as well as thank you, Dr. Shyamashika sir, for conducting the session. Now we go to the second session. This is a panel session where we have Dr. Nayanmani Deka will be moderating this panel on allergic rhinosinusitis. And to share the session, we have Dr. Nirmal Kumar Jain sir. Sir, please go ahead.
Okay. Good evening to all. Am I audible?
Yes, sir.
Hello.
Yes. Yeah, you're audible.
Sir. So, good evening to all. So, after the exhaustive topic, exhaustive topic about some rare diseases also, now we come to the common pediatric problem in day-to-day practice. I am of any Northeast RESPICON for giving me the honor of being a chairperson. I am here by pleased to introduce the younger generals of pediatrician. Thanks Dr. Partha and Mrityunjay forming such a Northeast respiratory chapter, because respiratory problem is the commonest So, Noinman Deka, so Partha, should I introduce? Hello, Mrityunjay.
Yes, Dada, you can introduce Noyan, then he will introduce the panelists.
He's introduced. Okay then. So, Noyan Deka is a consultant pediatrician and asthma and allergy specialist of Pratiksha Hospital, Guwahati, and he's a work experience for more than 10 years. He is the East Zone Coordinator of Allergy Asthma Network of India. I think he has done a good job doing a consultant pediatrician with specialized in asthma and allergy specialist. He is a reviewer of IAP guidelines of air pollution and allergy 2020, who have a publication also, so many publications. So I want to hand over the mic to the Nayan Mani for this day-to-day practice common problem.
Thank you, Dr. Nirmal. Dr. Nayan, please go ahead, introduce your panelists and take over the panel discussion, please.
Thank you, sir, for having a nice introduction. At the outset, I offer my sincere thanks to IIP Respiratory Sector Northeast, as well as the Central IIP Respiratory Sector, Dr. Pathurputin Mora, Dr. Mrityunjay Pauda, and Dr. Subramaniam sir and his team. So before starting our session, let me introduce our young panelists from Northeastern region. Extremely happy to meet them and also share our knowledge in this august platform. Let me first introduce Dr. Yasin Ali. Dr. Yasin did his MD from Mulanapur Medical College, also DCS from Guwahati Medical College, is a consultant pediatrician and neonatologist in Health City Hospital, Guwahati. He is the current Secretary General of IIP Guwahati City Branch. Welcome, Yasin.
Thank you.
Our next panelist from Nagaland, Dr. Akumrusi Ponjen. He has completed his MD from Assam Medical College, PGC under neonatology from Southampton University, UK, and he is a treasurer in current IIP state branch of Nagaland, and is a NRP coordinator.
Thank you, sir.
Yeah, welcome, Dr. Akum. Our another esteemed panelist, Dr. Tunu Gadi, did her MD from Mulanapur Medical College, a consultant pediatrician and neonatologist from Ramkrishna Mission Hospital, Itanagar, Arunachal Pradesh, or eastern part of India. Extremely happy to have you as our panelist. Our next, another young panelist, Dr. Pankaj Pradip Payeng, is working as an assistant professor in the Department of Pediatrics in Jorhat Medical College, Jorhat, Assam. Welcome, Dr. Pankaj. So our last panelist from Scotland of India, Shillong, Meghalaya, Dr. Rosina Su, currently working as assistant professor in the Department of Pediatrics in one of the central medical college, Negrim's Northeastern Indira Gandhi Regional Institute of Health and Medical Science. Currently working also as a Secretary General in IIP Meghalaya State Branch. I welcome all of you in this August platform. And before starting the session, let me give a brief introduction of this important topic of allergic rhinosinusitis. Basically, this is a the first occurrence of the environmental occurrence of the first allergic manifestation of the childhood disease. Although proper estimation is not up to date, not done properly, but the only tip of the iceberg we used to diagnose. But the major burden of the disease is a very huge burden. In some studies, it has been reported globally in around 6 to 7 years of age group, almost 2 to 15% of children were having allergic rhinitis. In Indian scenario, up to 26% of cases they have reported as a case of sinusitis and rhinoconjunctivitis. So it's definitely is a huge huge major socio-economical burden in the community that is underestimated, and sometimes the rational approach of diagnosing the disease as well as the management is the utmost important to prevent the progression of this important manifestation of the disease. So after introducing this topic, let me come directly to the panelists and take their opinion regarding these important aspects of the disease. So just we to make it interesting, we'll start with a case scenario of Arjun. So this Arjun, a 6 years old, presented with itching, nasal congestion, sneezing, blocked nose for last 3 years. Symptoms were persistent, almost daily and perennial, and mostly indoor, aggravated in late summer, early fall, and again in early spring. Impaired quality of life for schooling, and there is sleep disturbances. Over-the-counter use of some medications like oral antihistamines, irregular use of inhaled nasal steroids. Housing condition was damp, ventilation was poor, no pets, no biomass use. Strong family history of atopy, both parents and maternal grandparents, birth history of uneventful, a term LSCS delivered baby, exclusively breastfed up to 6 months, no history of smoking, and no history of asthma. The history is very important. We have taken a elaborative history because in allergy diagnosis, almost more than 90% cases, history takes the major role. So that's why this was our case. It's a common scenario we used to face in day-to-day practice. So coming to our first panelist, Dr. Yasin Ali. So having gone through this case scenario, what are the thought process in your mind and what might be the provisional diagnosis in this case? Dr. Yasin?
Okay, thank you, Dr. Nayan. So after going through this case, so we see this case, Arjun, he has some symptoms which suggest inflammation in the form of congestion and nasal blockage, some symptoms in the form of some allergic activity which is going on, such as sneezing and itching, and in the background of strong family history of atopy in the parents and also in the grandparents. So this case is most probably we are dealing with a case of allergic rhinitis, and we can see it is perennial and it is persistent for the last 3 years. So it is persistent, severe case of allergic rhinitis, and it is now not only localized to the nose as such, not localized to only one organ. So it has started disturbing the sleep. It has affected the quality of life also. So it has become a systemic thing now. So our provisional diagnosis would be a moderate to severe and persistent allergic rhinitis compromising the quality of life.
Yes, very well explained. Yasin, having a very good approach. After taking a brief clinical history, we should have to have a provisional diagnosis, and you have nicely spoken about the progression of the disease, a systemic onset of the disease, as well as the regarding grading and all will come later on. But initially, definitely it's a severe form of allergic rhinitis. Very well explained, Dr. Yasin. Thank you. So next question is to Dr. Akum. So what is allergic rhinosinusitis, and why it's both allergy and rhinosinusitis? The term is coined basically. Why it is called allergic rhinosinusitis together?
Thank you, Nayanda. First of all, I like to thank the organizers for this wonderful opportunity. Coming to why is it called allergic rhinosinusitis? It is so because the inflammation of it is basically the inflammation of the sinuses and the nasal cavity. Now, this term had to be coined together. The reason being both rhinitis and sinusitis, they go hand in hand because of its anatomical proximity. And we all know that the sinuses would drain into the nasal cavity. For example, the maxillary sinus would drain into the middle meatus. So it drains to a very small ostium or a very small opening, which is about 0.4 millimeters. And when the small openings are closed because of inflammation, it can cause sinusitis because of the inflammation. And therefore, these two are very closely related, not only anatomically, but even pathophysiologically, because their mucosas are in continuity with each other. And coming to the statistics, if you look, about 60% of patients with chronic sinusitis are going to have acute rhinitis. And the use of topical intranasal steroids, of course, reduces the inflammation and improves the obstruction. And of course, it may take a little while, but then it does reduce the obstruction and improve the clinical scenario.
Thank you, Dr. Akun. Very well explained. Yes, definitely, both the sinuses as well as the rhinitis part, they are close proximity, having covered by same mucosa. So definitely, inflammation of the nasal part will definitely extend to the sinuses. So very well explained. Thank you. So our next question is to Dr. Pankaj. So why do you think that Arjun's symptoms are not just merely a sneeze or a trivial disease and needs to be considered in the context of systemic allergic disease, as Dr. Yasin has in the first slide or first question that he has mentioned that yes, it's a progressive disease and it's a systemic disease. So why do you think it's so? Is it real? Because it's a rhinitis. So is there any pointer or something like that for which you will explain that it's definitely it's a systemic disease? So what is your opinion regarding this one, Dr.
Okay, thanks for your question. So first of all, I also want to thank all organizers to be a proud part of this RESPICON versus RESPICON. So coming back to the case now. So after going through Arjun's history and after hearing panelists, that now it is confirmed that Arjun is having a progressive allergic disorder primarily involving the and which has also impaired his quality of life. So as we all know that this rhinitis is an allergic disorder, and it sometimes it not only restricted to the nose, and it goes to the perinasal and paranasal structures and can impair the quality of life. So apart from the classical nasal symptoms like rhinorrhea, then nasal itching, sneezing, and nasal congestion, so we can have symptoms of paranasal sinus involvement like headache and heaviness, along with pain and tenderness over the areas or overlying the paranasal sinuses, and also the perinasal symptoms like involvement of the eyes, involvement of the adenoids, pharynx, and the medullary cavity, like allergic rhino conjunctivitis, then the itching of the eyes, then the tearing of the eyes, redness of the eyes, and child can have oral symptoms like fissuring of the tongue and lips due to prolonged duration of mouth breathing due to nasal congestion. Then child can have recurrent otitis media. Child can have adenoid problem. The child can have altered sleep behavior, and sometimes we often get hyperactive airway diseases. And lastly, systemic and constitutional symptoms like excessive or increased daytime somnolence, easy fatigability, irritability, lethargy, poor scholastic performance, failure to thrive, depression, and which ultimately lead to impairment in the quality of life. So here in Arjun's history also, we have observed all those four fields has been involved and impaired his quality of life. Again, allergy has proven again that it's not a localized problem, it is a systemic disease.
Nicely explained, Dr. Thank you, Dr. Pankaj. Nothing much more to say. Already we have added elaborately, already have discussed regarding this issue. So let us go ahead with the next question to Dr. Tunu. So how do you diagnose allergic rhinitis from clinical to lab history? And because you should have a rational approach just before ordering some investigations, you need to know why are you investigating the child, or is there any some particular investigation, is it required or not? So you should know, you should have a rational approach. So how will you approach? Like some we used to prescribe or investigate total immunoglobulin E, some used to investigate with specific immunoglobulin E. So what is your take on regarding rational approach of investigating a child with allergic rhinitis? Dr. Tunu.
Okay, thank you. First of all, good evening to everyone. And thank you, organizers, for giving me this opportunity. Coming to the question, the first and the most important step for diagnosing allergic rhinitis is a good clinical history and to look for specific physical signs. The symptoms, the most cardinal symptoms are runny nose, sneezing, itching, nasal stuffiness. And then we should also look for Signs, specific signs like examples are allergic shiners, nasal creases, then Danny Morgan's line, etc. If two or more symptoms are present for more than 1 hour for most of the days, then we are diagnosing allergic rhinitis. And now coming to the lab investigations like skin prick test, specific IgE antibody test, these are done only for complementary reasons. Skin prick test and allergic specific IgE specific allergen specific IgE, these tests are done to look for sensitization to any specific allergy, but they have their own advantages and disadvantages. Skin prick test is a test which can be done in the OPD in the presence of the parents. The result is available within 20 minutes and the real-time result can be seen by the parents. But at the same time, presence of certain skin conditions like atopic rhinitis can interfere with the result. And when coming to allergen-specific IgE, these tests are very expensive and the test result does not come early. Now coming to total IgE and peripheral eosinophil count, these tests are not routinely recommended because like in 30% of allergic cases, allergic rhinitis cases, this test comes negative. At the same time, there are certain conditions, many other conditions other than allergic rhinitis where total IgE and the peripheral smear may be elevated. So before going for an investigation in a child with allergic rhinitis, we have to ask ourselves why these investigations are needed when most of the diagnosis can be made on the basis of a good clinical history and a good physical examination. Thank you.
Thank you. So nicely explained, Dr. Tunu. All aspects of this investigating a child, a rational approach, and the important point here is that we should not go for total IgE estimation. That points need to be highlighted, and the role of specific IgE or skin prick test is to be highlighted. And definitely you have very well explained. Then let's go ahead with our next question to this one. In between, we'll just we'll show you that regarding the skin prick test report of Arjun, it shows significant sensitivity to house dust, mite, and cockroach. We'll come to this later on. In continuation of the discussion, we have shown you the report, and we'll discuss it again in the later part. So our next question to Dr. Rosina. So how will you grade and classify the severity of allergic rhinitis in case of Arjun? And here you can go through area classification. Can you elaborate regarding this?
Good evening, everyone. I'd like to thank the organizer for giving me this opportunity. So the grading of allergic rhinitis is as per the ARIA guidelines, which is the allergic rhinitis and its impact on asthma guideline. This is an expert panel which uses an evidence-based grade approach to classify allergic rhinitis. In 2001, they have included a new subdivision, and they have added the term intermittent allergic rhinitis and persistent allergic rhinitis. These terms should not be used synonymously with the previous classification of seasonal allergic rhinitis and perennial allergic rhinitis. So intermittent allergic rhinitis is actually used when the symptoms last for less than 4 days per week or less than 4 consecutive weeks. And for persistent allergic rhinitis, it is used if the symptoms appears for more than 4 days a week and more than 4 weeks per episodes. Then according to the severity of the symptoms and the quality of life outcomes, it is again classified as mild or moderate to severe allergic rhinitis. In mild allergic rhinitis, the child will have normal sleep. There is no impairment of daily activity, sports, leisure, and the symptoms will be present, but they're not troublesome. And then in moderate to severe allergic rhinitis, the child will have abnormal sleep. He can have impairment of daily activities, sports and leisures, or problems at works and school performances, as well as bothersome symptoms. So for this ARIA classification is closest to the patient needs than the previous classification. So for Arjun, actually his symptoms will fit the moderate to severe persistent allergic rhinitis.
Thank you, Dr. Rosina. Very well explained. We should all, before writing the diagnosis, we should categorize the patient, and we should write the complete diagnosis as per Dr. Rosina has mentioned, moderate to severe persistent allergic rhinitis of like Arjun, in case of Arjun. Thank you. Let's go ahead with again Dr. Yasin. So how will you differentiate this condition, allergic rhinosinusitis, from common cold? So how do you differentiate this one?
Okay, you see, this is a very common scenario in our day-to-day office practice. So we commonly encounter this common colds and allergic rhinitis cases, and we need to differentiate these two cases because the treatment is different from each other. So the basic thing which we need to fit into our head is that allergic rhinitis is a form of allergy and common cold is a viral infection. So common cold is usually caused by many viruses, the most commonly the rhinovirus, and allergic rhinitis is the allergy. So just knowing this basic, we can easily differentiate that these two conditions. Allergic rhinitis, there will be family history of this allergy in other members with atopy also, but in common cold such family history will be absent. But in a common cold, there will be clustering of cases in the family because one person getting affected, the many other persons will be getting affected at the same time. But there will be no such history in allergic rhinitis. And usually viral infection comes fast, goes fast. The cold usually lasts for less than a week. But in allergic rhinitis, the cold will last it will linger on. It will last for more than 10 days. So as we know, in a common cold, there will be mild fever with other system involvement also. But in allergic rhinitis, plain allergic rhinitis, there won't be any fever. And the nasal mucosa, if we check the nasal mucosa, we will get difference between the two. In the cases of common cold, the nasal mucosa will be red with a thick mucus. But in allergic rhinitis, we usually which we encounter, we see the mucosa as pale and boggy mucosa with thin mucus. And allergic rhinitis, we give antihistamines, we get a prompt response, but in common cold, we may not get any other such response. So it will be very difficult. It won't be very difficult for us to distinguish these two cases.
Thanks, Dr. Yasin. It's very important to differentiate these two conditions. And as already you have elaborated, definitely by all these pointers, you can differentiate it from common cold and whether it is rhinitis or common cold. And sometimes rhinitis start with common cold, but if it persists for more than 10 days, that's an important pointer, which is significant history. Yes, thank you. Let's discuss with the next question. Dr. Akum. So, after taking the history, coming to this diagnosis, so do you recommend pulmonary function test for Arjun, even though he is not having any symptoms of asthma? So, what is your opinion regarding doing spirometry in case of Arjun, although he is not symptoms are suggestive of asthma? What is your opinion, Dr. Akum?
Well, for Arjun, it is not just logical, but it is prudent to do the test because, as we all know, about 40% of the patients with allergic rhinitis, they're going to have underlying asthma. And this could be an undetected case. And conversely, about 80% of asthmatics are going to have allergic rhinitis. If you look at the spirometry result of Arjun, that's up on the slides, you can see there is a bronchodilator reversibility of FEV1 more than 200 ml or more than 12%, which indicates that there is definitely an underlying inflammation going on due to asthma.
Yeah, thank you, Dr. Akum. It's a very important point, needs to be highlighted and need to be sensitized to all, because in rhinitis, almost 40% cases is associated with asthma. Although it's clinically not evident, but there might be underlying inflammation, for which this spirometry report is very important. Although this child was not symptomatic, but there was significant bronchodilator reversibility, which itself indicated that he was also suffering from asthma, although not manifested at that time, might be manifested within few months or years. So this is very important. We also recommend this one. And in 80% of asthma, there is associated with rhinitis. But in 40% of rhinitis, there is association of asthma. So that's why importance of doing spirometry in case of Arjun, as Dr. Akum has very well highlighted. Thank you. Then going to the next question to Dr. Tunu. What is your, because sometimes what we used to do lots of investigations, unnecessary investigations, like doing an X-ray chest X-ray, sometimes doing a X-ray lateral view to look for adenoids, sometimes doing CT scan of sinuses, sometimes doing fiber optic laryngoscopy. So, Arjun, do you recommend all these extensive investigations? And if yes, or if not, why? Can you elaborate?
Okay, thank you, sir, for the question. Well, for Arjun, I would not like to go for these investigations. The reason being, these investigations, that is X-ray, CT, FOL, they are not used to establish a diagnosis of allergic rhinitis. Firstly, secondly, these investigations are done if the clinical examination and history of the child directs towards any comorbidity or any other structural abnormality, then we go for this test. And whenever we have any suspicions of sinusitis, we often go for X-ray paranasal sinuses. But I must tell here that X-ray paranasal sinuses, they in children with allergic rhinitis, it is seen that in 40% of the cases they do not show any evidence of mucosal inflammation. And it is also a very common practice to get X-ray lateral view of the neck to look for adenoids. But it has been found that the size of adenoid does not correlate with the X-ray picture. And when coming to the CT scan, CT scan itself has a very high risk of radiation exposure. And CT scan is therefore CT scan is not routinely recommended. It is we can go for CT scan if we suspect any if the child is to be taken for surgery, or if we suspect very serious complications like sinusitis. And for FOL children, it's very difficult to do nasal endoscopy in children. And if at all we want to do nasal endoscopy to look for any, to assess the osteometal status or to look for adenoid hypertrophy, then we must send them to experts like ENT surgeons. So that's the answer, sir.
Thank you, Dr. Tunu. That's why we have prepared these slides so that you all of us should have a rational approach in diagnosis and whether to do or whether not to do. Dr. Tunu has very nicely explained. Nothing much more to say. We can proceed to the next question. Our next question to Dr. Ruzina. So, what will after coming to all the after going to all the investigations, history and all, what will be the final diagnosis? What will you write in the? Yeah, what will the final diagnosis?
After doing all those, thank you, sir. So after doing all those investigations for Arjun and listening to the history and the findings, and also we have to take into account the associated comorbidities. So for a complete diagnosis, we've already established that he has moderate to severe persistent allergic rhinitis. From the pulmonary function test, we also see that he has a mild intermittent asthma. And from the skin prick test, we also found that he has house dust mite sensitization in addition to cockroaches and peanuts. And he also has a very impaired quality of life from the history. And as Dr. Yasin has already pointed out, he also has a progressive allergic disease. So when we have to write a diagnosis for Arjun, we have to include all of these symptoms as well as associated comorbidities for a complete diagnosis and further management.
Thanks, Dr. Rosina. So this is a complete workup and diagnosis will be for Arjun. Thank you. So next again to Dr. Yasin. So now you have diagnosed Arjun as a case of moderate to severe persistent allergic rhinitis. So now how will you manage this child?
Okay, regarding the management, there has been very well laid pillars of management. The first is the education. So education about the disease, and not only to the family, we have to educate the family, and if the child can comprehend, we need to educate the child also, because he is also a team of the treatment. So we are treating him, but we are also educating him, and we need to educate them about the self-monitoring, the parents and the child both. And we need to emphasize upon them the importance of regular physician visits for repeated checkup. So the next important thing is the avoidance of trigger. Avoidance of trigger is Very, very important, because if we are giving the right amount of pharmacotherapy in the right doses for right duration also, but the child is not improving, then then we need to see are we avoiding the triggers or not. So avoidance of triggers is very important. But then the treatment of choice is the pharmacotherapy, which makes the cornerstone in the management. And in selective cases when the triggers are usually limited amount of triggers, then we are definitely going for immunotherapy when required. So when we are managing our case, we need to explain about the disease. We need to educate the child and the family. We need to control the environmental triggers. In our case, there were quite specific to environmental triggers we got in our skin prick test. We got the house dust mite and the cockroach as our triggers. Then pharmacotherapy, definitely yes, we will initiate with our pharmacotherapy. Then if not controlled with the pharmacotherapy, then our Arjun is an ideal candidate for going for immunotherapy, because he has got only limited amount of triggers which is causing his disease. So immunotherapy basically is of two types. We got the sublingual immunotherapy or the subcutaneous. Sublingual is preferred over the subcutaneous because of its more safe, and definitely the child needs follow-up visits regularly.
Thank you, Dr. Yasin. So well explained regarding the management of our case. So these four approaches we should always remember, starting from the education, then environmental control, pharmacotherapy, and immunotherapy. Definitely, if there is sometimes it's very difficult to avoid triggers, and sometimes it's very difficult to sometimes it might control for longer duration of time. So in those cases, sometimes we can offer the parents regarding the immunotherapy, because it is a definitive treatment, and others are basically supportive treatment. So these four pillars of management of residence is very important, and we also can you elaborate this as per severity? Can you elaborate the treatment modalities?
Yeah, definitely. So regarding the management has been laid down in the area and the ADEX guidelines. So we have got 4 grades. So basically intranasal steroids are the pillar, are the mainstay of treating almost all the grades. But in the mild intermittent cases, which the child may come only with sneezing, then we may try on with only second generation oral antihistamines, and avoidance of allergen and irritants will be applicable to all the grades. But in the other cases, the moderate, severe, intermittent, the mild persistent, and the moderate to severe persistent, inhaled steroids and inhaled steroids are the drug of choice. It has to be given, and then we add on with the second generation H1 antihistamines and the leukotriene receptor antagonists if required. And in the later 3 grades, then if applicable, we are going for the allergen immunotherapy. So now another condition which has come out in the latest 2019 ARIA guidelines, it has been mentioned that in moderate to severe persistent cases, we can go for the intranasal steroid along with azilastine, the combination. Why? Because the intranasal steroids, they take a few days to have their onset of action, but the child having severe persistent disease, so they need immediate relief. So this azilastine, add-on azilastine, it usually has onset of action within few minutes. So the child will be given this combination of fluticasone propionate. It comes with fluticasone along with azilastine. So we give it for 2 weeks. We control the child rapidly, and then we switch over to intranasal steroids for some months according to the severity. So this is a new thing which has come up, and so we'll be going along with this compact picture. It tells many things about the management.
Thank you, Dr. Yasin. So definitely inhaled nasal steroid is a cornerstone in the management of rhinitis. And as you already have said, this azilastine, regarding this one, there is palatability issue or just compliance issue is there. So although it's been recommended, but it's very difficult to give in case of children. We'll discuss later on this one. So coming to next question to Dr. Akum. So why, as Dr. Yasin has already mentioned regarding the second generation antihistamines, why is second generation antihistamines not the first generation one in management of rhinosinusitis in children?
Well, the second generation is preferred over the first generation, like chlorpheniramine. The reason being the safety and the efficacy ratio is much better in the second generation antihistaminics. Coming to the second generation antihistaminics, there are some drugs like cetirizine which can cause some sedation, and we want to avoid those. But the others like fexofenadine and levocetirizine hardly passes or crosses the blood-brain barrier and causes very less sedation, and the safety ratio is much better. So we want to prefer all the newer second generation antihistaminics. Coming to the intranasal antihistaminics, although it has been allowed to use in children as well, but of course it is not very common to use because of its bitter taste and compliance, and of course the mild somnolence that it can cause.
Thank you, Akum. So yes, definitely we will use, if at all to be used, we will use second generation antihistamines, as already we have explained very nicely. So next we'll move forward to the next case. Next question to Dr. Pankaj. So why oral decongestant are not used in case of children? Can you comment on this one?
So both systemic and local decongestants are not recommended in children because of their side effects, adverse effects. The systemic side effects of oral decongestants are like irritability, dizziness, headache, tremor, insomnia, as well as your increase in heart rate and blood pressure. And we all aware that the local adverse effects of intranasal decongestants like Rhinarius medicamentosa, when we use for longer duration, that is more than 7 to 10 days, as this prolonged use downregulates the adrenergic receptors locally, and after stoppage, they might rebound with more severe symptoms.
Thank you. Dr. Pankaj, thank you. Very well explained regarding this not use of this oral decongestant. So we'll move forward with the next question to Dr. Tunu. So can you elaborate on various drugs and their effects? Because we're discussing lots of drugs regarding inhaled nasal steroids, Montelukast, then again some oral antihistamines, inhaled nasal antihistamines. So lots of things we're discussing. So can you elaborate regarding their effects in different symptomatic controls, relieving the controls? So can you elaborate, Dr. Tunu?
Thank you, sir. The two major drugs which are used for management of allergic rhinitis are intranasal corticosteroids, oral antihistaminics. As you can see here, INS and oral antihistaminics, they have equal efficacy, almost similar efficacy in reducing symptoms like sneezing, rhinorrhea. However, INS has a better effect on nasal obstruction, whereas oral antihistamines has better control over nasal itching and ocular symptoms. INS is the gold standard for management of existent allergic rhinitis, and oral histaminics are the first line for mild allergic rhinitis. As for leukotriene receptor antagonists like Montelukast, they have mild anti-inflammatory effect, and they are very inferior as compared to INS and oral antihistaminics. And as of now, they are phasing out, as it has already been explained in earlier lectures in the evening. And as you can see here, intranasal decongestant, intranasal hormones, anticholinergics, they hardly have any effect on the symptoms of allergic rhinitis. Anticholinergics, you can see they have some effect on rhinorrhea, but that is not because of antihistaminic effect, but because of their anticholinergic effect, so which will have more side effects and will have detrimental effect on children. So these are not advised to be used. Thank you, sir.
Thank you. Very well explained. This is a very important slide. So we also know regarding the pharmacotherapy as well as the symptomatic control of different group of drugs. So very well explained by Dr. Tunu. Thank you. So next question to Dr. Rosina regarding controller, that is inhaled nasal steroids. So in case of Arjun, so which intranasal steroid will you prefer, and why will you prefer that one?
Thank you, sir. As already explained before, that intranasal steroids are the most efficacious medicine available for allergic rhinitis. Rationale being they are used in high drug concentration, which can be achieved at the receptor levels in the nasal mucosa and with minimal risk of systemic adverse events. The all intranasal steroids are equally efficacious when used in equipotent doses. So we have to choose one that has a low systemic bioavailability, preferably less than 30%, like mometasone or fluticasone furoate or fluticasone propionate. We don't advise using betamethasone because it has a higher bioavailability, which is more than 30%. Mometasone, fluticasone propionate can be used for children more than 4 years, whereas the rest of the population can be used for children more than 5 years. These intranasal steroids are used at a minimum. They are available at a minimum dose, which are required to achieve a symptom control. The adverse events of intranasal steroids are actually very negligible, as already mentioned by the previous panelists. They mainly include a minor nasal bleed or throat discomfort, which mainly arises from faulty techniques. Other adverse events, which I usually ask, are like what you call growth effects of growth in children. There are no long-term effects on growth in children, and there's also no HPA risk access effects on children. The prescription of these advice, however, should be individualized according to the patient's ability to use it, because we need an optimum outcome. So it also depends on their preferences as well as the cost. And the technique of inhaled nasal steroid should always be evaluated every time a child comes to you for a visit.
Thank you, Dr. Rosina. Very well explained regarding the. We should use that one which is having low systemic bioavailability. So in case of children, definitely mometasone or fluticasone will use. So next question is to Dr. Yasin. So can you mention about the dosage? Because whatever we have just now discussed, mometasone or fluticasone, in which age group need to be used, in what dose need to be used, how long need to be used. Suppose in case of Arjun, if you want to prescribe which one and how long you will prefer.
Okay, there are various preparations which are actually available in the market. We are using frequently basically these 3 molecules. One is the mometasone furoate, then fluticasone furoate, and the fluticasone propionate. So these 2 furoates we can use more than 2 years of age. So the doses for both are like in 2 to 12 years we will be using 1 puff per nostril once daily. And if it is more than 12 years, we'll be using 2 puffs per nostril once daily. And in the fluticasone propionate, we are using it in more than 4 years. So up till 12 years, if the dose will be like 1 puff per nostril once daily. And if it is more than 2 years, it is 2 puffs per nostril once daily. So the doses are almost all are fixed dose. The mometasone furoate comes as 50 microgram and fluticasone propionate also is 50 microgram per puff. And the fluticasone furoate is around 27.5 microgram per puff. So all these steroids are actually very, very safe. They are well tolerated with very low systemic bioavailability, and they can be used on a long-term basis on months and years together without any incidence of atrophy of mucosa, which we all feared earlier. And there are enough evidence that this does not contain the much feared growth suppression, and there is enough evidence that it does not cause any hypothalamic pituitary adrenal axis suppression. So the correct recommendation is that when we are starting with a intranasal steroid, we will be using it for a minimum of 3 months, and then we will be evaluating the child in subsequent visits. We need to evaluate the technique, how they are using it, and we need to assess the need or further need of the intranasal steroid during each visit. It is not that it is limited to 3 months. It may be used for years also without any such adverse effects.
Thanks, Dr. Yasin. This is a very important slide. You have very well highlighted 2 points. One is dose and another is duration. Dose, always once daily dose. And depending on the age, as already you have mentioned, it might be 1 puff or 2 puff depending on different preparations, but always once daily dose. That point need to be highlighted, and it should go from this platform. And then second important thing is the minimum duration. At least minimum you should give for 3 months. And also, as you have already discussed regarding the use of long-term use, even some literature says that even up to use of 4 to 5 years, they haven't got such adverse reactions for long-term use of this INS. So it's a very important slide. Thank you. And you very, very well, you have elaborated all these things. So next, next question to Dr. Akun. So suppose in case of Arjun, he was responding to therapy initially, but symptomatic again after a few months of therapy. So what might be the causes? Like in case of asthma, we used to get some recurrences. Here also you can get recurrence. So what might be the things in your back of the mind on further evaluation or examining or follow up the child?
One of the most important reason could be poor compliance and adherence, because from the history itself, we can see that there has been an irregular use of the intranasal steroids. Like there has been a lot of studies where even doctors has been patient, and even us have we have a very low compliance. So forget about other patients. So I think one of the most important thing is the compliance. Others can be wrong technique. For example, if you're going to spray over the nasal septum, then that's going to cause much irritation and the child may refuse further use of the nasal spray. Of course, you have to look for the allergens and identify the allergen and try to avoid the allergens as much as possible. For example, in our case here, we can see that the house in Arjun's house is damp and is very poorly ventilated. So this can be certain triggers occurring in this case. Apart from this, of course, comorbid conditions have to be dealt with properly, especially things like chronic otitis media, pharyngitis, or conjunctivitis. So this treatment of comorbid conditions can really reduce the cases of allergic rhinitis. Coming to how we should use the nasal spray. Make sure before you use the nasal spray, you clean and at least clear of the nostrils of the mucus and whatever it is, and use the spray. If it is a new spray, make sure you prime it before you use. And of course, priming also is not to be forgotten if you have not used the nasal spray for more than 14 days. Once you have cleaned off the nostrils, you can put it, shake it, and of course, close one nose and push it onto the other nose and spray it. Make sure you are spraying it behind, backwards, and not onto the nasal septum. And this can be repeated on the other side as well.
Yes, this is a very important slide. All of you need to know that regarding technique, as already Akum has told, because in case of asthma, we used to demonstrate them how to use inhalers by spacers and all. But in case of rhinitis, we used to forget. We used to prescribe and take this puff like that, and then patient used to take that one. But thing is that this proper technique towards the turbinate, how to give this one, need to be demonstrated in each and every visit. And the cleaning of the nose before application of the inhaled nasal steroid is very important, because if you put the INS on top of mucus, so it won't serve the purpose. That's why first clean with saline or saline irrigation, and then you need to apply this preparation. And these 4 pointers, as already Akum has highlighted, is very important in each follow-up visit. You need to stress on these 4 points regarding adherence, techniques, allergen exposure, comorbid conditions, like we used to follow up in case of asthma, like other conditions. So it is very important slide. Thank you, Dr. Akum. Very well explained. So next question to Dr. Pankaj. So Montelukast now, although previously it's coming in a big way, like previously common group of medicines now taken away. Now Montelukast is, what is the current status of Montelukast in management of rhinitis?
So, thank you. So recently, FDA has come up with restricted use of Montelukast as apart from these common side effects like pain, abdomen, fever, and recurrent otitis media, recurrent upper respiratory infection. This Montelukast molecule is associated with severe neuropsychiatric manifestations, especially suicidal tendencies. And and moreover, this Montelukast monotherapy is not superior to intranasal steroid or inhalational corticosteroids. And if we see the efficacy of medicines and recommendations by different guidelines like ARIA and ADEX, so they recommend like for seasonal allergic rhinitis, so any because it will be of shorter duration, so anyone as in like oral antihistamines or leukotriene antagonists will sufficient for the alleviation of the symptoms. And in case of perennial allergic rhinitis, which will be a bit longer, then the oral antihistamines will be better choice than leukotriene receptor antagonist. And regarding combination drug like Montelukast and antihistamines, combination drugs are strictly no in management of allergic rhinitis.
Thank you, Dr. Akum. This message, clear message from this August platform, as already Subramaniam sir has discussed, should be very clear that this Montelukast almost no, and the combination is never at all. So it's a very important slide. So next question to Dr. Tunu. So we are just we'll be finishing within few minutes. So 2 or 3 questions left behind. So Dr. Tunu, so should a combination of oral antihistamines and INS versus INS be used in treatment of rhinitis of Arjun? Will you use combination therapy or monotherapy?
Okay, thank you, sir. Well, for Arjun, we have already diagnosed Arjun as a case of persistent or perennial allergic rhinitis. So in case of Arjun, we would go for intranasal corticosteroid alone, because the current recommendation is to use intranasal corticosteroid alone for perennial allergic rhinitis, and a combination of oral antihistaminic and intranasal corticosteroid, or intranasal corticosteroid alone for seasonal allergic rhinitis. Thank you, sir.
Thank you, Dr. Tunu. So next question to Dr. Rosina. Should a combination of an intranasal antihistamines and inhaled nasal steroid versus inhaled nasal steroids alone be used in treatment of rhinitis of Arjun?
Thank you so much, sir. I think this question was very beautifully answered by a study done by Brosek et al., which was published in October 2017. They did a systematic review, and hence they've used the term seasonal allergic rhinitis and perennial allergic rhinitis to enable the interpretation of the previously published evidence. This is actually a level 2A recommendation, that in patient with seasonal, if a patient has seasonal allergic rhinitis, they can suggest a combination of intranasal corticosteroids with intranasal antihistaminics or intranasal corticosteroids alone. This is actually a conditional recommendation. The logic for the initiation of treatment, they recommended using the intranasal antihistaminics because this acts faster than intranasal corticosteroids alone. As we've already discussed before, the onset of action of intranasal corticosteroids takes about a few hours for the onset and peaks about 2 weeks. So for immediate results, we can give this, consider adding intranasal antihistaminics initially. And then in patient with perennial allergic rhinitis, again, similarly recommend combination of intranasal with intranasal corticosteroids with intranasal antihistaminics. This is a level 2B recommendation. Again, this depends on preferences, local availability, and the cause of the treatment for him. And again, always remember that antihistaminics, inhaled antihistaminics may not be tolerated by children because of the ability. So that compliance will also have to be taken into consideration.
Thank you, Rosina. Very nicely explained. Thank you. So this will be our last question in this session to Dr. Yasin. So after going through this one, the last pillar regarding the management of allergic rhinitis, the last pillar was immunotherapy. So will you recommend allergen immunotherapy for Arjun? And if you, then why?
Okay. When do you actually use allergen immunotherapy? So allergen immunotherapy is usually used when we have got a limited amount of 1 or 2 triggers are there which is causing the disease, and they are unavoidable. We cannot avoid them, such as in our case, cockroaches and house dust mite cannot be avoided in any household. So these are unavoidable. And in a case when after achieving maximum pharmacotherapy also we could not achieve the control, then we will be recommending this allergen immunotherapy. So for our case, Arjun, actually he is the ideal candidate for this one, allergen immunotherapy, but first he has not been treated properly. So I would like to treat Arjun properly with proper pharmacotherapy, with proper dose and proper duration. And even after that, if the child is having persistence of these symptoms, then we will be moving ahead to the immunotherapy. And one thing regarding immunotherapy, that in cases of severe asthma or where the FEV1 is less than 70%, this immunotherapy is contraindicated. So what to do in these cases? In these cases, we achieve control of the asthma first, and then if required, and if required, then we will move ahead to the immunotherapy. And I have already told that sublingual immunotherapy is always preferred over subcutaneous one because of this better safety.
Very well explained regarding the role of immunotherapy. Definitely, it can halt the progression of the disease. It can prevent the further. Suppose Arjun is going for a going to develop asthma also because the spirometry has shown significant bronchodilator reversibility. So in near 2 to 3 months, he might develop some attacks of asthma also. So in order to prevent the further sensitization and further progression of the disease, definitely we can offer parents regarding this modality of treatment. We can't insist, but we can definitely offer them that this such type of modalities are there, which I can't say 100%, but thing is that definitely it might control the disease, or sometimes it might cure the disease also. So, but it's a long duration of therapy. The adherence part is important. You need to continue medication for at least 3 to 5 years. So those things need to be discussed, and if patients are voluntarily willing, then definitely we can offer to them. So. So after discussing all this, so what is our take-home message? So our take-home message here is this: we have discussed the most common chronic respiratory disorder overlooked by pediatrician affecting quality of life. Children with allergic rhinitis usually present with other problems related to rhinitis. The rational diagnosis and history examination like skin prick test is very important. All children with rhinitis must be evaluated for asthma and vice versa. And like in PFT in Arjun, we have seen in our case, there are always 4 pillars of management: education, avoidance, pharmacotherapy, and immunotherapy. Inhaled nasal steroid is the mainstay of treatment, and technique is very important and need to be emphasized in each and every visit. Need for continuation of therapy need to be counseled, and need for immunotherapy in selected cases, as Dr. Yasin has already discussed, which can halt or even prevent the progression of the disease, and it might have some definitive treatment therapy. Like in case of inhaled nasal steroid, we used to have control therapy, but if you offer this one, it might give some definitive treatment. So coming, we came to the conclusion of our discussion. It's a very well, our esteemed panelists, they have explained so nicely regarding this important topic. I'm very happy, and hopefully all have been benefited with this discussion. And before concluding this session, I'd like to give an announcement regarding our first notice pediatric LRCon is going to be organized on 22nd in virtual platform, and I need blessings from all of you and all of the esteemed panelists and other faculties and other attendants. This would always I encourage you to join in this session, because there will be important faculties from national as well as the international platform, and you will clear many more doubts regarding allergies in the upcoming conference. Thank you. Over to Nirmal Jain, sir. Thank you.
Hello. Hello. Am I audible?
Yes, sir.
Yes, sir. Yes.
Yes. Thanks, Nayanmani Deka and his team with panelists. Very nicely explained from the diagnosis to the management, and also very good differentiation between allergic rhinitis and rhinosinusitis with cold. So some questions from my question. My question is one: how long will treat duration of immunotherapy? If you want to treat the treatment of immunotherapy. Anyone want to pick?
I'll answer to the question. Yes, this immunotherapy duration is very important. Yes. The duration is longer one. It's minimum 3 years, even 3 to 5 years sometimes used to be given, and need to be given for a longer time. Adherence issue is very important, and it should be well explained beforehand to the parents regarding the use of immunotherapy, and it has some definitive role. And before starting this one, you need to be discussed with the parents, and it might take 2 to 3, even up to 6 months to start its effects, because by immunotherapy we used to hit the target organs at the basic root by fooling the T cell, basically allergic T cell disease. So we used to hit the target organ. So that's why it's a the T cell is a memory cell, and we used to fool that memory cell, and so it's a very long duration, of course, and that need to be counseled to the parents at the very beginning.
So another question asked by Eslastin spray age limit there is cost.
Yeah, Eslastin because in
Yes, wonderful.
Ideally not so much used. In adults it's used, but after 6 years definitely if like seasonal allergic rhinitis or some other conditions where symptoms are very much prominent, and to control the symptoms we sometimes use azithromycin for 2 to 3 weeks. After that we can continue with inhaled nasal steroids.
So I think there are no many questions. Yes. Any chat? Let's see. Any chat? What is the treatment in infants with AR less than 6 months? Yes, very good question.
It's a very good
Whether
question.
yes, rhinosalvinitis is occur below 6 months or not, or any age limit also the disease. Anyone? I think Nayan.
Yes.
My question is AR occur below 6 months or not, and
Yes.
any treatment.
Thing is that this allergic rhinitis below 6 months is very difficult to diagnose, and there should be minimum period to make the child sensitized to the particular allergen. So at least 1 or 2 years need to be there. But in certain cases with strong family history, if there is strong family history of atopy or disease in the family, in certain cases definitely we can make diagnosis of allergy, although it's not recommend or it's not there in less than 2 years. Very difficult to diagnose, but in certain cases definitely we can. But less than 6 months we cannot use inhaled nasal steroids. But after 6 months, some studies are there from 6 months to 2 years. They are even using mometasone in case of severe allergic rhinitis. They are using definitely.
Sir, can I come in for that question?
Yes, sir. Subramaniam, sir.
Yes, sir.
The best answer is exclusive breastfeeding up to 6 months and not to go for diagnosis.
Okay, sir.
Thank you, sir.
Thank you. Thank you, sir. So I think we can close the session. Partho?
Yeah.
Yes. Yes, sir.
Hello.
Yes.
Yes. So good night.
No, not good
Good
night.
night to everybody. And I think there should be a dinner followed by this session.
Yeah,
Yes, yes.
At home.
Sir, we have ordered in the
Over to Mike.
Swiggy. We have already
Okay.
Partha, parcel karo dinner.
delivered. Anyway, I think we have come to the end of a wonderful session, a wonderful Sunday. We started in the morning with the workshop, and then we started around 200 attendees in the workshop, and also in our webinar from a Northeast region, we had more than 150 participations. So I think it was a wonderful day for us, for the Northeast, to held the first Northeast RESPICON, and along with the team of Respiratory Sector from Northeast RESPICON, I think all of you, all the attendees, all the participants, and of course, my big thanks to the faculties who has taken time, who has given wonderful insight and at least mind-opening lectures to all of our practitioners who will think about the unknown or the uncommon problems that we often miss in our day-to-day practice. I would like to thank the National Chapter President Dr. Bakul Parikh sir, Dr. Vasav sir, Dr. Jagdish Sinappa sir, and Professor Barinder Singh sir, and of course our own Dr. Subramaniam sir for being there and being so helpful and blessing us with so many things in the conference. And of course, ClearNet for giving us the platform for conducting the workshop. And my last words to Dr. Mrityunjay Pal. He has been an eminent support to me, and he has been supporting me. And it is actually, he is the man behind who helps me and who supports me. And at night, he always comes up with beautiful thoughts, and then he will put ideas into my head, and then he makes me work. So my thanks to Dr. Mrityunjay Pal, and of course Dr. Santanu. He's been really encouraging to us, and all senior faculties from the Northeastern region, my teachers, our senior colleagues, everyone who has helped us a lot in conducting this Northeast RESPICON. To Subramaniam sir, I think I saw you listening to the allergic rhinosinusitis part quite intently. So I think what's going on into your mind, you have got the next module ready, and you have the faculties also ready for the next module.
Yeah. You send all their names. They are all in.
They are there for the allergic rhinitis module.
Yeah.
They will be there.
First of young brigade, they have played under 19. Now they are international team.
They have to be in the national team. Yes. Thank you to all young panelists for the wonderful panel discussion.
Thank you.
Yeah, I'd like to congratulate all the young panelists led by Dr. Nayan. Thank you, Akum, Dr. Tunu, and Dr. Pankaj Paeng, and Dr. Roslin from Meghalaya. So it was a great discussion. I would like to thank Dr. Nirmal Jain also chairing the last session so patiently. And I would like to thank all the participants who were there till the last moment. And Dr. Subbu sir, our dear Subbu sir, for
No, I'm your man.
always.
No need to thank me.
Yeah.
I'm insider.
And I would like to request all pediatricians and Northeast to become the chapter of the National IP chapter of respiratory IP chapter and the Northeast chapter also. Thank you. And the man behind the show is Dr. Partha Pratim Bora. Actually, he's been running the show since the last 5 years. I think this is the first online. It is. I think this has been very satisfactory. Yes. Good night to all.
Yeah. Thank you. Thanks a lot.
Yeah.
Thank you, Partha. Thank you, everyone.
Yeah,
thank you.
yeah.
Thanks,
Good night,
Leonid.
good
Thanks.
Thank you.
Good night. Yeah.
Good night.
Good night, Subbu sir. Good night.
Thank you, sir. Thank you, everybody. Good night.
Requesting everyone to log out.
Thank